there are fire exits are there. There are no any supposed to be any fire drills or anything like that. If you see the brochure that you have been given, there is some information leaflet in that which tells you to open the brochure, and then you are supposed to put some stickings on your hand. One you can put at the wrist and one at the index finger. This is part of the workshop that will help you to enjoy a bit rather than just listening the talks. And if you have not picked up some lozenges from the outside, you can pick some and then you can start chewing them. I want you to observe what your positional changes are, how the room surrounding and everything. I put some questionnaires in that, about how is the room temperature, how is the noise part, the lightning part, how many times you are changing your positions, how many times you are swallowing the secretions that you are getting in your mouth. So all these things I want you to keep in mind so that this is a workshop, everyone should be involved actively rather than just listening. So with this brief introduction, I am going to start the session on requesting Dr. Navin Jain sir. He is one of the senior faculty, he is editor of Clarity and Clarity that everyone is aware of. He is going to talk to us on different mechanics of ventilation and basics of ventilation. So I invite Navin Jain sir to start the session.
Have time clear. What time you want to start?
9.
10?
Question answer.
Morning 5 minutes away.
Question answers after each session, 5 minutes.
Thank you. So, good morning, and we'll go through certain practical tips of what we are doing every day to save lives. Some of you are already into doing something which has changed the way neonatology is. Sanjay might agree that when we were pediatric residents, I remember we did not have enough facilities to give high quality respiratory support to most of the sick babies. They used to grunt and die or get suboptimal care. And such a phenomenal change has happened that today you are talking about saving 500 grammars, asphyxiated sick babies, very bad sepsis. One of the central lifeline is respiratory support or ventilation. So, for those who are already practicing, I hope I can still find going back into a little physiology which will help us to look at our decision making a little more critically. And for youngsters, of course, there will be something to learn. These will be some key points we will learn in the next 20 minutes. We'll rekindle the importance of knowing your FiO2 and what does it mean. A little bit about ventilation perfusion and how it helps us to fine tune. We know PEEP is important, but what is it that it is doing for us? And the concept of opening the lung and avoiding over distension. We'll touch upon surfactant, and then we will see that actually ventilation is all about carbon dioxide. It's synonymous with ventilation. So the first quiz is for maybe our first friend there. If you have a sick baby and you want to oxygenate the cell, what will be the most important in order? It will be shock, correction of hemoglobin, or improving ventilation. You can give them a cordless mic, the first friend. Don't get shy. Nobody knows anything, so it's all right. We can only be wrong, but if you don't speak, you won't enjoy. If you have a sick baby in the ICU or on duty, which one has to be corrected to oxygenate the cell better? Which will be more critical to correct shock if it is there, hemoglobin or ventilation? Yeah, we would have thought that we are trying to trick you into this workshop, but it is the least of the importance actually. Just think of it that oxygen is there, it goes through hemoglobin. Agar bus ही नहीं है तो कैसे आओगे? कार नहीं है, aeroplane नहीं है तो how will you reach here? And then finally that aeroplane has to reach there, no? So even though we are discussing ventilation today, when it comes to delivering oxygen to cells, taking the waste products away, the most critical is correction of circulation. Hemoglobin should be optimal, and having those, then our ventilation workshop becomes important. So we think ventilation is oxygenation by default, but it is not. It is about removing carbon dioxide. It is about putting fresh air. We say that this room may depend on ventilation and air conditioning. But if you're sitting in an open mountain in Lonavala, then ventilation is jabardast hota hai udhar. Fresh air coming in. So fresh air is about oxygen and taking carbon dioxide away. Okay. So that is what we call bulk flow ventilation. Most of you are doing high frequency also, and it is a totally different concept. Whenever you start saying ventilation, I would ask you to start using a different word now. Is assisted ventilation. I wonder whether that can be turned a little bit. It's really very bright. It's okay if they don't see me. थोड़ा वो घुमा सकते हैं क्या उसको, थोड़ा सा एंगल, वो बहुत ब्राइट है. तो असिस्टेड वेंटिलेशन बोल, हाँ थैंक यू, दैट्स परफेक्ट. असिस्टेड वेंटिलेशन, वो असिस्टेड वेंटिलेशन ही बोलना है, डोंट से वेंटिलेशन, बिकॉज व्हेन यू आर सेइंग असिस्टेड वेंटिलेशन you want to only help the baby as much as he is asking. That is what you have to remember. What is the first purpose is to optimize gas exchange, get oxygen into him, get carbon dioxide out. The second is the most important, assist, is to reduce the work of breathing of the baby. And the last is to do it without injuring the baby. So you can think of a baby as an elderly person in the family who is a little weak. They want to do it all themselves, otherwise the dignity is hurt. You can't do it everything for them. But you have to assist them a little bit. Agar thoda kar diya, so then they will do it by themselves. So you have to assist the baby without injuring him, and that is what you have to do. These are words which we all know on this side, most of you are practicing in the back there, but still I will emphasize on teaching them all over again. So FiO2 is what is the oxygen content concentration in the inspired air. That is the I. Okay? And then the capital A is what goes into the alveoli, small a is what goes into the artery, and just to show you the cascade inside the air, your proportion of oxygen, the pressure it exerts on the wall, that's your pressure, partial pressure out of the 760 is about 150 is for oxygen. By the time it enters alveoli, your humidity and carbon dioxide replaces part of it, and it is only 100. And in the artery, it is only 75 in newborns because there is a mixture happening inside. And by the time it reaches tissues, what is leaving from the venous side is 35. We know that, no? So capillary is around 35. Any guesses what will be it when it's entering the mitochondria? Where it finally is going to act into the mitochondria and produce energy? Is only 1. So you can see that what you need there is finally only very little. Okay? And why are we talking about this? So this was the first question, and I gave away that what is the PaO2 at tissue level? What is the answer? 1. It's so little. And you're starting with 150 from the atmospheric. So it takes that much to reach there. Now we saw this, and I'm quickly going to run. I'm not going to spend much time on this. Is 0.2, 21%. FiO2 is a fraction, it's 0.2. We conventionally keep saying 20%, but it is 0.2. So 0.2 of atmospheric pressure at sea level, which is Mumbai, Trivandrum, all are at sea level, most of it is about 150. Humidity takes some part of it, and then the carbon dioxide takes away, so you're left with 100 in the alveolus. Now this is one important learning point. If I'm giving room air breathing, which we all very happy, and we tell the families कि अभी आपका baby room air पे है, which means you're doing a good job, and you're putting into the alveolus, capital A is alveolus, you're putting 100, that is normal, you will end up getting 70 in the artery. If you put 0.3 and the baby is healthy, you will end up getting 120 partial pressure inside the artery. And if you put 100% oxygen, it will go to 450. Now this is an important number which we learn when we see the next slide. So if you don't remember this, thumb rule is into 5. Thumb rule. So if you are giving 100% FiO2, your arterial blood gas should be 500. Okay? Now if I have a sick baby and if he is not saturating well, what will I do? I will give more FiO2, more oxygen. So let us say the same situation. Baby came from the labor room, came from the emergency room, he was not saturating, so I gave 30% oxygen. अभी भी saturation कम है, PaO2 is only 70 or lesser. And then I increase the FiO2 to 100%. Saturation is maintained at 93, 94. PaO2 is just about 70. What it should have been at 100? We told in the last one, 100 पे कितना होना चाहिए? 500. कितना मिला? 50. So the efficiency of the system which transfers oxygen from alveolus to your artery has become so sick, which you may not understand, that instead of getting 70, you should have been getting 500. So that much your system is compromised. So while you turn up the FiO2, remember that even small changes in FiO2, which is required to get the saturation in PaO2, is meaning that the alveolar perfusing unit inside the lung is extremely sick. There is a large change in health. So from today onwards, when you report saturation to your team member, to your nurses, to your parents, there is no meaning in talking without FiO2. If I am saying, बच्चे का saturation कितना है? I still remember one of my colleagues and younger colleagues who is now a very senior pediatric intensivist. She had just joined our unit. रात को बेबी छोड़ के चला गया क्योंकि वो सीनियर थे, PPHN बच्चा था. जितनी बार भी फ़ोन करता सर सैचुरेशन 95 है, लेकिन वो दे वर टर्निंग अप द FiO2 टू गेट 95. वो नहीं बताया, मैंने भी नहीं पूछा. When we left it was 30 and 100% पे आधे घंटे बाद क्रैश हो गया बेबी. So you have to now learn, this is the first learning point of the day. Do not speak about saturations or PaO2 without talking what is the FiO2 going to the baby. All the indices which are measuring the health are A minus A, capital A is alveolus, small a is artery. कितना difference है? 100% FiO2 में अगर saturation just 95 तो कितना difference हो गया? 450 minus 70. It should have been 450 and it is only 70. Huge difference. Gradient. I am putting everything here but nothing is going there. So the whole unit is very sick, the alveolar unit is permanent. Or small a by capital A is the same thing. We give surfactant at what number? Small a by capital A. Our DM trainees were there. बता दो कुछ भी ऐसे. कितना point? 0.22. हाँ, तो 0.22, 0.3. मतलब ये कि 1/3 भी नहीं आ रहा है आर्टरी में जो आप alveolus में डाल रहे हो. That is importance. ठीक है? So now comes a quiz. So सर आपके लिए पीछे. तो आपको बताना है कि बच्चा कैसा है. हाउ इज द फिजियोलॉजिकल स्टेटस ऑफ दिस बेबी. बेबी सैचुरेशन इज 96, PaO2 ब्लड गैस किया तो 75 है. यू आर हैप्पी और नॉट हैप्पी? नहीं सर, मैं वो एक्चुअली वर्कशॉप में इन्होंने मुझे इतना दूर लगा दिया, नहीं तो मैं पास बैठता हूँ, हथौड़ी भी रखता हूँ हाथ में. एक बार और सोचिए क्या पूछना है अपने एक एक्स्ट्रा वन. FiO2. ये 100% FiO2 पे तो आप खुश रहेंगे क्या? What would be the expected PaO2 if it was 100%? 500. और क्या मिल रहा है? So I think I put the first point in there. Now we'll pet Jaisa. Thank you. So doesn't matter if learning is very easy, unlearning is very difficult. So these young people, 4 people there will learn very fast. हम लोगों को मुश्किल रहेगा जो इधर बैठे हैं, जो पहले से सीख गए सब कुछ. तो first lesson of today is, from today we will not speak about saturation or PaO2 without talking about FiO2, and we'll keep this Guru Mantra in mind कि whatever FiO2 I'm putting, 5 times I would have ended up getting the PaO2. ठीक है? Similarly, there is oxygen saturation index nowadays. You don't have to do blood gases all the time, but there also you see in the equation you are having FiO2 and SpO2 both. बिना FiO2 के कुछ नहीं है. कितना दिया आपने to get the things there. Okay? Now coming to the second learning point. This is the alveoli. There is a alveolar membrane, there is a thin film of water, and then there are red cells which are going to take everything away. They are the ones which carry. Who carries oxygen? The plasma or the hemoglobin? The hemoglobin. So it is all that matters. No, that's why we said hemoglobin is important. From today onwards, when you start ventilating a baby, what to do when I'm in trouble? Imagine of this figure. This is all that lung is about. There is an alveolus and there is a capillary, and the gas exchange takes place between this. This is normal. You can see a good shaped alveolus and a well distended capillary. In this you can see the alveolus has become very small. This is the typical type of diseases we are treating: atelectasis, pneumonia, RDS, whatever you call it. And here, because the alveolus is small, it is not easy to expand, Therefore, baby has to make more efforts. He will have retractions, he will grunt to try and keep it open, he will have faster rate because tidal volume is low. He will have on the X-ray, remember X-rays come only in black and white, not in grey. So either there is white, that means no air, or black, there is air. So the X-ray will have areas of no air, they will be white. And whatever area is bronchus, that will not go away. So you will have white everywhere, atelectasis and bronchus. So bronchogram will, if you look at bronchograms, you will not get fooled by quality of X-rays. ये जो शादी से पहले वो पेंट लगाते हैं ना वो करने के लिए, तो X-rays also nowadays you can make them fair, you can make them dark, post you can do. So don't get fooled by that. If you see a bronchogram inside white, it is confirming that outside doesn't have air, bronchus has air. Okay, and you will have low oxygenation, CO2 can't be thrown out. We'll learn CO2 quickly in next few minutes, and this will be a typical telling that I want to expand the alveoli. Whereas if you have a big alveoli, normal alveoli, whereas the pulmonary capillary is very thin, not getting a flow, then what you will have no difficulty in distress actually. Baby doesn't have to make more effort to breathe, no retractions, no grunt, no tachypnea, his tidal volume is normal, his CO2 will be normal, but his oxygenation will be very poor. And there are only two compartments. You have to ask yourself, is it the alveolus or is it the capillary? So now comes the question to the third person from here. You can pass the mic and be happy कि मेरे से छूट गया mic. So पहले वाले picture में क्या करेंगे? Small alveolus, normal capillary. How will you correct this baby's problem? He is not oxygenating and he is having difficulty. He has a small alveolus and normal capillary. I will go back and show you what it was. He was having retractions, grunting, and lung is atelectatic. You will want to, I'll give you MCQ choices. वो ज़्यादा अच्छा होता है life में. You will want to put more pressure and open the alveoli, or you will give more nitric oxide and open the capillary.
First circulatory status is looking good, sir.
Huh.
Problem is in alveoli. We have to increase the P.
Correct. Fantastic. So that is the one where you will increase P. What about the second picture? Normal alveoli.
The problem is in circulation.
Yes.
So we have to give the fluid or vasodilate filters.
So very good. This is what we have to remember when you get to the bedside. How many of our years, 25th year in our ventilation, we still make the same mistakes sometimes. We chase numbers, we get worried when we, but you have to ask first question is, which side am I going? Am I looking at a baby who has, here you optimize ventilation and you open the lung, you are right, and here you optimize the lung perfusion, you may treat shock or you may improve the pulmonary circulation. Okay? So the second lesson we learned, what was the first lesson we learned? Without FiO2, we will not think of what is the PaO2 saturation. Second lesson is, to get oxygenation and carbon dioxide right, you need both. Not only ventilator. You need to open the alveoli and you need the right perfusion of the capillary. Then only this process will happen. And you have to just ask yourself, am I dealing with retractions? Am I dealing with a white lung? White lung means? Black lung means? There is air. So you don't have to push more air. Don't put him on more high frequency, higher PEEP, just because saturation ठीक करना है. Black lung है तो पहले से ही सब वहाँ ठीक है. Then you work on the perfusion of the lung. Okay? Now you think of this balloon. All of you have blown birthday balloons? पहले क्या होता है? Balloon हिलता ही नहीं है. सिर्फ parotid में दर्द होता है ना? And then your child also wants to do it. You say रुक जा. I'll blow a little bit and then I'll give you and you blow the rest. And then if he by mistake leaves it, then you try to hold it halfway through, because अगर halfway से छूट गया तो parotid फिर से फट गया. You don't want parotid pain again. So what are you doing? Initially what you did, this is the pressure volume you learn, for those who are not familiar you learn in the afternoon, but I can see most of you know it. So pressure went from 0 to 2. What happened to volume? Nothing changed. Compliance is 0. 2 to 4. No change. 4 के बाद क्या हो गया? Just like the balloon, thak, it is going up. And here you increase the pressure only by 2, from 4 to 6, but the lung volume jacked up. This is called the opening pressure point or the inflection, whatever name you may give it. Okay, if you start working from here, if you take the baby till this point, then baby will say, bas, ab main karunga. I can do it. So if you don't take to this point, baby has to do a lot of work to get till here. So our job is to bring the baby to PEEP, open the lung, and then he is an efficient system. He can do it. Nature made him for that. Okay, so we had to bring him to that point. So don't let go the balloon deflate. Agar deflate ho gaya, goes back to zero, then the whole work starts all over again. So when you ventilate, when you support, if you bring the baby only to PEEP, from here job is very easy. Baby can do all the work. So one of the jobs we have to do is to not allow the alveoli to collapse back to the 0 point in any sickness that we have. So this is the best place where you work. Okay. So what is more important, volume of gases in the lung or pressure? You want oxygen or you want pressure? You want oxygen gases inside and carbon dioxide outside, that is volumes, or you want pressure on the walls? Which is more important for baby? That's what we have been taught all the while. कहाँ करोगे प्रेशर का? आपको ऑक्सीजन चाहिए कि प्रेशर चाहिए? Why pressure became famous? बीपी लेते हैं लेकिन टिश्यू परफ्यूजन नहीं करते हैं. सेल को तो टिश्यू परफ्यूजन चाहिए बिकॉज वी डोंट हैव ए कैपिलरी रिफिलोमीटर, वी आर हैविंग बीपी मीटर, तो इसलिए बीपी कर रहे हैं सब. उसी तरह से प्रेशर मेजर करना बहुत ईजी है, तो वी बीन ओनली रनिंग आफ्टर प्रेशर. बट वॉट यू नीड इज fresh gases going in, volume, and gases coming out. So you need volume inside there. You need the lung to be well inflated. Okay. So this is the next point. Even though we call it PEEP, it is continuous distending pressure. The word is continuous. It is there throughout the cycle. It keeps the alveoli distended. Agar wo balloon deflate nahi hue, then from there work is very easy. Okay, so the PEEP or the CDP or this one determines the work of breathing of the baby. If you are having right distension all throughout, then the baby will say, my job is very easy. I will not get tired, I will not get tachycardia, I will not spend glucose, I will not get lactate in my system. It's very easy for the baby to go. ठीक है? Now, ये सुन के क्या करते हैं मेरे residents? More is merry. 5 की जगह 6, 6 की जगह 7. मैं बता देता हूँ कि मशीन में 4 भी होता है, वो लगाते ही नहीं है. नॉर्मल पोस्ट हर्नियोटमी वाले को भी 5 लगाते हैं. मोर पीप से क्या होगा? मोर डिस्टेंशन होगा, है ना? यू विल गेट. टुडे इज व्हाट डे? योगा डे. somebody said correctly. Yeah, so we'll do some yoga now and understand what it is. I am going to tell the story which Dr. Simbruna, who was the chairperson of Hippocrates, taught us. So all of you do some yoga with me. अभी ये सब तो गुरु हैं, योगा भी गुरु हैं, आशीष भाई. So he is exempted from this because he will. All of you take a deep breath and hold. If you feel you will die, you can leave. मतलब पकड़ के नहीं रखना है. अब इसके ऊपर एक और ब्रेथ लो. हो सकता है? नहीं, you can release. ठीक है? For those who didn't listen, consent release कर दो, नहीं तो गड़बड़ जाएगा. तो if you ventilate the baby like that, if you inflate him this much, then उसके ऊपर कैसे ventilation होगा? How will you push more fresh gases inside and take outside? So over distension can cause hypoxia, it can cause hypercarbia, and you can foolishly keep chasing those numbers and giving more and more into the baby. So please remember that over distension is something we have to avoid. Suppose you're looking at this baby, we saw the same story earlier. So वहाँ पे प्रेशर ठीक ठाक चल रहा था, but somebody said थोड़ा सा और दे देते हैं. We gave more. So what happens? Pressure went up, but did the volume go up much? No. The lung said, I can't do it, just like you already just some time back. More. Nothing is going up. This is what is called in graphics which you learn in the afternoon as beaking. वो bird की beak की तरह आ गया. I like to call it as breaking. वहाँ से सब कुछ टूटना शुरू हो जाता है, alveoli, capillary. तो वो उस level पे नहीं जाना है. So if you feel that nothing is improving, then you may back off. My Guruji Narang sir used to tell the best way to know whether you're doing ventilation correctly is reduce by PIP by 2 and see. If you're still in the same place, then why you want to give more PIP? Then you remove a little less. No? So this will help you to understand that over distension should not happen. For those who are learning fancy things already, when you talk about C20 by C in Draeger's, it is the last 20 part compliance which should not be less than the main compliance. That means the last part you are overdoing ventilation. You are not doing. So our first lesson was respect, FI2. Second was we need ventilation and perfusion. Third क्या था? भूल गए ना? Continuous distending pressure to reduce the work of the baby. Fourth is don't over distend. So if you over distend, then baby will not be able to get right oxygenation and carbon dioxide into him. Okay. Now we come to learning what is surface tension. You see this particle being attracted on all sides. That is why it's staying there, equal. But what happens to a particle which is on the surface of a water surface? Talab ke upar, samundar ke upar. They are only pulled inwards by water. They are not pulled outside. So in one direction. So that creates a force which is called as surface tension. Assay. Okay. So it is having a force inward into the ocean, into the lake, into the alveoli. It is pulling inwards. And that's why it causes the alveoli to collapse. What are you doing when you're doing surfactant is that surfactant is a oil droplet. Divide and rule. So you put oil droplet between the water droplets. So you're breaking that surface tension. समझ आ गया ना? So if you put oil droplets between the water droplets, the surface tension will break. And as the alveolus comes closer, more and more oil droplets are available between each water droplet. So actually the breaking becomes more. And what we don't know sometimes is when the alveolus becomes bigger, these oil droplets between the water become less. So then the surface force and surface tension ka reverse ho jata hai equation. That is why actually surfactant prevents even over distension of alveoli, not only atelectasis. It is a dual action. So when the concentration of oil droplets between the water changes, it will either prevent atelectasis or prevent over distension. So this is all surfactant is about. You can do that with CDP also. You can do both together also. So put some oil droplets between the water and also give distending pressure. So quiz. Surfactant prevents over distension of alveoli. True or false? True. It has both roles. It not only prevents atelectasis, it does this also. So our fifth lesson we learned today is for oxygenation, the most important guy is perfusion. Next important is hemoglobin, the molecule, the carrier. And then if these both are good, then you have to optimize ventilation. Make sure you know that you are not giving too much FiO2. In our ventilators, we go back and see, you will have green color till 30% on the knob of FiO2. After that is red color, trying to tell you that you are working on a danger zone now. You are not doing, something's wrong. Get back your knob into green. नहीं तो ventilation ठीक नहीं कर रहे हैं, वो बच्चा ठीक नहीं है. So it has to be in that 20 to 30% zone. You need continuous distending pressure to reduce work, because we started with assisted ventilation. We want to improve oxygenation, carbon dioxide, reduce the work of baby by taking him to that part of the balloon from where everyone can, बच्चा भी कर सकता है, baby भी कर सकता है. And then we don't want to prevent injury. Okay, you can warn me when I have 5 minutes left, because we have to carry on with the workshop. So now coming to carbon dioxide story of ventilation. Maybe in 1950s there was a polio epidemic. Everyone was not breathing and dying, and great anesthetists, intensivists all thought it is acidosis that they were dying. They were giving bicarb to treat them. Till an anesthetist said कि ऐसा नहीं है, carbon dioxide आ रहा है, वो acidosis कर रहा है, so we have to ventilate to remove carbon dioxide. People didn't believe him, but because they were dying, they just tried it out. And when they ventilated the patient, the carbon dioxide went away, acidosis चला गया, patient ठीक हो गया. Next day, all medical students were given leave and all were bagging polio patients. And within 1 year, we had ventilators. Okay, so please remember that if you are having acidosis, it may not be only bicarb that is a correction. You may have to just probably sometimes get a CO2 after the person. So remember, CO2 is ventilation. And how do we know that? This is from Ganong. Some of you still remember Ganong, no? We went back those days. So you can see that this is PaO2, this one. 20, 40, 60, 80, 100. And this is your ventilation. How much are you breathing? So you can see that when the PaO2 fell from 140 to 60, there is no change in ventilation. That means the animal did not start breathing deeper even if you brought down the PaO2 from 140 to 60. That means oxygen is not the driving force for how deep you breathe, how much ventilation you do. Whereas the same animal, they increased the CO2 to 43, from 40 to 43 and then 48. Just by that much change, you see how much increase in ventilation has started happening. So the determinant of ventilation, the purpose of ventilation is to control CO2, and it is controlled here. CO2 अगर 40 से 45 हो गया, you'll start breathing like that. ऑक्सीजन 140 से 40 भी हो गए तब भी नहीं चेंज होगा, unless it goes so low that you start gasping. So the purpose of ventilation is to fine tune CO2, and CO2 drives what is ventilation, and that is what I meant when I said this is CO2 is ventilation, ventilation is CO2. Okay, so now coming back to, so baby's breathing effort responds to oxygen or carbon dioxide. Quiz to you back there. How much the baby breathes deeply responds to oxygen or carbon dioxide? Carbon dioxide, that's right. Thank you, please. So next 5 minutes we'll finish off carbon dioxide also. You can see this is our same unit, we come back to alveolar capillary unit, and you can see that carbon dioxide can diffuse across this unit effortlessly. Somewhere during the line we'll discuss about some situations where we are doing neonatology today with 500-400 grammars. What I'm telling now will not hold good. Otherwise, even if out of 120 alveoli left, CO2 will go out from capillary to artery, from the into the alveoli. कोई नहीं रोक सकता उसको. ऑक्सीजन को रोक सकते हो, कार्बन डाइऑक्साइड को नहीं रोक सकते. It will just go out, and that is why, like you have P capital AO2 is alveolus, P small AO2 is artery, but PCO2 बोलते हैं. Nobody talks about PA capital CO2 and P, क्योंकि दोनों सेम है. Values are always the same. It can just, कोई दीवार ही नहीं है उसके लिए, just goes across. Okay. So what is the limiting factor for CO2? कब बढ़ेगा? जब वो alveolus से बाहर नहीं जा सकता. That is the only real clinical situation. So if you are having high CO2, it is not able to leave the alveolus. Okay. Now let us see, for example, obstruction of airway. So quiz to the next person. What all conditions can you think in our neonatal or pediatric practice when CO2 is blocked inside the alveoli, or this is obstruction to airway?
Meconium.
Okay, great. Meconium, fantastic. Then
aspiration,
but don't tell all the answers, then they will have nothing more to live. So एक दो और बता दो. वेंटिलेटर का बच्चा तो क्या होगा?
Ventilator associated pneumonia.
Great. Then अगर वो blocked है वो वाला?
Maybe it is blocked.
Okay, great. So you can have block there like I showed you here. Then CO2 buildup. So CO2 buildup, first you think कि airway गड़बड़ है. First airway अगर CO2 buildup हो रहा है. Increase resistance कब हो सकता है? पास कर दो माइक उनको. कब resistance हो सकता है? आस्थमा में होता है, रेजिस्टेंस होता है. सेम मेकोनियम सेटिंग यू कैन हैव रेजिस्टेंस. ट्यूब थोड़ा सा ब्लॉक हो गया, रेजिस्टेंस बढ़ जाता है. ठीक है. सो रेजिस्टेंस ब्लॉक के लिए ट्यूब ब्लॉक, सेक्रेशंस, क्रॉनिक लंग डिसीज काइंड ऑफ सिचुएशन वेयर एयरवे इज गेटिंग कॉम्प्रोमाइज्ड. ठीक है. नॉन वेंटिलेटिंग एयरवेज, when there is an increase of non ventilating airway, that is there is some part of it which does not do this gas exchange. वो क्विज दे दो, किसी को भी दे दो. कहाँ पे?
Collapse.
Excellent, very good. Something outside the baby like this, where gas वहाँ से exchange नहीं हो सकता. Long tube. Okay, there is no gas exchange but gases are flowing through it. Capnograph लगा दिया, you are adding dead space. Large flow sensor लगा दिया. All these things will act as non-ventilating areas. Besides what you correctly said is atelectasis. Small atelectatic alveoli also can cause CO2 to stay, because अगर वो small है so their capacity of pushing out is only so much. So they can't push out carbon dioxide. So they will stay there. So small atelectatic, everyone knows. What are the ones? RDS, pneumonia. So there you have to expand alveoli. Okay? So that can be CO2 going back. Over distended alveoli. ये वाला picture दिमाग में रखने का है. Because we only remember all of this. It is so common. The commonest cause of death in PPH and in ICU is overzealous ventilation. We tend to go more pressure, more HFO, more surfactant, and the alveoli become like this. And you get hypoxia and CO2 and you give more, and then the perfusion to lung goes poorer. Death happens. So we remember this alveoli should not get over distended. Very few alveoli. कहाँ होता है? No alveoli. एक हमने कहा कुछ नंबर तक कम हो जाएगा तो nothing can be stopping the alveoli. They will still go out. So yeah, one of the young ladies there. जो भी अपने को यंग समझता है, ब्यूटीफुल एंड यंग. कब होता है कि एल्वेओली इतने कम हो गए कि है ही नहीं एल्वेओली, CO2 रुक गया. Although CO2 should not stop the number going down because it's so fast to diffuse. When can the number of alveoli be so less? Yes, pulmonary hypoplasia. And one pulmonary hypoplasia, these three people are seeing every day and still saving them, is pulmonary insufficiency of prematurity, 23 weeker. It's as good as pulmonary hypoplasia. Why I am saying this is, I don't know where our world is going. We say एक surfactant लग में डाल के 23 वीकर को 40 वीकर बना देंगे, कैसे हो जाएगा? 3 surfactant डाल के हो जाएगा, कैसे हो जाएगा? नाइट्रिक पहले दिन लगा देंगे तो बढ़ जाएगा, कैसे हो जाएगा? They don't have alveoli. They have to spend 16 weeks in a suboptimal world to reach 40 weeks. Their alveolar number has become so critically low, उनका कार्बन डाइऑक्साइड 100 आएगा. अगर उसको तुम 30 करना चाहते हो तो you will have to फोड़ने पड़ेंगे सारे alveoli. Not possible. There are no alveoli. Other than that kind of situation, you're dealing with 32-33 weeker, number of alveoli is sufficient to ventilate. But when you go down to that kind of critical low number, CO2 will not go out. Ventilation doesn't happen. Okay? So our aim of ventilation is to get optimal lung volume, recruit all the alveoli that God has given you at that gestation. Get them all open. Okay? Stop treating respiratory distress with only oxygen in mind. Ventilation है कि नहीं ठीक. Ventilation is fresh gases going in. Are the alveoli moving well or not? So this is the last 2 slides. Very nice looking graphic where you can see this pump. Ashish sir will teach us about this in the next presentation. It is pushing and gases are going in, getting humidified, going to the patient, coming outside from there. And you can see a valve up there which allows the gases to go out or not. So what is driving this, all this process is gases are being pushed with flow inside. Gases are flowing inside. So these are flow driven ventilators. And what decides when should I stop? So this is, if there is a high flow, it will fill up the circuit quickly like this. Some machines also call it inspiratorized time. Low flow means it will fill slowly. You got a refurbished ventilator, ज़्यादा गैस लगाना पड़ेगा. जितना पैसा वेंटिलेटर में बचा है उतना ऑक्सीजन में लग जाएगा हॉस्पिटल का. We don't realize that. ठीक है? Because everything will be leaking inside. Buy a brand new ventilator 4 लीटर में भी वो चलता रहेगा. दूसरा 15 लीटर नहीं लगाएंगे तो आप सेट करेंगे कुछ और मिलेगा कम. So always go back and see measured because enough flow is not happening inside. This is the curve we will get. So the time spent in that ventilating plateau will be very small. यहाँ पे यहीं से शुरू हो गया optimal oxygenation till we stop. But in the other one, only after this point optimal alveolar opening is happening. So the flow can determine. But it's not critical if you have a good machine. Then don't look at the flow. I just wanted to show pressure limit. We all are setting pressure limits in ventilators. And see, इससे ऊपर pressure नहीं जाना है. And it is not important, but that is the cheapest device that a company can attach to a machine. Pressure measure करना आसान है, सस्ता है. लेकिन बच्चे को pressure नहीं चाहिए, बच्चे को flow and volume चाहिए. But till now we are not able to do it accurately. So this is pressure limit. How much of flow you set, how much of time is there, इससे ऊपर pressure नहीं जाएगा. Who measures the pressure? Is a manometer. Okay? So you can see there is a manometer here attached near the ET tube part. There is a pressure tubing and that is connected to a limit system. So your ventilators are, yeah, I'm finished. Pressure limit. So this is there, and then what determines this green to red change? कब inspiration होगा, कब expiration होगा? Basic ventilation में it is time. You dial 0.4, 0.6, 0.4, 0.6. So these are called time limit ventilators. So this is what your ventilators are conventionally. They are driven by flow, they are driven by pressure, and they are limited by pressure, and they are cycled by time. Okay? So with that I stop here. Quickly we'll recap what we learned in 1 minute. So we can just pass on the mic. Anything that you learned together. First lesson क्या सीखा था हमने? Without FiO2, don't tell what is the saturation, what is the... After this hall also should be like this when you go back to your ward also. So if they ask you what is the saturation, what is the PO2, tell itne FiO2 pe hai. Otherwise there is no meaning. What is the second one we learned? You need both ventilation and perfusion. You've done everything in the alveoli, but if the capillary is not there, nothing can happen. So if you're not having retractions, you're not having grunting, you are not having atelectasis on the X-ray, you are not having high CO2, then focus on circulation. Okay? Third, what did we learn? Continuous distending pressure. It is to keep the alveoli all the time. क्या फायदा है उसका? What is the benefit? Work of breathing. Small baby also can blow balloon. शुरू से नहीं कर पाएगा. If you open till that point, then baby also can do. Very little work of breathing. Okay? Then fourth one was?
Don't over distend.
Don't over distend. Because you remember Simbrunner, you remember Yoga Day, you can't breathe over the top of what you have already taken. So if you push too hard, then from there baby can't do. What is the fifth one we learned? Surfactant. So क्या करता है surfactant? It puts oil between water, so that surface attraction becomes less. Okay, and then lastly we learned that CO2 अगर बढ़ रहा है तो only one problem is there. From the alveoli, CO2 can't go out. So think whether it is block in the airway, whether there is a pneumothorax. तो chest move कर रहा है लेकिन alveoli move नहीं कर रही. Too little alveoli. That is all. Thank you for your attention. Ashish, complete. If there are any questions, you can ask. Anything you want to discuss and ask, please do so.
CO2 will also decide the cerebral blood flow.
Yes. So CO2 is what determines very sensitively. If CO2 goes up, actually, if you look at a very nice graph by our Lakshmi, he has drawn in his article that in the fetus also they are reciprocally wired, your pulmonary and your cerebral. If CO2 goes up, cerebral will open, pulmonary will close. If CO2 comes down, pulmonary will open. तो इसलिए करेक्ट पे रहना, नहीं तो एक बंद हो जाएगा दूसरा चलेगा. PO2 बढ़ जाएगा, दिमाग में कुछ नहीं जाएगा. ठीक है, थैंक यू सो मच.
Thank you, sir, for such a elusive presentation on the basics of ventilation. I saw most of you have not opened the brochures yet, so I wanted to demonstrate it. All of you are sticking with you. Open that. It is not for to be kept. We have done some efforts to cut into that and not the wastage of dynamos that we have got too much. So one at the risk, you want me to demonstrate? I also got something. So one foot at the wrist and the second one at the index finger, and need to be good tightly so that how the pulse ox is attached, very tight so that we get a good tracing and good readings, isn't it? And keep a track of how many times you are changing the positions, how many times you are swelling the secretions. So that will help you to guide what you are doing to the babies when you are doing ventilation to these babies. Everyone has got the bands on the hand. It has to be there. We don't pulse ox is attached round the clock, not until we attach and then remove it, isn't it? So don't remove it till we suggest you to remove. that will get an idea whether it is disturbing or not disturbing. So we'll be having the inauguration session. So we are just waiting for a few minutes. Hello.
नहीं होगा सर. नॉर्मल रहते हैं। इधर बात कर रहा था, उधर कोई बात करते सेकेंड पे। तो मेरा फोटोग्राफर ऊपर आया है, उसको इधर रखो, आप मुझे फ़ोटो मेल कर दीजिए। हमारा फोटोग्राफर सब हम जा रहे हैं, उसको लेके आए हैं, हमारे साथ ही है। उसको अगर अंदर आना है तो फिर अलग से पेपर वगैरह बनाना पड़ेगा। आप जो फोटो निकालेंगे वही हमको मेल कर दीजिए, मैं उसको उधर ही बिठाता हूँ। चलेगा? हाँ, मिल जाएगा। आशीष भाई,
I think we'll keep utilizing till the inauguration starts. Ashish will ask you some tricks.
Yeah.
Yeah. So we are going to talk about modes of ventilation. And before I start, just want to have a basic idea that which mode that you are using in your day-to-day practice. Is it same for all the babies? Does it differ disease-wise? Or your own choice or own funda to decide the mode? Anyone? Have mic? See, नवीन ने तो माइक घुमाना सिखाई है, तो वो तो चलता ही रहेगा.
Sir, mostly we see the gestational age. It's not a particular funda.
Okay. So that is by choice.
There is by choice, there is by disease,
Okay.
there is by prematurity, term of gestation, and also the baby's response.
Okay.
Whether it's responding to a particular mode of ventilation that we put the baby on or not.
Sir, most of the premature babies we go with SIMV volume control mode, and if not maintaining on the volume control on the higher settings also, then we consider pressure control, SIMV pressure control in spontaneously breathing child. If the child is like under diaphragmatic hernia, in that case we prefer HO to start with.
So you go disease wise, that
Yes.
depending on the, but your fixed set of mind that you got SIMV pressure control.
Volume control.
Volume control.
Yes.
Great. Any other? Yeah.
Usually we use the pressure support ventilation, sir,
Yeah.
because our team is familiar with that pressure support. Second thing, most of the tube we are using the uncuffed tube, sir. There is a problem of leakage.
Yeah.
So pressure support is preferable rather than manual control.
Okay. Anyone? So someone is using disease wise and own choice. Someone is using volume. Someone is preferring pressure. Anything else?
First of all, we have to see whether we want to use invasive ventilation or non-invasive ventilation. Depends on the severity of the illness in the baby.
Yeah.
And we have to mainly look at the patient's own efforts, whether the patient requires assist or not. If the patients are not, patient is suppose comatose, not breathing, then we can go for the IMA also.
Okay.
But if the patient is having spontaneous breaths, then we have to assess the work of breathing. And as per the work of breathing, we have to provide the level of support and we have to choose the mode of the ventilator.
Okay. So again, it is depending on the baby and again some personal experiences and how the staff is acquainted with which mode. It goes like that. Any other choice on this side? Anyway, in the nutshell, that we do not have one particular mode with which you are happy with or your unit is happy with. Like you are coming in the morning round, you say that this patient should be an SIVA volume control, why you put on an access control? And you have reason to discuss on that, or you have reason to shout on that why the mode was changed, isn't it? So that means we need to, first of all, we need to understand that do we need to have different modes or not? Believe me, if you need the basic, if you understand the basics of each mode, probably one can ventilate with any baby with simple one mode. That we'll discuss later. But coming to the basics, what is equation of minute ventilation? What is? Okay. Now, in adult population or pediatric population, physiological rate is lesser than newborn rate. Why? Newborn is breathing at 40 to 60 while water. So healthy lung. Absolutely. Basically, the compliance of the chest wall itself, the strength of the muscle to keep the lung open or keep the chest open is not there. So desired tidal volume, though it's we say 3 to 5 ml per kg is the tidal volume that will adjust on the ventilator. But at times you find maybe 2 ml per kg and otherwise fine. Okay. So per kg means size of the baby doesn't matter. It is a volume that matters. You take 2, 4, 6, pick any number. But any healthy newborn baby will be breathing at 40 to 60 simply because to maintain that minute ventilation, they need to keep the rate high. That is one thing. What is happening with the time constant? What is equation of time constant? Anyone on this side? Equation of time constant. Ready? Equation of time constant.
Compliance into resistance.
Great. What is compliance?
Volume change but the pressure change. Delta V by delta V.
Per change in the volume, per change in the pressure, delta V by delta V. You are absolutely right. So what happens in higher disease? Poor compliance. Because of that, what happens? If you talk about what is the effect of poor compliance on time constant?
It will decrease.
Absolutely. Time constant will decrease because time constant is equal to C into R. Okay. What happens into meconium aspiration?
Resistance will be increased.
So time constant will be increased. Okay. So in both situations, in both the diseases, time constant is decreasing. Now apply this onto ventilator. What does time constant mean? What is time constant basically? What does it mean?
Amount of time required to completely expire or inspire the air completely out of the lung. Actually, one time constant is equal to 63% of the air to take inside.
Fantastic. You are nearly there. Time constant is equilibration of the pressure between proximal and distal alveoli. The time required to equilibrate pressure between proximal and distal alveoli is one time constant. So when you say one time constant, that means 63% of equalization is occurred. So let's say 20 PIP I want to reach. So from here to here, 20 PIP, 60% of that is somewhere about 12. So in one time constant, 12 is reached, or 12 PIP has happened. Two time constant means 85%, isn't it? So now 20 minus 12, 8 is remaining. 85% of 8, somewhere about 5, 6. So two time constant means 20 are 12 plus 5, 70. 3 बच गए. 3 time constant में 96% equilibrium. So 96% of 3, almost 2 or 3. तो 17 से 3 होगा 20. That is why we need 3 time constant to equilibrate pressure between proximal and distal. or your I time and normal physiological, one time constant is 0.15 second. So 3 time constant is 0.45 second. That is your normal I time in good olden days. Now we have started seeing smaller and smaller babies where we know that lungs are stiff, the compliance is poor, and hence the time constant is also less. If time constant less, I time will go less. And that is why in a cases where the lungs are stiff, the time constant will come down to 0.3, 0.4 depending on the consultant's preference. But bigger the baby, you are already with longer I times. Smaller the baby, you are already smaller 0.35 or 0.3 or 0.4 I time, which is physiological for that particular baby, for that particular disease. Mostly stiff lung or HMDs. Isn't it? That is one funda about time constant. Talking about resistance. Naveen nicely and very lucidly explained about the resistance. What is implication of that particular thing in your day-to-day practice? Longer the tube, what will the resistance? More the resistance, because the flow has to travel long, has to face a lot of resistance. How would you imply that in your practice? Cut down the endotracheal tube. Mostly you are cutting at 3 cm from the lips. You at times you see that the circuit is sitting here, baby is like this, and to make the things comfortable for the nurses, the tube is not cut. And the explanation is that because the circuit is so heavy, we need to rest next to the baby. So you will find baby sipping through something like some straw. The straw is very long, and that is enough to increase work of breathing. On gas you keep on getting, tube लंबी हुई तो क्या gas में क्या आएगा? Very good, excellent. You will find high CO2 क्योंकि ventilation नहीं हो रहा है. So the first implication of R is cut down the tube. And second thing would be cut down the dead spaces, which includes unnecessary length of your breathing circuits. At times, you know, the circuit has gone wrong, number circuit has come to you. Wrong number in the sense the purchase department or someone has sent you the wrong number circuit, not applicable for the particular population. And unknowingly you start feeding, ventilating this baby with that circuit and getting wrong the figures, or baby not getting ventilated. So remove the dead spaces. You nicely said the flow meter has to be come out. If you are finding unexplained CO2 rise, apart from block of the tube, apart from the secretions, length of the tube and dead spaces matters most. Now coming back to I time or time constant in a given case of meconium. We say that time constant is equal to C into R. And you rightly said that in meconium resistance increases. And when resistance increases, the time constant will go down. Isn't it? How will you apply this in a given case of meconium aspiration syndrome? What happens there? Which time constant you want to keep low? You need to give enough time for the gas to come out. Resistance is increased. Time constant will increase. If it is increased, your I time will be long. But if you keep too much of the I time, for example, you keep the rate of 40. Your I time is 0.4, baby's I time is, you set it as 0.4. What will be E time? 0.6. And what will be I ratio? 1:1.5. Meconiums at times are not happy with that. Number one, they are badly tachypneic. And why they are tachypneic? Because there is a lung disease, there is oxygen problem, tidal volume is not enough. To maintain minute ventilation, RR goes up. You intubate, open up the lung, improve the tidal volume, RR spontaneously starts coming down. That is what we see. The baby that you receive will come with 80 to 90 rate. The moment you put on ventilator without sedation or without analgesia or without, somehow suddenly starts getting at 60 because you open up the lung. but this baby should have adequate E time. Your time constant, E expiratory time constant has to be long enough so that the gas can come out, which is trapped because of the ball valve mechanism, because of the meconium stuck in the airway. वहाँ से CO2 बाहर नहीं निकल रहा था. So HMDs, make sure their I time is small because its time inspiratory time constant is small. Meconiums, expiratory time constant has to be long, so E time has to be long. That is difference in the setting, basic setting. बाकी तो you know BIP, PWP, rate, FI2, and I time, everything. But main difference is I time. So more we discuss that now regarding settings. Are we going for the talks? So shall I start my work?
We will do inauguration.
Okay. So we'll continue the mode after this thing. Thanks.
Thank you, Ashish Mehta sir, for a live presentation of what he has understood from the ventilation. That is more important, That is what we are here today. So we'll be doing the inauguration of this today's event. Before I do a formal flight landing, we are waiting for the DMS of our hospital, Dr. Ravi Shankar, to come. I would like to felicitate all the faculties who have spared their valuable, from night I will say, not just the day. Most of them have started from the 2 a.m. in the morning, 3 a.m. in the morning, wake up early in the morning and got their flight, and they came directly to this place. So you can't imagine doing the night duty and coming, and many of us are like already dozing off in the second lecture itself. So they are coming and they are actively interacting. So much of dedication they have got for the neonatal care and their desire to teach all of you. That's what we should appreciate them. So along with the faculties that we already introduced, we have other dignitaries. Gangolia sir is there, who is the overall coordinator and vice president of Mahanyukan. Our IIP Raigad president, Dr. Vikas More sir is there. Kohli sir is also there. Vinayak sir is also from IIP Raigad team. And one of our faculties, as well as is the Maharashtra State Chapter NNF President, Dr. Sanjay Hari sir, he is also there for the inauguration function. So before we do the formal lamp lighting, I would like to felicitate all the faculties. Navin Jain sir, I can see he's backbenchers, but he's always first. You can see he has done DM from PGI Chandigarh, and the talk he was giving, it was like, just go on listening. There should not be any interruption. So I was hesitant to give the 5-minute break also for him. I request Evely sir to felicitate the sir.
ऊपर से स्विच
I request Ashish Mehta sir to come forward, and I request Gangulia sir to felicitate him. So he is also coming with the night shift. I request the presidents to help each other. So Dr. Sanjay Hari sir, please come. And Dr. Vikas More sir, please, the president of IIT Raigad. I request Dr. Amishwara to come forward. So ECMO was something additional in this ventilation workshop because we thought we should have some baseline idea about what it is, when to shift the transfer and all that thing. So I request Vinayak sir to felicitate me. Dr. Prasanna, come forward. She is the coordinator from IIT private team. Dr. Narjan is there, Narjan and Dr. Shrikant.
After this we have the main person who has coordinated all the things to have the workshop here, Dr. Om Prakash Damadar. I will ask Dr. Vikas Moy to do the felicitation. Yes, Dr. Om Prakash. And Dr. Shrikant Tiwari to come forward. Dr. Vikas to do the honor.
पैच आ रहा है, ज़्यादा खोलेगा ना तो पैच है 15 डिग्री वो लाइट से आ गया था ना तो अंदर जा इधर लाइट से
And the most important person of this pediatric department, Dr. Vijay Yoli. Please, sir, come forward. We want to felicitate you. No, sir, you have to come forward.
This is taking some time, but these are all our Shiksha Gurus. So unless and until you give them proper respect, you will not retain anything in your mind. So these elements are very important. We have to appreciate their efforts. I'm really sorry for interrupting your program.
Dr. Vikas, do you want to say something? I will request our President, NLA President Dr. Ahir sir to speak few words and give blessings, and then just when the Director of Medical Service come over here, we will do the inauguration, lighting the lamp, and we'll just move on. Yes, Doctor.
Good morning. So, on behalf of Maharashtra State Chapter of National Neonatology Forum, Raigad IP and Organizing Committee of Mahanewcon 2024, I welcome all the delegates and all the esteemed faculties. You are so fortunate that you have such experienced faculties like Dr. Ashish Mehta and Dr. Naveen Jain. And it is a small group, so it has to be, and it is going to be,
it is going like that only, very interactive. Take this opportunity and try to learn as many things of ventilation, whether basic or advanced, whatever you get today. So make use of this today's day for learning lots of things from these faculties. And I congratulate Raigad IIP and organizing team for such a wonderful conference and all these workshops. So thank you everyone and enjoy today's day and learn as much as possible. Thank you.
Thank you very much. As well as the Chief Honorary Chairperson of this conference, Dr. Mahesh Moite, we would like to welcome you. Please, I will request Dr. Vikas to do I will ask Dr. Sanjay to do the needful. Yes, Dr. I will request Dr. Mahesh Moite sir to speak a few words.
Let's not waste time. Sorry to be slightly late. I think they have already given all the preambles. I've heard Sanjay giving all the things. I will not waste your time. Thank you very much and do enjoy the conferencing for next 3 days. I'm sure you will be very happy with what you get out of it. Navi, you wanted to say something? Yeah, I really thank those faculties coming from all the way. Ashish Bhai, our mentor, and he has got a lot to offer. Naveen has always been a revelation about stops, right? So I'm sure next 3 days we're going to enjoy the conference. We have tried our best to give the best academics. Those who have seen the agenda, I'm sure they'll be very happy with that. Thank you very much and all the best for the conference.
Davis sir is busy, so I think we'll go ahead with the lamp lighting. I invite all the faculties and dignitaries for the lamp lighting.
Yes, please.
सर थोड़ा सा पीछे हो जाइए।
So now we get on to the main lecture, that is modes of ventilation. Before I start, let me thank the organizer Mahan Yokon and the Department of Pediatrics, Dapur Hospital for this opportunity. Ventilation is very close to my heart because I believe that a sick baby or a sick human baby need to be supported as far as ventilation oxygen is concerned when they are sick. And then on top of that, if the perfusion is maintained well and nutrition is managed, any baby or any human being can be saved irrespective of the days or weeks or years they are on ventilator. There are examples that patients have stayed on ventilator for 6 months and they are actually fine today, neurologically and metabolic and everything. So it's the art with which one need to go about it. And as we discussed that there are so many different kind of things that people use and still babies are surviving. So what is basic of this thing? As we know that my babies or the babies that you are treating, there are some unique challenges. Which are those? As we discussed that I time is short because time constant is short. Time constant is short because resistance and compliance are less in my babies. Rapid respiratory rate we already discussed. And then the weakness of the thoracic cage or the muscle itself. Challenges to the people who are ventilating these babies. So which are the challenges? When we talk about making two things synchronized, word is synchronized ventilation or word is patient trigger ventilation, PTV. Mind well, I'm not talking about PSV, I'm talking about pressure trigger ventilation or synchronized ventilation. Ventilator will behave or will go on delivering the respiratory or breath according to what you have adjusted on the screen. You adjust 6 players, PIP, PWP, FI2, I time, more support. You are got into exhalation phase, and that is what my baby wants. My baby want to convey that I am exhaling now, stop putting more air into my lung, stop there. How can you do that? This is typical synchronized breath and this is ventilator breath, and you can see
the asynchrony happening. Here, the inspiration is still going on and baby is already in exhalation phase. And that is where the problem is, that I want to breathe out and machine is pushing air in my air, I'll be gagging, I'll start to struggle. And that is where the problem would be. So what I want my machine to calculate the flow. And the moment the flow demand has started decreasing because the PIP is reached, the flow demand will be less. And the moment it goes below 15% of the peak, the more flow will not be given to the baby. Ventilator will, exhalation valve opens up and ventilator gets into exhalation phase. Clear? So that means the termination sensitivity, there are two words, trigger sensitivity, triggering a beginning of the breath. Termination sensitivity, termination of the inspiration. So the moment this is pressure and this is flow, the moment there is a deceleration in the flow to 15% of the peak flow, the exhalation starts and machine gets into exhalation phase. You can see here again, this is a pressure, this is I time is reached, your flow is decelerating. And the moment it goes to 15% of the peak flow, the exhalation begins. And that is your PSV mode, pressure support ventilation. Are you with me? All of you? Loudly yes. Great. Sure? Okay, so let's play the quiz then. If you are awake, let's play the quiz. So what is IMV? We know that. No trigger, no, everything is for the patient. Everything is decided by the operator for the patient. SIMV, as I said, inspiratory trigger is with baby and rate. Ventilator is fixed. Only inspiratory trigger is going to the baby. SIPPV, now two things in the baby's hand. Rate, assistant to each breath, and inspiratory. So more or less it is triggering and rate has gone to the baby now. PSV, what is the change? I time, because baby can end I time when required. Baby is going to tell my machine that my exhalation is getting, or my inspiration is getting over, 15% of peak flow is reached, let's get into exhalation phase. So I time will also be decided by baby. Also your rate, trigger, I time now is with baby. What is not with the baby now? PIP, that is not with the baby. And we all are concerned about the pressure these days. कि सर वॉल्यूम से प्रेशर मत रखो, बच्चे को डैमेज करता है. How can you do that? Anyone? How can you control the pressure now? You will say that सब PIP तो fix कर देते हैं. For example, I put the PIP 20 on 5. So that means each breath will be delivered at 20 PIP. But after giving surfactant, that 20 is not required. Chest will start inflating like this. I want that PIP automatically come down to 16, 14, like that. How can I do that now? Okay, so what I'll do, I'll add volume guarantee to these basic modes. So that is your assist control with VG, SIMB with VG, or PSV with VG. Volume guarantee is never ever a separate mode. It is always comes with these three basic modes. I am talking about volume guarantee, I am not talking about volume ventilation. It's a pressure ventilation problem is totally different thing, which will take little later. I am talking about volume guarantee part. For that matter, let's work why volume is coming in the picture. DFUS almost 40-50 years back showed this experience. When a rabbit's chest is strapped, even one pushes the big tidal volume, it will not hurt the lungs, it will not damage the lung, because when it is strapped, the volume delivered will be restricted, isn't it? So we want to restrict the volume even though you put the pressure in, the lung will not cause problem. It will not be damaged. At the same time, if one pushes same time without the strap, it causes the lung to burst. That we know, pneumothorax ho jata hai. So we need to restrict the volume. Pressure is equally important, but the more important is volume. That is all been shown. And then it is already proven that high tidal volume and high pressure will lead to 7-fold increase in lymphatic leakage and the protein leakage. And that's why you want something where tidal volume is normal even though your pressures are high. So concept of volume has come in the picture because of these two gentlemen. They devised that try to restrict the volume, that will cause more trauma. You can see here the first graph that this is surfactant deficient lung. This one, where you are working at 20 pressure, and with 20 pressure, 5 tidal volume is reached. You are given surfactant to this baby. What do you expect with surfactant? Pardon? Yeah, but if you are not standing with the baby, you are given the surfactant and you are attending another delivery. What will happen? With the same pressure, baby will end up with more tidal volume. That is problem with the pressure ventilation. Isn't it? With the same pressure, you end up with more tidal volume. What you want is now volume ventilation. What is the difference? Here I am controlling volume. So for 5 ml volume, initially I was giving 20 of pressures. I given surfactant. Now the same tidal volume delivered with 10 of pressure. So if I change to volume ventilation, pressure automatically will be adjusted. And that is why I talk about basic mode plus volume guarantee or other volume modes. In PICU, in adult ICU, we see all patients are on ventilation. All. Anesthetists in the OT, all of them use ventilation. But unfortunately, in the newborn population, because of the uncuffed tube, we do not have good control over the things which will be delivered to the baby. Neither I can cuff my endotracheal tubes, nor I have very good sensitive ventilators which can do. But in current era, the kind of ventilator that you have, they adjust for the leaks now. So leak adaptation and leak compensation has come in the picture, because of which all leaks are nullified and desired volume is calculated and delivered. That's beauty of your volume ventilations. So these are the different modes. My friend said that volume control SMV, that is what is doing. Someone said PSV is doing, someone said SM is doing. Now we are in hybrid mode. 3 modes, guarantee, VAPS. What is VAPS? Volume assured pressure support. And what is PRVC? Pressure regulated volume control. And you can see here, you are seeing two things, V and P in both the things. So pressure and volume both are in operator's hand. We'll quickly go through because we're running short of time. I'll take rest of things on the stations. Volume guarantee we already know. Just to quickly go through, in this graph, I want tidal volume of 6 ml. The first breath, and I picked the maximum pressure of say 18. So the first breath will be measured that to deliver this first breath, it will measure the tidal volume at 8.1. Then it realized that, oh, I'm supposed to give 6 ml. So with the next subsequent breaths, the PIP is reduced gradually. But what is problem with this one? Why are you not happy with this one? Two issues with this one. हमने तो बोल दिया कि वॉल्यूम भी अच्छा है, प्रेशर भी अच्छा है, दोनों हो गया, तो प्रॉब्लम क्या है अभी इसमें? एनीवन? प्रॉब्लम क्या है? Here, you have gone home, overnight, a ventilator-associated pneumonia has happened. Baby is worsening. You have put the VG on. Machine is not allowed to increase the Pmax. Pmax आपने जो 20 पे सेट किया है वहीं रह जाएगा. So it will keep on giving alarm, check settings. My new fellow will not understand what do you mean by check settings. It says that your parameters are not delivering adequate tidal volume because the lung is now in trouble. Increase pressure, then only volume will be delivered. रात को पता नहीं चलता है. So with this PSV and VG, only limitation would be that Pmax cannot be crossed. It can decrease, as we know, you can see here. It will keep on decreasing to deliver minimum possible pressure to deliver set tidal volume. In this example, when I want to give 6 ml of tidal volume from 8.1, 7.3, it will keep on decreasing pressure. But can it go beyond this? No, it cannot go beyond this. There is one disadvantage. And second would be that you can see here, whatever changes are happening, it is not happening in real time. They are happening over next 2 to 3 breaths. Imagine a situation that my next breath is strong and I'll take good tidal volume at that time. Machine is told to cut down the pressure. Now my respiratory mechanism has changed. I woke up, I'm hungry. I'll start breathing smallly. So whatever changes were to be done will not happen, or it will happen, it will cause more problem to the baby. They are minute things. But what is important is that Pmax cannot be raised on its own by the machine, number one. And number two, changes those are not happening real time. It will happen over next 2 or 3 or 4 breaths. That's the problem with PSV with VG. Is it clear? Is it clear or not? Loudly the bolo bhai mane jara utsar hai. Okay, that's fine. Sir, that was about PSVG. Caveats will not go into detail. What is next now? This is your access control. Yeah. So then next mode is PRVC, pressure regulated volume control. This is the one where you can increase or decrease, or the machine can increase or decrease pressure as required. So read this: pressure limited time cycle mode that adjusts inspiratory pressure to target tidal volume based on tidal volume of previous breaths. Okay, adjust the inspiratory pressure. How can you adjust? It will increase or it will decrease within the limits. Let's see that compliance is calculated by the ventilator microprocessor. So first breath is as a pressure breath, and with that breath machine will decide that how much pressure required to deliver that much tidal volume. Subsequently, it delivers 3 breaths at 75% of calculated breaths, and you will say that whether the desired tidal is reached or not. If not, again the pressure is increased, isn't it? So first calculation, next 3 breaths, 75% what's been calculated. If desired volume is not reached, it will increase PIP by 1 to 3 centimeter if tidal is not reached. This is what is not there in Pmax of the PSV plus VG. It can increase Pmax depending on the tidal volume requirement. And that's the difference between PSVG and PRVC. But problem again here is, or it can decrease both way. What is the problem now? इसमें क्या बाकी रह गया अभी? अभी तो आप Pmax भी रात को सो गए तो भी प्रेशर भी अपना एडजस्ट हो जाता है. Desired volume is also reached. What is the problem with this mode now? Anyone? It is not in real time. It is happening with the next breaths. If things are not right with this breath, the ventilator will make changes over next 3 breaths. By that time things are different, isn't it? After baby is waking up, pain, going to sleep, pneumothorax, anything happen next 3 to 4 breaths. I want each breath to be delivered according to what I want, and that too in real time. That's what I want, isn't it? That's perfect. मुझे जितना चाहिए इतना ही प्रेशर चाहिए, मुझे जितना वॉल्यूम लगेगा, मुझे ज़्यादा कम नहीं चाहिए, ईच ब्रेथ में चाहिए. Then is ideal ventilator mode. which is that mode. Which is that mode. You can see here for this mode 3 up and 5 down. So PRVC is the one which will regulate the Pmax within this range. So you, for example, you set the Pmax of 20. You can go to 23, you can come down to 15. And within that range, the volume will be adjusted. That's beauty of PRVC. Only problem now is real time. And what you can do is, we'll not go into detail of this. This is the same thing that has been explained. Volume assured pressure support. The last mode. I will not get confused. VAPS. Volume assured pressure support. Here now we are talking about volume assurance. पहले क्या बोलते volume guarantee. But guarantee में you can't change the pressure beyond Pmax. Now talking about volume assurance. So by any means, volume will be delivered irrespective of baby's condition, irrespective of how much pressure required. That is your VAPS, volume assured pressure support. So what happens here is simple, that this first is pressure support breaths. Calculation is happening. Now, with next breath, machine is calculating the pressures and with which whether the tridone is delivered or not. If not, then more flow will be pushed to deliver the tridone. That is what we want. कि भाई ज़्यादा push करके भी मुझे tridone reach करना है. Just give more flow within that I time, or you can cross the I time also. Because all modes will follow the I time 0.4, 0.3, 0.2, 0.3. VAPS I time will change to give more flow to deliver the desired volume. Clear? So you can increase the pressure, deliver the volume by increasing the flow. But if the still lungs are so bad that desired tridone is not reached, then automatically machine will change from the pressure to volume ventilation and deliver desired volume. So within each breath, the ventilator keep on changing to deliver what baby needs. And that is beauty of VAPS. Unfortunately, in current era, we are going away from invasive modes in newborn population. Sick babies, like what Dr. Verma is going to discuss, HFV, CDH, very hypoplastic lungs. Yes, this all will matter most because baby is in a developing phase of the lung is in developing era, developing stage. We do not want to harm the lung. We want to protect the lung. So all these gimmicks will work when the baby is very sick and lungs are very bad. VAP is one of the mode for that. I'll stop here because still there are more to go, but time will limit and I'll take further on the tables. But before I stop, only 5 things that I want to ask. First, what is disadvantage of IMV? IMV का disadvantage क्या है? Asynchrony. Asynchrony से क्या होता है? फाइटिंग से क्या होता है? फैंटास्टिक. और दूसरा क्या होता है? न्यूमोथोरेक्स, IVH. SIMV का एडवांटेज क्या है? सिंक्रोनाइजेशन होता है. डिसएडवांटेज क्या है? फॉर स्पॉन्टेनियस ब्रेथ दिस इंक्रीज वर्कएबिलिटी. असिस्ट कंट्रोल का एडवांटेज क्या है? सपोर्टेड. डिसएडवांटेज क्या है? washed out. So there is decreased work of breathing, but CO2 washed out. PSV का एडवांटेज क्या है? Expiratory synchrony. But the bigger, okay, that which parameter is which baby is PSV?
Rate and I time.
Rate is there with the SS control also, but I time is the right answer. I time is the one which stays with the baby when you are receiving on PSV mode. Very good. You are awake. Thank you very much. Last question. What is the advantage of PRVC over PSV? Pmax can go up by 3, come down by 5. So Pmax also will change in PRVC mode. What is disadvantage of PRVC mode?
Pmax not in real time.
Not in real time. And what is advantage of VAPS mode?
With each brain can change into
It happens in the real time. That is advantage.
What is disadvantage of VFPS, which I didn't discuss because of the time problem? Only disadvantage with VFPS, still Pmax you can't change, like your PSV. Pmax only can be changed with PRVs. Having said that, last question, which is best mode to ventilate? Last question, which is best mode to ventilate? The one with which you are well versed with, the one which is good for your particular machine. Because I want to blame any brand, they really sell at very high price, but when this mechanic doesn't work, it is as good as any dabba from the Burjari or there is Sunday market. So ultimately you need to be with the baby during the round, make sure that baby is fine, but ventilation is also functioning well. At times, the quick busy nursery, you say baby is not working well and you always tend to believe that lungs are bad or baby is not breathing. But when you look at the things around, monitors, ventilators, humidifier, all these things, you will 100% pick up that it is not baby all the time, it is something else which is also responsible for not desired result in your round on that particular baby on that particular day. So it is very easy. जब quick round लेते हैं तो चलो इसका PA भी बढ़ा दिया, इसका effort बढ़ा दिया. Don't do that. Stay there. Why effort बढ़ा है? Why PA बढ़ा है? Why baby is not behaving? That will be the right mode for your nursery. Thank you very much.
Thank you, sir, for the presentation. It was quite interesting to see how different modes of ventilation work. There is still a mixture of things, but as at the end of the day, what your machine is delivering rightly and what you are comfortable with, that we should do. That is very important. So there will be slight change in the schedule. Instead of the nitric oxide and high frequency ventilation, we'll be doing a next session on the ECMO and then subsequently we'll take care.
Hi, good morning. Where is the good morning? Good morning. Yeah, that's better.
Everyone should stand up first.
Okay, let's stand up. Let's listen to the boss. Yoga day. Stand up and stretch.
Yes. Start.
Who wants to do Sirsasana? You want me to do Sirsasana? You join me? No, okay, leave it. So, good evening. Good morning. I also need a cup of coffee. Okay, so I'm Dr. Amish and I'm just showing this slide because I think most of you are fellows or finishing fellowship and I need to know, you need to know. Nowadays I find it very unusual after I came back to India after 25 years that people after 1 year fellowship said bahut ho gaya or they do 2 years fellowship bahut ho gaya. So I just want you to see this. When I left in 1999, I did 3 years of NICU fellowship. I was about to be an NICU consultant when I decided to 3 years PICU fellowship. And during our time in Australia, fellowship in Australia was 3 years. Okay? And PICU fellowship is only given to people who have finished one fellowship. Most of them were anesthetist fellowship or cardiac fellowship or airway fellowship. After that, they get PICU fellowship. I was the first in Children's Hospital Westmead in Sydney, which was a level 4 center, to be somebody coming from NICU doing PICU fellowship. So I did that for 3 years. And after that, I did 2 years of cardiac and ECMO fellowship. So I did about 8 years of fellowship before I became a decided consultant. If given a choice, I would go back and do interventional bronchoscopy fellowship again. Okay? So it's not that you should, after 1 year or 2 years, give up what you want. What you like, please continue. And 1 year fellowship is like, Indian Jugaad. So be happy that you have this option. Okay? All of us during our time had no options. Our batch was the first batch which had to decide whether I take my DM at KM or go to Australia, both at 3 years fellowship. So our batch was the first time when the fellowship in DM became 3 years. So please keep this in mind. Do your fellowship, enjoy and do more. I'm going to speak about ECMO. It's my passion. So this is what I'm going to speak about. Especially I would really like to thank OMI for putting this ECMO in program in this advanced workshop. Together with thank the Maha Neocon, scientific workshop of NNF and IAP Raigarh to giving me this opportunity. Okay. So what is ECMO? ECMO is a membrane which helps in oxygenation or helps in cardiac output in newborns to adults using a typical bypass machine which was used for a few hours in OT, which was modified to support in the ICU, to support one heart and both lung. What is going to be my objective? I'll give you a brief history of ECMO. What are the indications and contraindications? What are the basic principles of ECMO? What is the evidence base? We speak about evidence. Okay, so let's start with the basic theory. Broken leg. If you break your leg, do you rest it, ice it, elevate it, or do you slog it and go and play football or marathon? Rest it. So when a lung is injured, whether it's a newborn or pediatrics, or a heart is not functioning, do we put on the ventilator, a non-physiological ventilator, which will say work harder, or start more inotropes to work harder? So what is more physiological? Rest it, let somebody else take the role. What is a brief ECMO? ECMO is where you draw the blood out from a pipe. So this is a venous pipe. Blood is drawn out by the pump, monitored by the computer, gone into the oxygenator, gets oxygenated, CO2 comes out, the temperature is maintained at thermoneutral temperature, and the blood goes back. Simple. Does the work of lung and or heart both. So it's very simple. No making anyone slog hard. It was okay that this was my first ECMO. Okay, in 99, here's a baby. Here's a baby on high frequency here. This is a centrifugal pump. This is a roller pump where the pump, you needed height for the blood to drain out. So, this is where with the brain, this was the ECMO pump, and this is CRT machine over there. So this was in 99. I still remember, 7th of February 1999. I just landed. After 1 week, I saw my first ECMO. I was flabbergasted. What the hell is this going on? Heart bhi support karo, lung bhi support karo, kidney ko bhi support karo, baby ko sula do. And you take over everything. And this is nowadays centrifugal pump. 2008, I swapped over all my, in Leicester, in one night, I swapped over all my pumps from roller pump to centrifugal pump. Simple pump like your ventilator. This is my pump, this is my ventilator computer, and this is my oxygenator. Okay, blood comes in, blood goes to the oxygenator, blood goes back. And this is my control like a ventilator, which I control. So it's so simple and modified now. In last 25 years of my lifetime, it's drastically changed. And this is only so long that the ECMO is there. ECMO started in 1950s. Okay, first cardiac bypass surgery was done in 1970. First meconium by Bartlett was put in 1976. Esperanza is the first girl who, meconium aspiration, who was kept on ECMO. Okay, the ECMO Society was started in 1989, 35 years back. This is the first respiratory ECMO of a young biker in Orange County who went on ECMO in 1971. Okay, and this is Esperanza when I went to Boston when I was doing my internship in '98 in Australia, in USA and Boston Children's. I met her. Okay, she came to meet Professor Bob Bartlett, and this is her photograph. Now, after so many years, she's a mother of 2 and a grandmother of 1. These are the ECMO centers in UK. 4 ECMO centers: London, Leicester, Newcastle, and Glasgow. I worked, trained, and became a consultant in Leicester for 8 years. My pleasure it was. Leicester, as a pediatric and neonatal, we used to look after adult ECMO. Okay, we used to do ECMOs from newborn to adults. No adult intensivists would touch ECMO because our principle was they don't understand how to manage. We as a neonatologist told adult world how to do lung protective, how to use 4 to 6 ml per kg of tidal volume, how to keep an eye on the fluid balance, how to give importance to nutrition. The world has learned from us neonatologists what to do, and the world has learned ECMO from us. Okay, we were the only centers which were doing adult ECMO in whole of UK. Okay, till 2013. We are the Mecca, which did the first randomized controlled trial in ECMO and neonatology in 1996 published, and I was a part of the CSER trial which was done in adult randomized controlled trial, ECMO versus conventional, between 2007 and 2009. Okay, ECMO is a department, like you have neonatal department, pediatric department. In my center in Leicester, ECMO was a department. Okay, they were doing ECMO for 35 years. We have a head of the department in ECMO. We have surgeons who are 50% ECMO. We have neurologists like us, which does 50% ECMO. We have 5 consultants who used to do ECMO as 50%. We have 20 ECMO nurses whose only job was to do ECMO, and we had 20 ECMO, 200 ECMOs per year which were going on. So this is a brief history how ECMO is in the world. Okay, so it's nothing hi-fi, nothing things. It's very practical, which is going for more than 35 years, and I've been doing for more than 25 years. It's all like your ventilator. It's like your ventilator or a renal perfusion. This is your oxygenator. Okay, this is your oxygenator. The blood goes in from one side, the blood comes out. The blood goes through the oxygenator. The oxygen goes through the tubings. They don't mix. Okay, by simple principle of physics, they transfer oxygen and blow out CO2. The temperature water keeps on running. All 3 runs in the anti-clockwise and clockwise directions. They don't meet but are going through the porous membrane. This is like your monitor of your ventilator. This is my centrifugal pump. I just have to set how much mils per kg blood flow I need. Newborns 100 to 120 mils per kg. In newborns with sepsis, we might go up to 140, 150 mils per kg. I said that the machine will calculate and give me how much it should be running at. That machine will tell this pump to suck the blood. So blood is sucked in over here. This is a monitor which makes sure that it gives what I want to deliver, and from here it goes to the oxygenator. So 3 things: oxygenator, the brain, and the spine, the pump. 3 things decide the whole ECMO. It's such a simple science. Okay, nothing hi-fi. No 37 or 47 modes like Dr. Ashish was describing. Very simple in this. Nothing to do. Oxygen ज़्यादा है, FiO2 कम करो. CO2 ज़्यादा है, sweet flow कम ज़्यादा करो. खत्म. Nothing else to do in this. Only thing is that 2 types of ECMO. Whether you do venous for doing your lung. Okay, where your blood is sucked out from the vein, superior vena cava or inferior vena cava or central directly, and return to the either the same vein or the different vein. So this is venous ECMO. Okay, newborns, we have simple small cannulas which we have arranged for it, but we have not arranged a single lumen cannula. These are 13 French single lumen cannula. Very simple. The blood comes out of the blue and the blood goes back in the red. Okay, and we put it ourselves. When I was training, the surgeons used to do it. Nowadays, most of my juniors have do it themselves. I'm still being old time. I prefer my surgeons to do it, but for my surgeons also, I give them the jugular vein and then they dilate and they do it everything. But it's okay. And so this is how it looks, and this is how it looks like a baby. Slightly bigger than your UVC, UAC. What is second is VA ECMO, where you want to bypass both heart and the lung. You suck the blood out of the vein and you put the blood back in the artery. Okay? Either you take it from the jugular vein and go back to the carotid artery, or you direct, remove from the right atrium, give it to the aorta. Okay? And this is how the baby looks. This is single catheter, venous. This is dual catheter, veno-arterial. Simple ECMO. This is classical, your meconium with sepsis, with air leak syndrome, multiple 3-4 drainage here. And if you don't do anything, this patient would have died. And we put on a single lumen ECMO, okay, single catheter ECMO, and you can see the lung after we put on the ECMO is totally white out, okay. And this is another patient with sepsis on VA ECMO. So this is the artery and this is the vein. The tip of the ECMO is always in the right atrium. It will look at the ball and the ECMO is there. Similarly, we do in a teenagers. This is a teenager, about 17-year-old lady, young teenager, whom we did an ECMO, put the blood back in the jugular, remove the blood from the femoral. Okay, so we can do in both. This is in pediatrics. You can see they're using a single lumen VV ECMO with ARDS, and there's another child doing femoroarterial VA ECMO, doing peripheral VA ECMO. So it happens right from newborn to young adults. We do this. It's a simple process which happens. It's nothing hi-fi, just like a renal replacement therapy or what you do like an exchange transfusion, but for a few days and weeks. Okay? When should you refer the ECMO? The first thing I say as a clinician is, When something tells you, boss, आज fire हो गया, ये बच्चू is going to give me a trouble. Either it's heart failure or lung failure, you feel you are optimized all your resources and you have done your conventional ventilations, you need to speak to your ECMO center nearby. Okay? Make sure that underlying condition is reversible. There are no contraindications to heparin. Blood is coming out, you need to heparinize. We say the gestational age about 34 weeks plus and weight of 2 kg. Having said that, we have put 1.8 kg also on ECMO now. So what are the criteria? People like criteria. Okay, so PF ratio of less than 100 for more than 6 to 12 hours. Acidosis, any acidosis not reversing within 3 to 4 hours. When you can't do lung protective, 4 to 6 ml per kg, you can't do your lung protection, you should consider that. When your rescue therapy, high frequency, nitric, prone therapy, nothing fails. Whenever you have more than one air-leak syndrome, think of ECMO early because your lung protection is not working. In neonates, what we use is oxygenation index. Remember, oxygenation index was a criteria which came more than 30 years back before high frequency nitric came. So when you use high frequency or nitric, add oxygen index by 10. So if your oxygenation index is 30, you're on high frequency, your oxygenation index is 40. If you're on high frequency and nitric, your oxygenation index is 30, your oxygenation index is 50. Use that criteria, and if you're not winning, think of that. Okay? The most common causes are PPHN, meconium, diaphragmatics, RDS, in our setup, sepsis and pneumonia. Okay? Similarly, same criteria in pediatrics. Most important in India is what we are seeing is that we have published quite a few literature from North in Ludhiana, wherein a lot of pediatric patients are having poisoning. Okay? Organophosphorus poisoning from the fertilizers, and they are giving those patients who would have definitely died, 90% mortality, have 75% survival. ECMO contraindications, we say 7 days. If you are ventilated for more than 7 days, you should think whether you really want to refer because fibrosis will start. In newborns, we say 10 days. Okay, 7 to 10 days is a period, grace period. After 10 days, think twice. Obviously, IV is grade 2 because you're going to be heparinized. Irreversible disease or disease with poor outcome, you don't want. And relative contraindication, heparin. Nowadays, we do heparin-free ECMO as well. Now, so this is about why we refer for ECMO. Now, what is an evidence? There are lots of studies, right from 1970 to 2020. Okay, but I'm going to give you, we are specialized people. We believe only in the randomization control trial, blind, double blind. Okay, so these were the 4 centers which did a randomized control trial of ECMO. Okay, you can't do blind because it's ECMO and conventional, so it can't be blind. So we did the four centers did the randomized trial, published in Lancet in 1996. Okay, it was published, ECMO was published in 1996 and RCT was published. Okay, this trial was supposed to recruit 2,250 in each arms. It was supposed to run for 4 years. It was cut short in 1995 because it already proved that you have 25% improved survival, 1 extra survival patients on 3 on ECMO. So if you put 4 patients on ECMO, 1 patient will survive more than conventional. Hence, finally, it was stopped and was published. Okay, so since so long, improved mortality of 25%, we have no methods till now in last 40 years which improves the survival rate by 25%. Okay. So what about survival? But we are neonatologists. We want outcome. What about disability? So if you look at the ECMO, plus dark blue is your disability. If you consider both death with ECMO, okay, or severe disability, it is still 33% less than the actual thing. Okay, and the no disability group is also twice compared to the conventional. So not only ECMO, you have better survival, you have more survival without disability. And this was in 1996 when we were using centrifugal pump, the old pump which I showed you. Okay, as I said, in 2008 we changed everything in our center. So then we did a cohort study. 500 patients before using roller pump compared with our single center, 500 patients whom we use centrifugal pump. We looked at the data, cross-matched everything, okay, and we found that after changing the method of doing ECMO, we had even significant difference in mortality benefits in neonates. Okay, in pediatrics our numbers were a little low, so we could not match it and show that in pediatric also it was a mortality benefit. But neonates definitely going on centrifugal, there's a better mortality benefit. Also, the blood products requirement and platelets requirements were decreased using centrifugal pump. I was really confused. Okay, I'm looking at, but I found that there were more history of seizures in our group of patients who were on centrifugal pump. So I was really confused. I was looking at all the data, whether there was hemolyzing happen, whether IVH is increasing, whether irritability was happening. And you know, when you look at 1,000 patients for 3 years, you are literally this. I spoke to my mentor, Mr. Furman, and he said, let's talk about it and discuss it. He said, I'll also look it up. And then father of ECMO, Bob Bartlett, comes over. He comes to our center because one of our ECMO surgeon was retiring. So he came over for his felicitation party. I spoke to him about this data I was doing. And he gave me, as a mentor would do, he gave me one tupply on my head, whether it's India or UK, he just gave me one tupply. He said, fool, before when we were doing ECMO, we would never do amplitude EEG, we would never do EEG monitoring, we would never do 12-lead EEG, what you all intensivists and neurologists are doing. We would put on ECMO and we would be in the ECMO. No neuromonitoring was going on. So, you know, those 1,500 patients, you have not done neuromonitoring, that's why you are not picking up the seizures. And so, after that, you need to look back whether the rate of seizures is increasing or the rate of seizures are decreasing. So that's why we had increased seizures. But how, you know, something you were thinking and contemplating for 3 months, 4 months, and how your mentor can just come and solve it for 4 months. That's why they are what they are. Then comes the adult seizure trial, which was a conventional versus ECMO in adult respiratory distress. Not only that, ECMO is red, the conventional is blue. Not only there was mortality benefit in the initial discharge from hospital, but also 6 months down the line there was a mortality benefit. Okay, this is the same thing we saw in when we published 2007. We published our data about neurological outcome. We found that compared to the patients who were on ECMO had a higher rate of survival than those who were coming for conventional. We could not publish that because our primary aim was neurological outcome in 2007. So we have just published that, and that's what it is. Let's come to India. In 2008, when I came from UK to talk about ECMO, and there was a sepsis workshop next door. There were 4 patients in my ECMO, and sepsis was filled up. Okay. Nowadays, I do ECMO workshops. I have ECMO workshops, and I give a talk of ECMO in pediatrics and adults. My last ECMO workshop in Jaipur, it was a workshop at 120. I had to close down. 120 we closed down taking registration. Okay, so now ECMO is like a boomerang, all because of this one and this COVID. Okay, after COVID, people have gone gung-ho and realized that ECMO really works. And before that, it was, you know, India has a star specialization. So it's like a kawat. Jayalalitha went on ECMO, and since then everybody's talking about ECMO. It's like, you know, before dying you should go on ECMO in between. So it's like, ECMO pe nahi gaya, you didn't do everything. But that's a wrong thing. Let's not think like that. But for me, at least it worked. That since 2015, I am back. ECMO is just boomed up in India like anything. I'll show you the data. Before that, let me take a case. Okay, so we take a case of a 2-year-old, 8-month-old child with cough cold for 4 to 5 days, fever and breathlessness for 3 days, seen by a good pediatrician. Okay, the pediatrician saw the child 3 days back, diagnosed viral, sent home, saw the child 1 day before, she found the child was good. Next day morning when he sees the child again, okay, he finds the child is totally breathless, increased craps, and he says, what should we do? He speaks to his nearest PICU, which is a level 2 center, and said this child is deteriorating rapidly, and they did a chest x-ray, and he said that should I bring it to you? Luckily he said don't come to us, child is going to ARDS, is repeating very fast, or lung injury, let's transfer to Amish, let him see it. If he does not need anything, we'll get better than us trying to level 2. So referring is the key for initiation of ECMO. Okay, don't start thinking of ECMO as if when the child is about to die. Okay, when you are 100%, you try various modes, you start pro and high frequency nitric, and after that when the child is about to die, you think of ECMO. Don't do that. Okay, so when you fulfill your criteria and you're not reversing, you think you have done maximum, at least speak to them. So this was the X-ray when they saw in the morning, and luckily the nearest pediatric intensivist said let's send this child because it's a lung injury, two area involved shift. The child came to us, my fellow, usually by the time it's morning, by the time it comes to us, it's evening. Okay, so it comes in the evening after us. My fellow sees the child, says the child is sitting, we'll just put on high flow. So he puts on high flow. Within 2 hours, he gives me a call, the child is gasping and is needing intubation. The child goes and ventilate. Okay, by the time I reach, child is on high frequency. Now the child is on 3 inotopes. So, okay. So in 6 hours, the child's first CBC shows total count of 1,400, ANC of 532. Why is it important? ANC of less than 500 has a poor outcome on ECMO. CRP is 96. You remember the first X-ray. This is X-ray on the left side when the child came to us. And this is X-ray next day morning and the child is already on ECMO. At night we had to put this child on emergency ECMO. So how rapidly this child was progressing. Within 36 hours, child from sitting, talking, went to NIV, went to high frequency and went on ECMO. Before we went on ECMO, this was on high frequency. This was a blood gas, pH of acidosis 7.1, PO2 of 37 on 100%. Luckily, the lactate was maintained. OI was 64, PA2, FI2 was 37. ECMO was started on day 2. Continuous ultrafiltration was done on day 4. ECMO was weaned and removed on day 10. Early referral, early come out. Day 2 on ECMO, day 8 of admission, child off ECMO. Extubated on day 15. Discharged on day 21. Okay. Child was swine flu with secondary bacterial PVL staph aureus with EIRDS. This is the child's X-ray, and you can see the PVL cavitatory pneumonia, which is residual, which will go away in 6 months. As we said that this was one of the cases, just to highlight you how it happens. What are the Indian data of ECMO? As we said, after COVID in adult world, they have done 10,000 ECMOs per year in India, pediatric and adult. Okay. About 600 mobile ECMO. People think that they are difficult in moving. We do mobile ECMO as well. 600 mobile ECMOs happen. We have three fixed wing planes sitting in Bangalore, Chennai, Bangalore, Calcutta, Delhi. They can move anywhere to bring the patients. There are more than 30 adult ICU, which was in 2022. In 2 years, it will increase. 18 PICUs which are doing ECMO. Okay, India is doing highest number of ECMOs in the world now. Sadly, we don't do our numbers. Now, I'm showing you our own data of pediatric and neonatal ECMO in India in 2021. Okay, here you look at the neonatal figure, which is quite sad. All these centers are doing ECMO, but in these centers in the north, they had only 2 neonates which were put on ECMO. Here again, look at this Bangalore, 2,000 ECMOs over 4 years, only 4 meconiums. Okay, Hyderabad only 1. Okay, Riddhi, Nalasopara 1. Okay, so surprising how many less neonates we are doing. If you look at the south and western India, our centers, we don't do any neonatal ECMOs we get. We do majority pediatrics and adult ECMOs over here. When you look at the national data, before 2020, the highest number of ECMO used to be neonatal ECMOs. Okay, since 2020, after COVID, adults are doing more ECMOs than the neonates. But look at the outcome, neonatal ECMO. These are the patients who are last line, have outcome of ECMO 87% of survival to discharge 77%. Okay, or 72%. So, patients who are going to die go on ECMO and 73 out of 4 of them go home. And yet in our country, we are not referred. So please consider that. Look at the numbers of centers doing here. 2015, when we came to, oops. When I came here, the world had 384. Now you see there are 570. There are more than 200 centers which have started ECMO in the last 10 years. Out of those 200, at least more than 100 are in India. Okay? Doesn't mean that if you're sent to us, we put them on ECMO. Look at our data of PPHN. This is 2017 to 2019, which we published in the oral presentation my fellows did in Pedicon. Okay? So 35 infants were diagnosed with severe PPHN. 16 had meconium, 3 had HI who died, 6 had CDH, of which 2 were first trimesters who died, 11 had sepsis, only 1 died. Okay, 71% male, gestational age 38, inotropes, most of them had adrenaline 22, Dopamine 19 because they come on dopamine. Vasopressin is our preferred second line, which is 18. NORAD is 4. Dilator we use milrinone as first line at 17. Sildenafil at 4. Only out of 35, 4 needed nitric. In spite of OI being more than 35 on high frequency, only 2 we activated ECMO. Luckily we activated ECMO, but the child did not go on ECMO. Okay, so all of them had a very high anatropy score of 27, where more than 20 had a higher mortality rate. Okay, all this PPHN, the median duration of stay was only 12 days, and outcome was same thing like ECMO. 83% of them survived. Okay, so all the high risk PPHN with meconium, with sepsis, with CDH, if you do it, they come out. And this is my protocol since 2008. We don't use dopamine since 2008. In fact, if those who were there in Vadia with me in 99 remember me, that I would never use dopamine, because I said that in 99 I spoke with my pediatric intensivist, Dr. Joshi and Uma Ali. Madam, heart does not have dopaminergic receptors. Why am I using dopamine? Why can't I use adrenaline? Does not make sense. Since 99 I always keep adrenaline as my first choice. And this is my protocol where adrenaline is my first choice. I use milrinone for diastolic dysfunction. Vasopressin as a second choice. So, surfactant and ECMO is what we do. When you look at the outcome, this is what we had published in 97. We could not, overall survival rate of meconium was 95% on ECMO. 80% was respiratory ECMOs, 80% we had survival rate. CDH is the least one with 50%. Not only survival rate, we published in Pediatrics 2007, CNS injury moderate to severe 8%, sensory neural deafness 15%, and learning difficulties 20%. So it's same as conventional. And not only about ECMO, in 2009 we started mobile ECMO. This is my first patient. I transferred mobile ECMO from Birmingham to London for heart transplant. Since then we made a trolley, which is, this you can see the Indian Jugaad. And this is my perfusionist Richard. Him, I tell them that he's an Indian because he knows how to do the jugaad, how to fit the ECMO, how we did everything. 48 hours we did manage to just fit everything on a trolley and do the transport. After that he did everything and made it set up that we can transport. We do 50 ECMOs a year transport in 2015 when I left. As we said, in India we did 600. There we did 50. In India last year there's 600 mobile ECMOs happened. This is a plane helicopter. We had a helicopter pad in our hospital to transfer patients. We had 2 helicopters and 2 fixed wings to transport patients. This is when we were going to get an ECMO. This is me doing a mobile ECMO in 2020, doing it in adults. So we color coded that the whites are the doctors and the blue are the helpers. Okay, so this is me, the big man standing inside. This is a patient on ECMO. I put all the ECMO stuff, jugaad, everything in between the patient's leg. Okay, the ventilator, I disconnected the ventilator because he's not fully on ECMO and is stabilized. And we shifted him out to get a mobile ECMO. Okay, we talk about mobile ECMO. We had a patient from Goa which was supposed to come to Bombay, but Hyderabad took them over and the patient traveled 700 kilometers by flight for mobile ECMO. So Hyderabad has done one of the longest mobile ECMO in our country for the youngest infant, 6 weeks old child. Okay, and the child has gone home. Beautiful. People talk about cost. I don't know why neonatologists talk about cost. When ECMO costs about 3.5 lakhs, cannula costs about 50,000, we can even make it free for them. The cost is about 80,000 per day. Total cost is 10 to 20 lakhs. In Bombay, the cost of preterm 25-weeker is 20-25 lakhs. Okay, so people, when they tell me the ECMO is expensive, I think prematurity is more expensive. There are centers over here which charge, whose 30% of the patients pay more than 15 lakhs when they come to the NICU. Big centers which are 50-bedded ones. So people should not be talking about, when we do prematurity, when we keep the patients for 3 months in NICU, can't be talking about ECMO being expensive because, for 12 days it's expensive, but it's life-saving and nothing more needed. So adult bypass costs about 7 lakhs, kidney transplant 15 lakhs, liver transplant 20-25 lakhs, bone marrow 30 to 35 lakhs. How many of you know patients with transplant? 1, 2, 3, 4. Okay, 4 patients have known people who have done transplant. And how many have put on ECMO? 1, 2. See? So that's what it is. And not only that, the cost per life year saved. Okay, after you go on ECMO, you come out, you don't need any medications. Transplant for lifelong, you need medication and you need transplant again. My first liver transplant in 2020 has had a second liver transplant done. Okay? While all my ECMO patients, hardly anyone has needed a second ECMO. Sadly, some of them, my first adult ECMO over a year done with swine flu in 2018, had another COVID, and we tried to do another ECMO on COVID and didn't make it. Okay? So it's sad, it's very rare the patient needs 2 ECMO runs, but it happens. So finally, ECMO is a treatment, it's not a treatment, but a supportive like your ventilator. It supports the organ till it recovers, and it is most physiological because you are not causing any injury. It needs a skilled, dedicated staff. People call me up, why don't you come and do ECMO over here? Okay, one of the reasons why in Western India, like in Bombay and this Gujarat, it didn't work is because people go around doing ECMO in bedsides. It does not work. ECMO needs a specialized staff, dedicated staff. Okay, my ECMO unit has a laminar flow. Okay, it has a positive pressure chamber. Okay, 4 times in an hour, 4 times in a minute, the air is pumped out. It's recirculated. It's like as if you're going into a OT theater. And hence, we keep patients off antibiotics on ECMO last 2 years now. We are so confident that the patients on ECMO don't need antibiotics. And it works. This is this child, the father just sent me this child's video this Eid. You can see the father laughing. This is the same child who was on ECMO. People talk about ventilation. People talk about really silly, all the injuries. I say just put on ECMO and remove the ventilator. This is my first patient I removed from the ECMO in 2010. This is the same patient whom we brought from New Bombay over here. Today somebody was talking about this child I transferred from this part of Bombay, New Bombay. I transferred this child with pneumonia, with ARDS, with air leak syndrome. Okay, you can see how much air leak and how much bad the ARDS is. This is a pH of 6.9, PCO2 of 120. I was about to put on ECMO. The surgeons were ready, OT was ready, it was perfused. But the child, we did maneuvers, child recovered, we didn't do ECMO, child came off without ECMO. And this is a baby who went home after 10 days. So just because if you refer, does not mean you go on ECMO. And just because you transfer the child does not mean you can't manage it. Okay? This was a patient who was referred from ECMO, from a very good center. But because they timely referred, and we also thought the child nearly needed to go on ECMO, but the child didn't need to go on ECMO. So ECMO, is it a miracle? I think so, but it's also become a standard of care. Its early referral is indicated. Better to refer and not go on ECMO than to refer late and then have a prolonged run. Course of ECMO is less expensive than transplant. After ECMO, you have a normal life. This is ECMO made simple. Once again, thank you. If any questions, I can take it now or I'll take it at the end. Thank you. Just one more last slide. You all see me with the long hair. Okay, it's not that I want to look like Salman Khan. He is jealous of my long hair, but that's okay. I tell him to be it. But I'm doing it for Cut for Cancer, hair donation. I lost one of my colleagues to CA breast with sepsis in her name. 20 doctors and 66 family members are growing hair to donate for cancer patients. So there's some information. I also never knew that you can donate hair for cancer patients. So gents donates hair for kids with cancer. Ladies donate hair with for ladies with CA breast. Okay, just some information. Thank you.
We can have a short break by the time we are arranging the presentation.
इधर सीटों की डाली नहीं हुई थी ओपन
संजयला फोन करू
नाही
हां केलास तू
ऐसी के अंदर हो गया
कनेक्टेड है नहीं इधर स्क्रीन पे नहीं है स्क्रीन पे आना चाहिए और कनेक्टेड है
all out.
ठीक है सर उसमें कैंसिल करो तो देख के ना वो ये तो दिया भी 500
इसके लिए हो गया काउंसिल भी करना है इसके बाद तो यहाँ पे प्रोजेक्टर कनेक्ट नहीं हो रहा है राइट
इसमें लिखा था पार्सल वेट शुड नॉट बी मोर देन 20 kg डाल के दें तो वो पीछे करना सकते हो मैं बोलता हूँ पूछ लेता हूँ कार्टून रहेगा तो कार्टून के अंदर डाल के रस्सी को काम लो पीछे मैं तो
Good afternoon, everyone. Call inside. Yeah. Yes. So we'll start. All of them are inside. So we'll be talking about care of a baby who is on ventilator. So we have covered the initial parts about different modes of ventilation as well as the connections and everything. We are going to do the demonstration. But while the baby is on the ventilator, what are the things that we will be taking care of that is very important for us, because without supportive care, the outcome just by the mechanical support is not going to make much of difference. So this is a place where I was trained in UK, and this is a place where I am working at present. So there's a good saying that tell me and I forget, teach me and I remember, involve me and I learn. And that is what we have tried to do during this session. I have given this information leaflet for everyone to follow when you are sitting at the in the auditorium. So how is the room temperature today?
Conducive.
Is it conducive? As it is cozy, isn't it? So everyone is saying it is a bit warm here, So this is the temperature that we want in the NICU setting. I have not asked them to set this, but it has just happened like that. So the environmental temperature is the first and foremost parameter, and subsequently we'll go through the series of questions that I have given to all of you. So what we want to do is the environment in the where the baby is in utero, that is what we are trying to create. And that was the concept where the incubator has started. We are trying to create an artificial miniature womb, and time to come, AI can help us to make an incubator like a mother's nutrition and everything. That is what we may come in future. So thermal comfort is the most important. We need to take care of the surrounding environmental temperature. With ACs are there most of the places, 26, 28 what we target, and the temperature, the skin probes has to be in place. That is very important. We have seen mishaps happening because of the skin probe getting misplaced from the baby's contact. Then second, the noise part. How many have noticed you have got any measurement? Have you measured the noise decibels in your NICU setting? How many have you done? There are equipments in the mobile, there are apps are there which can tell you how much is the noise. And who is the most contributing factor for the noise? Alarms. So we tried to review our data, and the alarms was the first and foremost thing. Second was the ringing bells from the mobile phones of the doctors and the landline phones in the NICU setting. And third, during round times, there is noise of the discussion from the nurses and the doctors. So these are the things which we need to be taken care of. If you sit beside a loud noise for a longer time, you will get irritated. What is this going on? You will be neither able to take rest, and all your parameters in terms of, I'm sure, like if your blood pressure will also vary with the intensity of sound that you are going to get exposed. So you need to have monitors that tells you how much is the intensity of noise in the NICU, and you need to control the noise. We need to try to find out the contributing factors and help to calm them down. Next is the light. There is a bright light in front of me. I'm sure all the presenters are facing the challenge that there is light on my face. Can you imagine the lights being on our face in a lying down position? You are sleeping and there's a bright light on your face. And that is what we do to our babies. Someone comes, switches on the lights, put the cannulas, goes away. Someone comes, changes the diaper. So in this way, there is no time off for them. There is something called as sleeping hours for the NICUs, quiet hours for the NICUs, and that is which is very important for all of us to follow. So the light intensity, what we should keep in the daytime is 100 to 200 lux, and in the night hours it should be 60 lux. If you are doing some procedures, you can require something up like a 1000 to 2000 lux, because you need a good brightness, but it has to be limited for that much time frame only and not for a continuous time. There should be extra precautionary measures that we should take in all babies, and in particular for preterm babies. Many of you take x-rays for the babies. There's an x-ray plate that comes, put the baby on the x-ray plate. Warmers and incubators, they do have got the provision of putting the x-ray plates, but many times the plates and the size of the warmer facility which is given is not appropriate, so we have to use different ways and means. So you need to be careful before we put the cold X-ray plates for the babies taking X-rays, which may happen many times in a day. Incubators should not be very close to the walls. There should be some spacing so that there is no insensible heat loss is there. And the nesting makes the baby, keeping like an in utero surrounding that helps them for the gentle care. You use all stickings, There are different stickings we use for the fixation of the ET tube, for the fixation of the cannulas, for the fixation of temperature probes. So there are different times we do change that places. So we need to be very careful in terms of our standardized practices. So it is good to have a one common way of fixing tubes. Otherwise, some people fix currently 2 parts, some people fix into using the 3-part stickings. So if it's a standardized practice, then it becomes easy for the NICU people to practice. And it is good idea to keep a card that mention the depth of insertion of the ET tube, the depth of insertion of the orogastric tube. So by chance, if it is out, then you may not have to go back again and see what has been done, or you don't have to do an X-ray just for confirming the position of the ET tube. In a situation where baby is stable, you have put the tube in place at the previously measured length, then you don't have to go for a repeated radiation exposure also for these babies. You need to be very careful when you are handling the babies on ventilator. If you are doing suction, if you are doing changing of the positions, there are high chances of extubation, and these chances of extubations are higher if the baby is on a ventilator for a longer time. So that tells us that better to do a shorter time of ventilation than a prolonged ventilation with repeated chances of failure. In fact, I many times tell to our doctors that if baby is getting extubated, that means baby doesn't need ventilator. That baby is telling, and we need to keep in mind, and we need to think of non-invasive way of ventilation. So there are different ways of fixation. This is what I used to get earlier in UK. This is new fix, which is again very quick, easier way of fixation. The chances of dislodgement of tube is very less. Now I have given stickings to all of you. I want you to remove the sticking which is put on your wrist. They are still there. Many have already removed because it was not very comfortable for them. So how is that? It is painful. It pulls the hairs. So we need to be very careful when we are putting any stickies on the babies. There are stickies which will be more comfortable for them to remove. So there are alcohol-free plastic polymer stickings are there. Cavelon or Tegadum is also there. We need to be careful when we are removing it, because if you remove in a direction parallel to the skin, then the chances of pain and discomfort will be less. It is good idea to use a wet cotton or gauze when you are removing, so that the friction part, the sticking part is taken care of when you are removing the stickings. So alcohol swabs are also very helpful in that situation. Particularly in the preterm babies, we can use hydroadhesive gels, silicone tapes and Durapore, which are better options. Tegadums are good to put in, but it is sometimes difficult to remove. When you are trying to bring it out, it is really a difficult task. So next comes for a baby who is on ventilator, how we are taking care of the gases that we are giving to them. So if you see, we need to have filters at the ventilators so that there is no contamination of gases, and that contamination gases causes infection to the babies. Then the ET tube bypasses the initial airways, which warms and humidifies the air that we are breathing in. So we need to humidify this air that we are giving to the baby. This will help to prevent the secretions getting accumulated, secretions getting thick and crusted, which is going to be more problematic for a baby who was on a ventilator for a longer time. So for this purpose, we use heated, humidified gases, and they are all servo-control gases. You must have seen this. So if you give a properly heated, humidified gases, the chance of infection, the consequences of morbidities and mortalities in these babies decreases significantly. And there are sensors, they are connected to the proximal end and distal end, that senses the temperature, and accordingly the humidifier adjusts the temperature as per the requirement. Now many a times what happens, the distal center is under the warmer, and then that senses the temperature of the warmer, and that decreases the amount of humidified air that is coming, the hot air that is coming, that decreases. So we need to be careful that this distal sensor should not be below the warmer. We can use some extension tubing so that the distal sensor is not in the area of warmer. There are different circuits where there are heated wire. So this prevents the accumulation of droplets of water inside, because these droplets of water which are there for a longer time increases the risk of infection for these babies. So it is good idea to have a heated, humidified wire in the corrugated tube as well. So I have asked you to take some lozenges and see how many times you are swallowing. Or while we are sitting here without anything in the mouth, also we do get some, and then we do get some secretions, and we tend to swallow that secretions. So how many times you have done that? Can you recollect since last maybe like 3 hours since the time we are here? Anyone? How frequently you must have done that? So can you imagine a baby having ET tube in place, which is quite irritating? So the secretions in the oral cavity, the secretions in the tube will contribute a lot for the disturbance to the baby. So we need to be very careful when we are going to do suction. The oral hygiene has to be maintained very well. We did some evaluation in terms of applying mother's milk in the oral cavities for the preterm babies. So that is also very helpful. That promotes the normal flora and decreases the chances of sepsis for these babies. So when we are doing suction, we need to keep in mind how frequently we are going to do. How frequently you do suction? 4 hourly? As and when needed. Any other answers? So suction, the purpose of suction is to bring out the secretions. If you feel the baby is getting irritated, you feel there are secretions are there, on auscultation there is wetness of sound is there, or you feel there is fluctuations in the saturation because of that secretions, in that situations we should think of doing suction. It is as and when needed, not as a ritual that nursing shift happened, the suction has to be done. It is not like that. The moment we disconnect the baby from the ventilator, the settings, what we are delivering in terms of your PEEP and PIP, for a high frequency ventilator, it is more challenging to re-expand the lung, to recruit the lungs. So we need to be very careful when we are thinking of doing suction for these babies. And when we are doing suction, you need to be very careful again in terms of the depth of insertion, the pressure that we are giving. You need to be quick enough to go inside and come outside without causing significant problems in the vital parameters of the baby. This is something called as an inline suction that also helps a lot to prevent this problem in terms of the fluctuations in the saturations and the fluctuations in the equipment delivery that is happening to the babies. If you don't do regular suction, you can cause atelectic trauma and all the other complications. If you are doing a prolonged suction, it increases the risk of hypoxia to the babies because you connect, disconnect, can contribute for variations in the blood pressures, and in preterm babies particularly, you are increasing the risk of IVH for these babies. So suctioning, as I told, frequency of suction, depth of suction. Many people tend to put saline as again a routine habit, like before suction put some drops of saline and then do suction, may not be required. Because that again increases the risk of infections. And then if secretions are thin, we don't have to do a regular suction with the help of saline instillation beforehand. And it is a sterile procedure. People rush for the suction just like that, but you should be keeping in mind that you are handling the airways, and whatever you are doing to handle the airways, it can go and contribute for your VAP. So it's a sterile procedure where two people helping each other with a sterile gloves has to be in place. So prevention of the VAP is the most important. So the best strategy is no ventilation to prevent the VAP, isn't it? Rather than ventilation and doing problems, you need to do a regular oral hygiene as well as the ET section based on the frequency of secretions that we are getting. A head-up position also naturally helps to drain up the secretions they are coming, and we need to have a additional factor of application of mother's milk in the oral cavity that also helps to decrease the chances of sepsis for these babies on ventilator. Preventing connections and reconnections. Maintain separate ET and oral catheter. That is another important parameters. Many places we see that same catheter is used for same ET as well as oral suction. So better to have a separate catheters. And once you use the catheter, ideally you are supposed to dispose it off. And next time when you are using, you should get another catheter. So what about the positional changes that you have done so far? Right side, left side, center, standing up? Many times, can't count. So what about a baby? So this is the data where they are trying to analyze different postures for the baby, and prone positioning was found to be helpful. If you see the babies in a prone position, they are more comforted. In fact, COVID has again taught us about something about the prone ventilation. So that has also helped us that there is evidence that supports that prone positioning does help for the ventilation as well as preventing the frequent desaturation for these babies. So we have to change the positions regularly. You have changed positions how many times so far that we don't recollect immediately, but you have done it indirectly, right side, left side, center. But for babies, we need to do it because they are dependent on us. Otherwise, you land into pressure source and all the problems. Particularly babies who are on a significant support where we are giving sedation, paralysis, these babies are again totally dependent on us. So we need to take care of their skin. So positional changes, giving a nesting, placing, when you are doing a prone position, you should give some roller support at the hip so that the abduction of the hip is prevented. And again in the prone position, you should give support at the soles also so that the proper posture is maintained. Otherwise, these babies tend to land into subsequent contractures and all the problems. So swaddling does makes them comfortable. If you are giving a positional changes, if the baby is on a prone position, making it supine, you need to look at the pressure points. They tend to get erythematous, they tend to get firm at different places, so you can do a gentle skin massage to improve the circulation of the skin there. So there is something called as the physiotherapy that we do, not in all babies, particularly babies who are requiring some support on a ventilator, where there is underlying lung issues like a collapse is there, consolidation is there. So in that situation, we need to do a gentle physiotherapy. There are different ways. There are palm cups are there. There are some vibrators also that also helps to open up the lungs. So these are one of the types of the masks that they are used particularly for improving the chest expansion of the babies and doing a proper chest physiotherapy for these babies. So pressure ulcers and skin breakdowns are well-known entities in the babies, particularly in preterm babies or term babies who are on a prolonged ventilatory support like high-frequency ventilation or ECMOs. Paralysis and sedation increases the risk of, again, skin problems because babies' spontaneous movements are decreased. So we should use gel mattresses, regular postural changes, and skin massages. So you have put another sticker, another Dynaplast on your fingers. You are allowed to remove that. So how is their finger now? So there is a lot of discomfort. So we can imagine that we are putting the pulse oximeter nicely at one place for a good time. BP cuff is there, every 2 hourly BP cuff is tightening, relaxing, or sometimes in bad babies maybe 1 hourly, and that is causing so much of compromise about the local circulations. So this is what we did a audit cycle in a place where I was doing a mentoring the NICU. So there we used to get these pulse ox burns, you can see. So these are burns there because the baby's pulse oximeter position is not changed on a regular basis. So either we can put some barrier at these places, or we make a habit that we change the pulse ox position on a regular basis per shift so that these burns are prevented. So babies are on the ventilator because they have got a hypoxia, or they have got a CO2 retention, or they are having some underlying lung issues like pneumonias and all that things. So to try to decrease the oxygen, that is our primary thing. So we should look at the contributing factor, whether it is the disease or the other additional factors which are contributing for this hypoxemia. So if the baby is having temperature instabilities, pain and discomfort, that also is going to contribute for this. So these are the babies where we should think of giving sedation and paralysis. Clumping of the activity is another thing which is very important. As I said, we tend to handle babies for blood sugars, for changing nappies, or maybe for collections. So all that things has to be clumped together so that the disturbance is minimal for the babies. Sedation, analgesia, and paralysis. How many of you use sedation? So what are the indications for giving sedation and paralysis? Do you sedate all preterm babies when you? No. So nowadays we do very minimal ventilation for preterm babies. So it should not be a routine practice that the moment we intubate the babies or ventilate the babies, we should not give any sedation. Sedation is required primarily for bigger babies, term babies, like a meconium aspiration or perinatal asphyxias, or a baby who is on higher support like a high frequency nitric oxide and ECMO, these are the babies who require sedation and paralysis. Otherwise, there is no need of routine sedation and paralysis. So medications that we use is fentanyl and morphine, and dexmedetomidine is one more which is coming in the neonatal ICUs as well, along with the pediatric and adult ICUs. So when you are using these sedative medicines, we need to be careful to look at the parameters, because most of them, they do cause hypotension. So you need to be diligent when you are giving fentanyl. Particularly if you give fentanyl as a push, as a bolus, you can cause chest rigidity, and that can compromise the ventilation also. So you need to be careful. Look at the blood pressures when you use these sedative medicines. And analgesia like midazolam and lorazepam. So we need to understand this difference between sedation and analgesia. So fentanyl does help for both purposes, as well as dexmed also does help. But if baby is still showing signs, symptoms of pain on your pain score, you should think of adding on midazolam or lorazepam as a boluses or as a continuous infusion. Paralysis, we don't do paralysis on a routine basis or frequently, but for a baby who is again a full-term baby who is struggling to get intubated, before intubation we can use as a paralyzing agent along with the atropine and midazolam. Or if baby is fighting on the ventilator during the process of ventilation, in that situation also, for a short term you can use paralysis. But again, when we are paralyzing the babies, they can go for certain hypotension as well as certain hypoxemia, because the spontaneous drive we are taking away from them. So we need to be ready with the ventilatory support that we are giving. So dosages, I may not go into the details of the dosages. So there in RCT there is noted that there is no benefit with continuous infusion of all this for preterm babies in particular. So we should not go for a routine preterm babies with sedation and paralysis. And if required, we can use the intermittent bolus dosages of the fentanyl or morphine. So prevention of iatrogenic injuries, we should take care of the IV sites and infusion, because extravasation can contribute to more problems than the help of IV fluids that we are going to give. The errors in the calculation of fluid and electrolytes, particularly electrolytes like KCl and calcium, we need to be careful. We need to monitor the underlying heart rate. So we need to be ready for sudden events. What are the commonest difficulties that we face? A baby on a ventilator and then suddenly there is deterioration. So what are the parameters that we will be looking for? What is that? Displaced tube, obstructed tube, pneumothorax, equipment failure. So the sequence is important. It is not that equipment failure is the first thing. It is again based on the observations. That is, the tube is displaced. That is the first thing that we should look for. Like second is obstruction of the tube. You need to look at the chest rise. See if chest rise is not good on both sides. On auscultation, air entry is not there. So either tube is displaced or obstructed. So we should think of either changing the tube or doing the suction. Pneumothorax is again very common condition, particularly when we are doing overzealous ventilation for a term babies or even for a preterm babies. In that case, we should look at the chest rise and air entry, and X-ray or a bedside transillumination test will be helpful. In all these situations, we should have a backup plan ready. So we should have a bedside bag and mask. It is good to have a measured PIP and PEEP with the help of an equipment like a NeoPuff, where we know how much pressures we are giving. So that has to be ready. And the intubation in terms of ET tube, laryngoscope, all these things has to be ready. Otherwise, it should not happen that baby is extubated and we are rushing and running away from the things. There should be strict aseptic precautions. Hand washing is the most parameter that we have seen, whether we are touching the baby, whether we are putting cannulation, doing blood collections. So I always tell that cannulation is as strict procedure as we are doing a central line insertion, because we do cannulation more frequently than the central line insertion, and that is the commonest cause of infection that we see. There should be adequate spacing with no overcrowding. No stock solution, prepare IV fluids under laminar flow so that the risk of infection contamination is decreased. And whenever you are taking rounds, we should think, does this baby require ventilation? Does this baby require central lines? Can this baby be started on the feeds as soon as possible? So these are the things that we should think whenever we are taking rounds. Transfusion is another thing which is very important, particularly for the babies who are all these on ventilator, sick babies. So there should be unit-wise guidelines to when to think of transfusion for these babies. So based on your hematocrit and based on day of life, the intensity of support that we are requiring, based on that we can decide when to think of giving transfusion for the babies. So baby who is on ventilatory support, oxygen requirement is more than 30% or hematocrit of less than 40, who is less than a month old, in that case we should think of transfusion for these babies. And same, if the baby is more than 28 days, up to hematocrit up to less than 30 is also acceptable, because there is a physiological drop in the hemoglobin that we see in all term as well as the preterm babies. And babies who are on CPAP, if they are requiring oxygen, any amount of oxygen with hematocrit of less than 30, in that case we should think of transfusion. And babies more than 28 days, hematocrit of less than 25, we should think of transfusion. And the most important and the best analgesia, anesthesia that we find in the NICU setting is involving the parents in the care of the baby. So this is a baby who is on ventilator, who is getting kangaroo mother care. This will make the baby most comfortable than your sedation and paralysis and everything else. So make sure family is involved while we are doing all these things, because there are so many complexities that we are handling with the babies. If the parents are not involved, then they will say like, we don't know what is happening with the baby. So try to explain, try to involve them, encourage parents. We allow mother and father both in the NICU setting, ask them to let them touch the baby, provide skin to skin contact, let the mother handle and try to communicate with the baby. We do put express milk surrounding the baby so that they do get the smell of the EBM as well in difficult situation like babies on a prolonged ventilation. Provide appropriate audiovisual stimulations, assist family for bonding with the baby, and preparing for the discharge and follow-up by the time the baby is in the NICU setting is also very important, because these are the babies who require screening for hearing, screening for your eyes, and neurosonography and developmental assessment. So all these things should be in place before we plan to send them home. So these are the questions that I want you to take home rather than just the theoretical content that we are discussing. So the room temperature, the sound system, the stickings that we are using for the babies, the secretions that we can see need to be taken care of, need to change their positions regularly. And finally, it is a teamwork where the nurses play a vital role than doctors. I will say we do go to the NICU setting morning, evening, or the resident is there round the clock, but may not be beside the babies. But the nurses who are there round the clock beside the babies, managing babies, so we need to make sure that they are involved into the care and communication with the parents. So by this time, I'm sure all of your brain is filled up with so many things. There is one session which is left or still on high frequency and inhaled nitric oxide, but with the restraint of time and the given scenario, I think we will break for the lunch because everyone is looking hungry to me. And then after lunch, either we'll go for the station based on availability of Dr. Sanjay Ahir, or we'll go for the stations. So stations, there will be 2 stations in this room, and there will be 2 stations at second floor. So all of you have been divided into batches. If you see your folders, there are color codes are there. So there's a yellow team is there. How many are there in the yellow team? So yellow team will stay back in this room. Then second is there's a green team. Yellow is then green will again stay back in this. Which one you have got? Green team again will stay back in the same room. So there will be 2 stations, and rest 2 teams after the lunch will come with us to second floor. That we will guide. We will be there with you. Yes. Any doubts or questions or anything to be clarified? So we'll break for lunch for half hour, and then we'll start with our session. So 2 teams who are going to stay back. First team is station 1, second team is station 2, which is on ECMO, and rest 2 teams will come upstairs with us at second floor. Thank you very much. What is the analysis machine which is okay? So, what is high frequency ventilation? I want you to reply rather than just a one-way communication. Yes. What is high frequency ventilation?
Rate is more with less tidal volume.
Higher rate with less tidal volume. Anything else?
Tidal volumes are in the range of 1 to 2 ml per kg, and frequency is in hertz, like 1 hertz equal to 60, so in the range of 9 to 10 hertz depending upon the weight of the child. And like for ventilation and oxygenation, there are two separate phenomena in
Yes. Yes.
So ventilation, CO2 removal is controlled by hertz and amplitude, and oxygenation is controlled by MAP and FiO2.
Yes. What else? There's one more thing which is very important. In a conventional ventilation,
Expiration is active.
yes. See, when we are doing inspiration and expiration, it's a natural process for us. When the baby is on a ventilator, the inspiration is active process. Expiration is still happening by who is doing expiration? Lung coil, the elastic capacity of the lung, and simultaneously you need to have muscles also. But lung recoil has got some limitation. We have to do the expiratory efforts. Then only the CO2 is going to wash out. But here, inspiration and expiration both are active processes. That is one thing. Second, in a conventional ventilation, your oxygenation and your CO2 removal, they go parallelly. But here we have got different parameters for improving your oxygenation and improving your CO2 washout. So what are the parameters which are going to be helpful for oxygenation first? FiO2, that everyone knows. What is another parameter? Mean airway pressure. So there, when we are setting PIP and PWP, that decides our mean airway pressure. But here there is no PWP or PIP. It's a combination of both, which is MAP. Do you know how to calculate MAP, mean airway pressures?
Minute 1 minute.
So there is a component of PIP, PWP, your minute volume. So all these parameters impact your MAP, and that is what the area under the curve. You remember the graph which is shown. So that MAP is set directly on a high frequency ventilation. That is one. And then second thing which is important, like when we think of high frequency ventilator, and then we will decide what are the settings which are required for high frequency. So oxygenation, FiO2 and MAP, and for CO2 what is required? Rate and amplitude. So rate also, this is inverse the relation of the CO2 and rate. If you increase the rate, what will happen? If you increase the rates in a high frequency ventilation, it will cause CO2 retention. So this we need to play in our mind. There is no direct relationship like a conventional ventilator and a high frequency ventilation. In a conventional, you want to remove the CO2, you make the baby breathe fast. But here, if you want to wash out the CO2, you have to decrease the rate. Is it clear? This is very important. Otherwise, you will get confused with conventional and high frequency. So there is an inverse relation between your CO2 washout and rate of ventilation. Clear? So, and what is the other parameter for CO2 washout? Amplitude. So amplitude is what we can see on the baby is the wiggle, what we say wiggle. So that is the vibration of the chest. And how much amplitude do you want to set? That I will come in the next part maybe. So that is about the basics about the conventional ventilation and high frequency ventilation. Oxygenation by MAP and FiO2, CO2 washout by your amplitude, So what is that bad?
Airflix.
What is that bad ABG?
pH less than 7.2
Okay.
and PCO2 more than 60, PO2 less than 50 still.
Yes. So your parameters on the gas. So now based on this value what we are telling, we calculate what? OI. So that parameter is important. So you have set your maximum settings. Your FiO2 is 100%. PIP you have gone up to 25 and PEEP is already like 6-7 based on the underlying problem. And you do a blood gas. Clinically in saturation but with a high settings. It's not that just maintaining saturation. What settings are there on the ventilator, that is more important than just just the saturation that we are getting. So we need to calculate your oxygenation index. So what is the formula for oxygenation index?
Mean area pressure FiO2 divided by PO.
That's it. Into 100. Do you know saturation index? Oxygenation index is this. What is saturation index?
Mean area pressure into saturation divided by PO2.
Yes. So it's not necessary that you need a ABG. See, many places don't have a bedside ABGs or maybe a nearby lab having a ABG facility. So with your pulse oximeter available, we can get a saturation index and we can add maybe like a 10. There's a difference of almost 10 between the OI and saturation index. And that will also give us an idea when to think of high frequency ventilation. So what are the oxygenation index that you will be looking for before you think of high frequency? What OI you will be looking for? You have got an ABG machine. When you will think of high frequency ventilation.
More than 30 OI.
More than 30 OI.
Less than 100%.
So more than 30, more than
16.
more than 15. More than 15. Okay. So see what we have seen in the presentation also, the OI what has been calculated for all these indications is before these advanced modes of ventilation. So OI of 30 used to be going for a ECMO. So that is not ideally 30, it should be 10 less than that. So same for high frequency also. If you are touching OI of more than 10, you should be alarmed. See, earlier you intervene, better is the outcome. It's not that you are gone and then you are doing the rest of things. That doesn't make sense. So before the body decompensates, we have to do intervention. So OI of more than 10, you should get alarm. Now I need to think of something more. For a baby who is more than 34 weeks, preterm babies, like again we need to be a bit skeptical for high frequency because many times they don't tolerate. There were centers where in preterm baby also they tried high frequency, but the outcome was not much difference in terms of the conventional or high frequency. And on the top there were chances of IVH in the preterm babies. So high frequency is not the first as a routine we use for preterm babies at many centers, but some centers they do based on their experiences. So your OI is more than 10. You are on the settings which you feel that they are appropriate for the baby, maximum for the baby. So that is the stage we should think of using the high frequency ventilation. Now the conventional ventilator settings which are there, they are guide for us to set on the high frequency ventilation. Okay. So now MAP on a conventional ventilation is around 10. So how much you will set on a high frequency? So we will add 1 to 2. Okay. Your FiO2 is already 100%. So there is no scope for increasing it further. It is already 100. If you are on a 60%, 70%, then you can still think of adding some 10% more than what you are giving on a conventional ventilation. So FiO2 is 100%. Then MAP and FiO2, these are the parameters which will be picking from the conventional ventilation, and the rest of the parameters will be decided by the gestational age of the baby. For a term baby and a preterm baby, we select different delta P's. The amplitude will be different for a term and preterm babies, because for a term baby generally we tend to select 10. The frequency should be around 10, and for a preterm baby we select the higher frequencies like 12 to 14, 10 to 12 for a term baby, and for preterm babies it is higher. Okay, because the CO2 washout happening fast in a preterm baby is going to cause a lot of difficulties. Both babies it is going to be difficult, but still you will be more sensitive in terms of the preterm babies because of their hemodynamic instabilities and IVH risk is there. Okay, so and then your chest vibrations that should be visible up to the umbilical lower, in fact lower part of the umbilicus. That much will be your approximate setting of the amplitude. Okay, so your rates are 10. So as a thumb rule, we try to keep amplitude almost 2 to 3 times of the rate. So that is like initial setting to get an idea. MAP is decided, FiO2 is decided. We have set the rate for a term baby 10. So approximately 30 will be to start with, and based on the vibrations, we are going to adjust the amplitude. Okay. So these are the 4 parameters. So now we will see the 4 parameters on the ventilator, and then we'll go for a case scenario. Dr. Prasanna will guide us on the case. Okay. So you can come. I have not come to this machine yet. This will do it in the second part of it. So we are just going to understand the high frequency first. So many of you have seen this ventilator. So this is a SLE 5000 with a conventional and high frequency mode. Both are in place. Up to 25 kg pediatric population also we can use. There is 6000 which is more than 25 also we can manage. So there are different mode settings are there. So if you see this, when you press at the mode, there are non-invasive CPAP and then CME, pressure ticket, pressure support, high frequency, SME, high frequency with CME. So this is like a hybrid mode of ventilation. HFOE plus CME combination is sometimes difficult. You know, it is difficult to do changes also based on the blood gases. So most of the times we use either the high frequency ventilation. So now I have selected high frequency ventilation. I have confirmed the mode. Now in this there is an option of inspiratory expiration IE ratio is there. So generally we select expiration as a prolonged, but here again as I said it's a active process of expiration. So we need to keep a track of your CO2 because once the baby is on high frequency, the gases changes very fast. The CO2 washout happens very fast. So we need to be careful. We don't want too much of CO2 washes. So if you press it and then adjust, we can go up to 1:2. Now the rate I was talking. So consider this as a term baby. So I'm going to keep it around 10. MAP, we must be somewhere around 12 to 15. So when I'm increasing the MAP, you can see the difference in the distending pressures. You can see this test lung. Now I'm increasing the MAP. Did you notice the difference? Okay. So this is your MAP, and now I am adjusting the delta P. Did you notice the difference of the vibrations? Is it clear? Now let me. Did you notice I have decreased the rate? You observe closely so that you will understand. So this is the baseline setting for a term baby that we can start. Obviously MAP is going to depend on your settings on the conventional ventilation. So I will keep somewhere around the rates of 10, MAP of 17, delta P of almost like a 2 to 3 times based on the chest vibration that we are getting. So these are the initial settings, and most of the times FiO2 is on a higher side. Okay. Any doubts about these settings? Now we have set the all values. After starting high frequency ventilation, we need to get a chest X-ray because the chances of overexpansion and overexpansion causing pneumothorax are very high once the baby is on high frequency ventilation. So we need to look at the X-ray to see the expansion of the lung is adequate. There is something called as a recruitment maneuver. where if the lung spaces are not all opened up, particularly in a situation like meconium and all that thing, where there is a patchy collapse consolidation is there, we can go up on the map to see at least like 8.5, 9 spaces of the like ribs are covered by the lungs. If there is flattening or more than 9 spaces, that means you are doing over ventilation in terms of you need to cut down on the map, the mean airway pressure, because mean airway pressure is going to be always there. Okay, so we monitoring on the high frequency. One is the X-ray, maybe an half or 45 minutes after getting, and then we should do a blood gas, looking at the oxygenation and looking at the CO2 washout, and both based on that we need to adjust the settings. Any doubts on the initial settings, starting the high frequency? So indication. So see, pressure is your mean airway pressure. Patient friendly. Okay. So I thought pressure friendly. Yes. So see here the tidal volume is very small. Okay. And in fact the synchronization many times it becomes difficult because your rates are exponentially high. Normal rate of 40 to 60 and here is like 600 plus. So most of the time these baby they do require some sedation, some paralysis, and commonly you use high frequency ventilation in the case of meconium or asphyxias, diaphragmatic hernias, which are most of the time they are big babies. So they tend to fight with the high frequency ventilation. Initially they do fight, and over a period of time they get settled. It's not that you need to have a higher doses of support of sedation and paralysis. Initially there will be struggle till the body get accustomed, and then they do get accustomed. We can directly think of extubation from high frequency also. So they do get accustomed because here the babies also will be doing some efforts and the ventilator will be on a minimal setting. Okay. Only in initial stages, yes, it is struggle because baby will also try to fight out against this ventilation. But still I will say they do adapt to this very well.
This is not physiological, it is so much high.
Yes, it is not physiological, but your tidal volume is less. See, most of the time what happens, your inspiration, expiration, that pressure changes causes more difficulties. And the
It can be from hot-blooded animals like dogs or they are breathing so much fast.
So fast, yes.
But they are not always breathing fast. They are panting sometimes and they will breathing regularly. The idea is that to maintain the minute ventilation. So because we are using the tidal volume so low, just below the dead space, that is why we are using, we have to maintain the ventilation of it. And that is the reason we have to use a high frequency to maintain the normal minute ventilation. And once if you taken care of all the requirements of the child, suppose if your need is 1,000 rupees and I am providing you 1,000 rupees per month, why will you work? Your need has been already satisfied. If my work, whatever I am required, has been taken care by a machine, why should I? Only thing that will lead to the fight for the baby is the putting a tube inside, because that is a discomfort. Rest, if you maintain the ABG and decrease whatever the pathology or pathology is taken care by this ventilator, the child will not may require a sedation just to overcome the discomfort because of the tubes or the pain. That is the only thing. Or sometimes they may try because of feeding. That can also be taken care by giving a RBs. So most of the time the sedation requirement gradually goes down. And we are doing already support. Yes, supporting the child. And we frequently use HFOs mainly in cases of severe meconium aspiration or in cases of severe PPHN, which is unresponsive to the maximum inotropic support or maximum medical management you have tried. And you have already reached to the peak of conventional ventilator. Here still you are unable to maintain the saturation in spite of giving 100% oxygen. So one of the reasons for PPHN is that every stimulus you do to the baby, there will be more. So how will you reduce the stimulus? The calming is disturbance, reducing the light. So here the child needs to be completely calmed down. All the sympathetic stimulus for the child has to be reduced, and that can only be achieved by sedating the child. So anyway you wanted to sedate the child and anesthesia both. So both will be served. They will be synergistically active.
So these are the indications what we are talking about. PaO2 of less than 60, PCO2 on a higher side 55, pH is compromised 7.2 and OI is more than 15. But as I said, this is again an earlier study, so we need to be alarmed when OI is going about 10. Okay? So we'll go for the case now.
Did you understand the physiological concept of HFO basically? So small tidal volume and with a high frequency. So what we called it as a minute ventilation is the frequency into the tidal volume. So here the tidal volume is so low and frequency has been raised up so that to match required minute ventilations. Why this machine came into picture? Because we wanted to avoid the volume trauma, barotrauma, lung injuries. That is why this machine came into picture. But when they started using for the premature child, because this is supposed to work very well for the lung conditions where there is a homogeneous problem like RDS or HMD of prematurity. But for prematurity, they tried to use it as a first line therapy and they failed because there was higher rate of neurologically bad outcomes because of IVH leukomalacias. They may be because of two reasons, because the active expiration was just extracting the CO2 from the blood, which causes vasoconstrictions in the brain and impairing the neurological or exceeding the neurological problems. And second is sometimes, most of the times, for pulmonary hypertension we were using nitric oxide and it causes platelet aggregation or disaggregation, platelet dysfunction, which can lead to bleeds. Then from they discontinued use as a primary mode and HFO has been considered as a rescue mode. So we are using it as a rescue mode usually, not as a primary mode of ventilation in any child. Even for meconium aspiration, we don't put them directly onto the HFO. They have to fulfill some specific criteria. How does a small tidal volume and frequency, how does a alveolar ventilation happens with such a small tidal volume? Most of the tidal volume must be disappearing into the trachea only. So how does that causes the ventilation? And how does that causes the gas exchange and the CO2 removal from the lung? So here the physiology comes into play because they were giving a MAP constant, mean airway pressure. That means there will be constant, that amount of pressure will be maintained throughout the airway and alveoli, just like a mean arterial pressure. Systolic will be different, diastolic will be different, but the mean will be there in every vessel. That is called as mean. So same mean airway pressure will be maintained, which is a constant descending pressure provided to the alveoli. And this is called as open lung strategy. And on that we are just giving the vibrations. This frequency, which is a vibrations. And the vibrations can be given in a small volume or can be given in a large volume. That is oscillations along the center. You are deviating above and deviating below the center. Or how much you are deviating above and below, that is the amplitude we see. That is the amplitude we are using. If you use small amplitude, then the V-gulls will be low. If you use high amplitude, then the V-gulls will be high. So those V-gulls will get travels into the airways, and there the physiology of this HFO is a Taylor dispersion, what we say, Taylor dispersion. So in the proximal airways there will be a pressure. directly air is going into the lungs. So the upper alveoli are directly distended because of pressure. But the lower airways will get oscillated and gas exchange will happen with this Taylor dispersion, laminar flow, and lastly alveoli will get diffusions. So because of Taylor dispersion, the flow of gas will be conical, like a pencil tip. So the main O2 and gas will go in a tapering fashion, and rest of the gas will come by the side of the airway. Okay, so one gas will be flowing inside, and rest of the gas is coming from the periphery of the airways outside. And this is the way the CO2 get washed out. And here it is just like a conventional ventilator. We use a valve in a conventional ventilator where flow is happening. When we want inspiration, we stop the valve. The flow will go inside. When we want expiration, we open the valve, the air will go outside. When the air is going in, there is a piston above. The piston will vibrate. And this will push the air inside at a specified rate. And this will create a vibration inside. So all this physiology will help in the gas exchange, CO2 removal and oxygenation. Oxygenation mainly happens because of open alveoli. So this is the basic physiology. Okay. Now Om has already told you about the ventilator setting.
The 3.8 kg full-term main child delivered to primary by LCS because of failure of progression and components of fetal distress and meconium stent Reichert. Baby didn't cry well at the time of birth, did require resuscitation. Apgars were 1 and 6 at 5 and 6 at 1 and 5 minutes, and then shifted to NICU for respiratory distress. So Downey score was 7, saturations were 70s, and baby was on a nasal prom. So what will be your next step?
Baby has a meconium stained amniotic fluid. Child is not vigorous when the baby cried. Child required resuscitation. So what are the guidelines of resuscitation of a non-vigorous child with meconium stain like her? Whether we should do endotracheal suction before initiating the resuscitation, or we should directly go for ventilation.
Guidelines are not different.
So what are they? Yes.
What are they?
They are not different. So what are they?
Initial suctioning, positioning, and then go for bag and mask.
So no need of tracheal suction. Tracheal suction is not required.
Only oral suction if there are mucus.
If required. Otherwise, yes, if required. Okay. So we have to ventilate. That is the first and foremost thing. So if airways, upper airways are clear, go directly for bag and mask ventilation, because by that time we don't have a tube in place, so we can go directly with bag and mask ventilation. So this baby was given a bag and mask ventilation, and then for respiratory distress, baby shifted. So what is Downey score? Yes, for a full-term baby.
So assess the respiratory distress.
Yes. What is difference between Silverman and Downey score? Preterm. The component wise, what is the difference? So there are chest retractions.
More of respiratory retractions and all are more focused on
There is no rate. If you see in Silverman, there is no rate. But in Downey's we have got rate, because physiologically preterm baby's rate is on a higher side. So baby who is breathing at 60 plus, you may not be able to label it at distress. But for a term baby who is breathing 60, then you will be careful to grade into the respiratory distress. So there we look more as the recessions and then synchronity of the respiratory movements. So here we look at the other signs of respiratory distress, not just the chest movement. It is the number of chest movement and other parameters. So that is the baseline difference. And then score of more than 7, saturation of 70. So what you will do?
Sometimes baby is only tachypneic without any chest sign. No signs of distress.
So that is,
metabolism.
yes, soft tachypnea sometimes we can say. Yes.
So RR is not single most right.
Exactly. So there are other parameters are also there.
For breathing rate.
Yes.
Silence is there, silence is there.
That is the objective for objective assessment. The somebody may interpret there is a mild respiratory distress, somebody may interpret no, it is a severe. So there has to have some objectivity. That is why the scores are being defined. So what will be the next plan of action for him? What kind of management would you like to do? Now this child definitely in a respiratory distress, child is hypoxic, okay, but child is breathing, not maintaining saturation. So whether you will put him on a CPAP, whether you will give high flow nasal cannula, whether you will give just oxygen or anything else, or intubate him and directly put on conventional ventilator, what should be the
We need respiratory support along with oxygen, not only
Correct.
oxygen.
So what kind of a respirator support?
First we can try the NIV.
Very good. So again, in this oxygen also, we should think of giving a measured oxygen, not just free flow oxygen. So free flow oxygen maybe 60%, 70%, 80%, we don't know. If you give a blended air and oxygen, we know how much is the oxygen requirement. If the oxygen requirement is just 25, you are still okay. Fine with 25%, some high flow I will observe and then decide. But oxygen requirement is 60%, you are not okay. So you have to give a measured oxygen. Okay, that is very important. So now, this is the X-ray of the baby.
So as Dinkar has said, we will try NIV. What NIV would you like to try? CPAP or high flow nasal cannula? So what are the guidelines for providing CPAP in a meconium aspiration child? Are there any recommendations that if there is a meconium aspiration, you can put the child on CPAP?
It's the first line of support.
We can use.
Always, even resuscitation algorithm tell you, if the child is in distress, providing a CPAP. So this child was taken on CPAP, 5 to 60%, PEEP of 7. Is it a correct or wrong?
PEEP is also
PEEP is high, FiO2 is also high. But what is what according to you, what should be the setting?
less than 30 up to 40 is
His saturation is only
40.
70%.
Yes.
If the requirement is more than 40, and still saturation is less, we will require more support.
Next.
Not just
No, this is what
Yes.
then the support is, no? More support.
Increases PEEP.
Escalate. But this is the initial. This
To
is
start
the
with,
initial.
this is the initial
Start.
setting. Yes. We need to start somewhere, you know. So this is the starting.
From here you have to
Ah.
take a
Yes.
call
Yes.
whether we should escalate or de-escalate according to the response. So
Yes.
ABG 7.20, PCO2 60, PO2 50, bicarb 15, saturation 84 in spite of giving this support. Now you can take a look. जैसे ये बोल रहे थे सर.
This is metabolic acidosis plus CO2 retention.
Means
This is a respiratory failure, type 2. Because there is CO2 retention.
CO2 is also there.
It needs invasive ventilation. As far as ABC is concerned.
correct. So this is
With failure of oxygenation, we can manage with NIV. Failure of ventilation, we have to go for invasive ventilation.
So there are what?
CO2 retention.
Both are there. There is compromise in the oxygenation as well as your ventilation.
Only oxygenation we can manage with NIV.
Right.
so this is the next exam. दिख रहा है अच्छा कि नहीं दिख रहा है?
Easily.
नहीं दिख रहा है.
So the next step has been taken. नहीं ठीक है. This there. This there. Visible है.
This is on CPAP. ठीक है? Oh sorry. किधर गया रे?
नहीं. Yes no?
Next. Back session. नाही मला वाटतं मागे.
This is the one.
हे इथं आहे. हां. हे त्यांचं कन्व्हेन्शनल व्हेंटिलेशनवर आलं ना तो.
So this we were at this place.
हां. So conventional ventilation first. So we'll put him on conventional ventilator. So on conventional ventilator, when the child is on a meconium aspiration syndrome, what kind of setting would you like to? Would you like to start with what kind of settings? So first you need to understand what you need to understand before ventilating the child.
There is a lot of air trapping.
That means we need to understand what is the lung pathology is. And according to that we need to adjust the setting. So for meconium aspiration it is a inhomogeneous disease. Somewhere there is a atelectasis, somewhere there is a overinflation. So here setting the child on ventilator, what precautions would you like to take? So what you are worried about in meconium aspiration syndrome while ventilating a child? We are worried about pneumothorax. The pneumothorax will happen because of overzealous ventilation and giving a high peak because we see a whiteout lung. And we try to increase the PIP, we try to increase the P pulse to open up the lung. And that inadvertently leads to some complications. And third thing is there is an added component of pulmonary hypertension. So whatever lung strategy we apply, most of the time it will not help to reduce the pulmonary pressures, and the hypoxia which is caused by pulmonary hypertension is not going to get corrected because of our conventional ventilatory strategies. So we try to chase the saturation and try to increase the ventilatory setting, and then that leads to a complication. So putting a right that is because it is a pre-ductal.
So no inspiratory time, that is also beneficial.
That can also be one of the strategy we can use.
Along with circulatory support, not only respiratory.
Yes, that is very important.
Mean arterial pressure we have to keep on higher side. Pulmonary dilators.
Yes.
Only respiratory support will not work.
So in the respiratory, it is important to open as much alveoli as possible. So he said about keeping the PEEP on lower side. So there is something called as an optimal PEEP to open up the lungs. So in that situation, we may have to do some lung recruitment maneuvers, which are more easier on a high frequency than on a conventional ventilation, because here we need to fiddle with two parameters, PIP and PWP, and both are going to be difficult to manipulate here because of the chances of ear trapping and then chances of pneumothorax. So map and recruitment maneuvers and adjustment of FiO2 is easier with a high frequency. That is another advantage of high frequency ventilation. Okay. So now if you see this, we have tried the CPAP, we have failed, we have gone to ventilation with a bag and with a ventilator and tube in place. Do you think surfactant will be helpful in these situations?
First we have to do the echo, sir. It is really PHNR or PAP.
No.
Sometimes it is
Where is the question of PPH? You have seen the X-ray here. The child has a meconium, child has a bad X-ray, child is desaturating.
Still functional echo will work.
Yeah,
that is good.
Functional echo will be always helpful. But will that solve the question of giving surfactant or not? Whether you will give surfactant in a meconium aspiration case.
We can give.
So effective in reducing surface tension.
Yes.
Because there is a relative deficiency of surfactant.
Yes.
There is not absolute, but there is a relative
deficiency because of the chemical immunities. Yes.
Of surfactant because of meconium. But question is again whether you will put directly the surfactant or you will give surfactant lavage. That is the question. And surfactant is again getting distributed in a non-ventilated and also in a over-distended alveoli. So that has got some problem again. So some people they do surfactant lavage by diluting the surfactant into saline and then they put and then again absorb suck it out, because that again suck out the meconium from inside. Some people they put surfactant, but at what parameter you will decide to do surfactant? Not in all meconium you do surfactant. So which is the case where you will think of surfactant, giving surfactant? Where there is a white where there is a good amount of meconium absorbed into the lung. So there is a major chunk of alveoli are being affected. But somewhere there is air, there is much amount of aeration is there, and patchy, there is aspirations. Then there is no role of giving surfactant in this, or the purpose will not be served. So here surfactant was given. Okay, and these are the settings: PIP of 20, PEEP of 5, rate of 35, FiO2 was 60%, I time 0.4. Okay, are you okay with this? Is this the correct setting, or you wanted to put something different? I time.
Can go up.
Then we can keep less of so that we should prolong the expiry date.
Now what should be the RR?
RR should be kept on higher side. Maybe the already getting fast.
Then when the child will exhale, if you keep a RR of higher side, there should be adequate time to exhale. Breathe 100 times. When will you exhale? The whole air will get trapped inside. So that should be blended properly, because we give 0.4 in 1 minute, 0.4 seconds. So you have to adjust your eye time and respiratory rate according to need to calculate how much is the alveolar ventilation happening, and according to the CO2 you need to set the parameters, either the rate, or you will want a PIP to be set for CO2 washout, or you want to reduce the eye time, because these are the three knobs you have to remove the CO2. Either you increase the PIP, or increase the respiratory rate, or decrease the eye time.
You can also change the eye ratio.
That is one is, yeah, that will 1:2 we should keep.
This is the next exercise. दिख रहा है क्या?
Yes.
Pneumothorax. So what will be the next plan of action? Putting ICD, that is okay. That is the first thing we will do.
FiO to 100%.
Why you want to keep FiO to 100%?
It will help in resolving pneumothorax. It will whatever nitrogen oxide is present, nitric oxide, it will help in resorption of that nitric oxide. So keeping FiO2 helps.
So which gas maintain the alveolar distension is a nitrogen. So majority of the fraction is a nitrogen. So giving 100% oxygen by nasal cannula for a long time, so the nitrogen will get displaced by your oxygen, and the distending pressure of alveoli will be lost. So there will be development of atelectasis after giving high flow of oxygen. So the nitrogen has to be maintained into the lung for the distension of alveoli. So giving 100% oxygen will displace the nitrogen which is present in the air, and so the pneumothorax will get absorbed. But the oxygen which is giving 100% should not be given for a longer time, because it is again harmful for the body because of reactive oxygen species. Then this is the second pneumothorax. So what will you do now? Will you continue with the conventional ventilator or think of something else?
Yes.
So which is the best ventilation for the pneumothorax? High frequency oscillator or high frequency jet ventilation? High frequency jet is better for pneumothorax, but we don't have it, so use whatever you have.
So in inhomogeneous lung problem, jet is better. And for homogeneous problem like RDS, oscillations are better.
So is there any other difference between jet and oscillator other
Functionality wise, both are same principles. In fact, I have not used any time jet ventilation. I have just used oscillatory ventilator only. So these are the indications that we have come up to the high frequency ventilation now. Now, these are our initial settings on conventional ventilation that we saw. When we are trying to keep on high frequency, we should try to give map to an amplitude based on the chest movement up to the umbilical area. And frequencies, as I said, around like 8 to 10 for the term babies and for a preterm baby on a higher side. And if it is initial 60%, then you increase by 10 or 20% and see the oxygen saturation.
What is the lower and upper limit of frequency in a ventilator? Sometimes it is below 5 also, and upper it is some 20, 22, 25. That is also available on a high frequency ventilator.
So this is our X-ray on the high frequency. So parameters to be kept track of. We discussed about the chest X-ray, around 8 to 9 posterior lips, and this already we have discussed.
How do you put this child on HFO ventilator? Now you have a HFO ventilator, you know the conventional ventilator settings. So what first thing you will do while putting the child on high frequency oscillatory ventilator? You have decided that I am using a high frequency oscillator ventilator. So what is the first thing you will do before connecting the child to high frequency oscillator ventilator? You need to put a snugly fitting endotracheal tube. What we people use the 3 number, 2.5, 3.5, which has a peritubular leak, which we can use for a pressure ventilator, where adjusting the pressure will reduce or accustom or adjust the leak, peritubular leak. Because if there is a large peritubular leak, you can use higher pressure to deliver a desired tidal volume without changing the tube. But here we are using a very small tidal volume, so you don't want to lose that also, because the whole purpose will be lost. So putting a snugly fitting tube, a large size tube, is very prerequisite before initiating on high frequency oscillator ventilator. So after putting the child on, doing the endotracheal tube intubations, you will put the child on oscillator. So map will be decided by what map you will start. At what map you will start? 2 to 3 centimeter above the conventional ventilator. But that is just arbitrarily derived equation, because the child was not maintaining on previous mean airway pressure. That is why it is decided to just try to give more map, 2 or 3 centimeter above the conventional. And the oscillation, as Om said, that there has to be a wiggles till the umbilicus. If you do high wiggles to the thighs, then it is really disturbing and it will wash out the CO2 rapidly. So washing out the CO2 rapidly will again disturb the cerebral blood flow and will have a problematic CNS circulations. So HFO, the wiggle has to be maintained till the umbilicus only. The frequency we usually don't fiddle with it. If the more smaller the child, higher should be the frequency. Bigger the child, lower should be the frequency. It should not be handled frequently. IE ratio 1:1, 1:2. Some ventilators they provide 1:3 also. The ideally speaking, IE ratio in HFO doesn't serve much purpose, because if you use 1:1, then the ventilator has to do much more work to remove the CO2, because inspiration and expiration is same, but has to deliver the same tidal volume and remove the same amount of CO2. So the piston will work more because it has got a very short time, and sometimes the piston sucks the air inside and the alveoli airways will get collapsed. So ventilating a B2 child with this is a very troublesome thing. IE ratio 1:1. So we use usually 1:2 or 1:3. normal conventional settings. And as he said, it is very easy to use for oxygenation different settings and for ventilation different settings. So that is the beauty for HFO. Where in conventional you handle one knob, the whole picture will be changed. CO2 again and oxygen again. But here for oxygenation is a different thing, CO2 is a different thing.
So again, different conditions where we can think of using high frequency. Commonest what we see is liponym aspiration. Then pulmonary hypertension could be primary or secondary. Diaphragmatic hernia, pulmonary hypertension, that is another common situation. And in certain situations like RDS also, where there is again problems with the air mix and all, then in that situation we can think of, and bronchopulmonary dysplasias, pulmonary hemorrhages, pneumonias, where again requirement of pressures is very high. So now we move to the next part. Now nitric oxide. So we are from conventional, we are going to high frequency ventilation. On high frequency we are on a good settings, but still the ventilation, oxygenation is not maintained. So here again we will look at the oxygenation index. So nitric oxide is used in pulmonary hypertension. It could be primary or secondary. Primary pulmonary hypertension is many times resistant to this nitric oxide, and even in situations like a secondary, because of the diaphragmatic hernia, if the lungs are quite contracted bad, then that also many times doesn't respond. So contraindications of nitric oxide, if there is some underlying cardiac issues are there, then again it may be not very rational. And even in the preterm babies less than 32 weeks, the evidence is not much supportive for use of nitric oxide. So before we go for initiation of nitric oxide, we use rule of 20. 20-20 everyone is aware of. But again, I will be cautious. If I am requiring more than 10, I thought of high frequency. More than 15, we will think of earlier nitric oxide rather than waiting to progress till 20. Okay, and then we start with initial dose of 20. So 20 ppm of nitric oxide, that is what we start. And there were some studies where they tried to use a higher dose, but again there was not much benefit was noted. In fact, there was problem in terms of your side effect profile, in terms of methemoglobinemia, so they are not used. And then what do we want after starting the nitric oxide is the improvement in the oxygenation. So within 20 minutes of starting nitric oxide, we should see difference in the oxygenation. Improvement should be at least 5 to 10% than the previous value. And there should be improved oxygenation and decrease in the oxygen requirement. There are two things are very important. That tells us that there is improvement in the pulmonary circulation is there. Okay, so this is the rule of 20, where OI of more than 20, starting with initial dose of 20 ppm, and you look at the PaO2. After PaO2, we should be seeing the difference of improvement in the oxygenation and decrease in the oxygen requirement. And echo is always good to do before we start the inhaled nitric oxide therapy.
Can we go for sildenafil before direct starting nitric oxide?
So again, the side effect profile, if you see nitric oxide and sildenafil.
Sildenafil is called as a poor means nitric oxide.
So nitric oxide side effects.
Going directly for nitric oxide.
No, side effect profile. Which is better? Nitric oxide side effect profile is better or sildenafil? No, we'll go for, see, cost is one factor, but benefits and risk, they are the one factor which comes upper than the cost.
Recent papers, they are supporting sildenafil rather than nitric oxide.
So I will.
This is more in critical care.
So I will say, if you look at the side effect profile of sildenafil, it is on a higher side in comparison to nitric oxide. Nitric oxide so far is time tested. So in a given
for that hypotension
yes,
and all this
yes.
while using the sildenafil.
So you are using inotropes for hypotension, which may not be required if you are on a nitric oxide.
That can be used. Sildenafil can be used, but again, where the hemodynamic monitoring is very important, when you use sildenafil. What sildenafil you will use, IV or oral? That
IV is better.
So
oral is safe, but both are safe.
Both are safe. But again, what we have seen that sildenafil, even if you give, ultimately most of the babies they land up on mental.
Chances of failure are
chances
more.
And second thing, hypotension.
Yes, exactly.
Hypotension.
That is a major.
Very difficult.
Yes.
And once the
That is
child
major
ends up in
challenge.
hypotension, again the saturations will be high, right to left shunting will be high, then lactate will increase and the cascade continues. So here the hemodynamic monitoring is very
First, as far as PPH is concerned, first we have to keep the MAP on higher side.
Yes.
So as to reduce the shunt right to left.
So the places of shunting are also very important. Your fluid balance is also very important. You shouldn't be hyper as well as hypo. And I was preparing nitric oxide because
on higher side as far as systemic pressures are concerned.
the systemic pressure is should be
To
on higher
reduce the
side.
shunt right to
Yes.
left.
So nitric oxide side profile, if you look at injectable sildenafil, if you see, there is a good differences there. So inhaled nitric is still safer, and if you have got the facility, then yes, no doubt you should go for nitric. If you don't have facility, then yes, whatever the options are available, we can think of sildenafil and other supportive measures like milrinone and everything, along with the addition of your inotropes, noradrenaline, vasopressin and all that things. Because we want to maintain a systemic pressure above the pulmonary pressure to improve the pulmonary circulation. That is the aim. And we should know, as I said, where are the places of shunting, how is the volume status, the TRZ, the functional echo will guide us in terms of what intervention we need to do.
PSAP is important.
Yes, pulmonary arterial.
Systolic arterial pressure.
So nitric oxide, you start with 20 ppm, and within 20 minutes to 30 minutes we get an idea there is a response is there or not there. If there is no response, then you should not continue for more than an hour. If there is no response, you should try to wean it off. If there is response is there, in that case we need to continue nitric oxide till you achieve saturation of 90 plus in the right periductal area, right upper limb, with FiO2 of less than 60%. So the FiO2 which was 100%, we want to bring down under the control of nitric oxide, which is acting as a pulmonary vasodilator. We come down on the FiO2 till 60%. That is the place where we feel that the nitric oxide is helping us, and then the next step that we are going to do is weaning off from the nitric oxide. So we'll see the nitric oxide circuit, and then we'll go from when you are giving nitric oxide. After 24 hours, we need to look at the methemoglobin levels, because methemoglobin is one thing. Second thing, many times we tend to miss, if someone, the particular nurses are pregnant, we need to be careful because we don't want them getting exposed to the nitric oxide. Third, nitric oxide is a corrosive agent. So if you are wearing contact lenses, it may be again damaging to your eyes. So you should not be exposed with contact lenses to the nitric oxide. These are the precautions which many a times we tend to miss in a rush, so that we need to be careful about. So methemoglobinemia, even though it is said in literature, but we have not seen any significant side effect like methemoglobinemia where we need to think of stopping nitric oxide for that reason. So nitric oxide is well tolerated by the babies. Now we have started with 20 ppm. Our oxygen saturation is maintained with FiO2 of less than 60%. That is the time when we should think of weaning from the nitric oxide. So how you are going to wean nitric oxide? What will be the steps? Say around 20, how much you will cut down? By 5. Say every 4 to 5 hours interval, you initially cut down by 5. When you cut down, you need to see the rebound pulmonary hypertension is happening or not. So how you will get an idea? One, saturation. Second, your oxygen requirement, and then if possible 2D echoes and blood gases. See, not every time we need to go for a ABG or echo. Clinical assessment is also enough. Echoes once in a day is enough for a baby with a pulmonary hypertension. Not every day, like every morning, afternoon, evening kind of thing. So clinical assessment will tell us whether the responsiveness of rebound hypertension is there or not. So you have decreased it to 15. Again after 3-4 hours, you can cut down by 5. You come down up to 5, and then parallelly from 60% we are trying to come down up to 40% of oxygen, FiO2, and keeping a track of your saturation index, which is a non-invasive way of monitoring, because these babies we don't want to fiddle a lot by handling them, by pricking them. So you should try to maintain a quiet surrounding with them with minimal handling to this baby. So saturation index is good enough. Your target saturation is 90 to 93, not 95 and above. So we don't want to give too much of oxygen, which is also going to cause more lung damage, over oxygenation causing lung injury. In fact, the pathology between the chronic lung disease is primarily because of this over oxygenation to these babies. So your saturations 91, 93 are maintained. You cut down on your FiO2 till 40%. So now we are on the 40% FiO2 with INO of 5. So from this point we need to be bit slow, because that is the time where we are planning to wean off the nitric oxide completely. So from 5 you don't come down to 1 directly, you decrease by 1 every 3 to 4 hourly, and again looking at your oxygen requirement, looking at your saturation. At any point if you feel your saturation is dropping more than 5% or oxygen requirement is increasing more than 10%, that means you need to step up further. From 4, if you have come down to 4, your requirements are going up, you increase your INO further to 5 and then wait for 3-4 hours for the baby to settle. So in this way, every 3 to 4 hourly we cut down the INO to 1, and once you are at 1, we expect by that time your FiO2 is also coming down from 40% to 30%, and then from that we can think of giving off complete off INO and see the baby's response. And if INO is, we are able to stop INO completely, then we can think of either going back to conventional ventilator, or from the high frequency itself we can cut down the MAP, because your oxygen requirement is like 25-30%. Your MAP we can come down to the baseline MAP of conventional, and if baby is comfortable on high frequency without much sedation, we can think of weaning off completely from this to either a non-invasive ventilation or a conventional ventilation. So now good part about these ventilators, like everything is in place with one equipment. So the same tubing we can use, we just need to change the mode of ventilation. If you are thinking of conventional, you just change the mode of ventilation, and then conventional you can go back immediately. From conventional, if baby is comfortable, again going back on a minimal settings, your MAP has come down, which was 10-15 earlier, it is coming down to 8-9. You can think of going back to the CPAP, because 8-9 PEEP, like we give 5-6 PEEP. So 8-9 is not much difference with a 25% FiO2. If baby's efforts of breathing are good, oxygen requirement is not much, we can think of switching to the non-invasive mode of ventilation. Now connection with this INO, those who have not seen, you can come forward. So this is their cylinder containing nitric oxide, and if you, this knob is very sensitive knob and very difficult to adjust. A little bit of change in this will cause a lot of variations into it. So you should know how to increase and decrease. There are marks are there. So this is the source of nitric oxide. This goes to the inspiratory limb, and then there is one more connection at this place. You can so there's one more connector that comes where we attach it. In fact, it is here. So this is going to sense how much is your nitric oxide which is getting delivered to the baby. So many times once you connect to nitric oxide, it may show that there is leakage of the fresh gases, because there are additional connections in the circuit now. So this is the nitric oxide going in, which is getting sensed at this place, and this will tell you how much is getting. So it initially value, if you see, it was somewhere around 5-6. So now it has automatically come down, and then what we want to set is 20 ppm to start with, and then we adjust and then see how much is going to get delivered to the baby with the help of this reading. Okay. If you see here, it does tell us how much is the oxygen we are giving. So it is some 21%. So here also we can reflect. So this gives a combination of things, nitric oxide and oxygen. So we are on a conventional, we are just on a ventilator is off. So nitric oxide we use most of the times with high frequency only. Conventional ventilation we don't use nitric oxide. Because there is a reason for using high frequency, then only there is a reason for going for a nitric oxide. Otherwise, if you are on a conventional ventilator, that means there is something wrong why you are going for a nitric oxide. Okay? Any doubts about the connections? Anyone wants to check the settings, the map and delta P and everything? So this is going to make an alarm because it's showing going to be continuous leak of the gases because of this addition of connections into it.
It will not compensate for the leak.
It will compensate, but it will alarm us at the same time. There is a high patient leak is there.
Usually the cylinder lasts how many hours?
So we use very minimal. On an average, if you are using on a continuous basis, at least 72 hours it lasts easily. Yes. Because the dose we use is hardly 20, going back down to less than 20.
And how long you can keep the baby with the iron?
So if you take the weaning time in total, around 36 to 48 hours is the time frame that you are out of this system. So यहाँ से ऑक्सीजन नाइट्रिक ऑक्साइड जाएगा, ये जाएगा ह्यूमिडिफायर पे इंस्पिरेट क्लीन की तरफ, है ना, और वहाँ से इधर जाएगा. ठीक है. हाँ, यस, बेबी का सेंटर कितना जा रहा है इसमें दिखेगा.
From humidifier, how it is going?
Humidifier के अंदर जाएगा, it gets humidified and then it will go to the inspiratory. Because see, this is fresh gases, so it is getting mixed in the fresh gases. From fresh gases go to the humidifier, get humidified, and then go to the inspiratory.
That tubing is just for sensing the concentration.
Yes, this is a sensor.
Inspiratory.
Yes, because this is what we want to deliver. This is what is expected, because here there is dilution of everything. Air, oxygen and nitric is also there. So it won't go inside the machine because it is in the inspiratory. See, this is the inflow of gases from the ventilator to the baby. So here at this place, so it will go down from here, and then from this inspiratory limit will go to the baby.
And this machine is only for sensing.
Yes, machine is going to tell us how much is getting delivered, how much ppm we are delivering to the baby. Okay.
Cost of this machine.
So if you see the 10 to 15, I think in total it will cost almost 10 to 15. There are newer machines which are again very easy to adjust in terms of this knob. They have got a digital analog scales now. You just press and then you set the values. With that knob, it is really many times difficult. A little bit of fluctuation is enough to cause significant change in the ion, in the ppm that you are delivering.
This is the problem with ionosis. You have to adjust.
Lot of stickers, yes.
Changes because of pressure also.
Yes. So now newer machines are coming which are relatively easy to adjust.
You need to maintain a continuous flow of gas. If the gas get interrupted, whole only nitric oxide will go.
Yes. So this will show. If only nitric is going, na, this will show immediately.
Whole endogenous synthesis of nitric oxide will be suppressed. So once you stop the nitric oxide, everything will create a problem. Severe hypoxia.
That is the reason you need to look for the methemoglobinemia as well as the pressure changes. Yes.
So whole continuous gas flow has to be maintained.
What is the treatment of methemoglobinemia? Just for knowledge purpose. Methylene blue. What else?
Vitamin C.
Vitamin C and dialysis in severe cases. Okay. So we'll stop here. Any doubts or any questions or any inputs?
कुछ पूछना है तो पूछ लो भाई इसमें.
हाँ नहीं इसमें नॉर्मी नहीं कुछ नहीं. 5,000 टी.
संजय येणार नाही आहे.
ठीक है. So we'll go to the next station then.
Can come and attach it if someone want to.
Not using, you come forward.
Yeah. Okay. And this is from ventilator to humidifier, in which no heated wire will be there. And second is this one is for inspiratory one, W1 is, which is from humidifier to patient, okay, in which heated wire will be there, okay, and this is a temperature sensor, okay. One temperature sensor, the distal one, the proximal one will be here, and distal one will be here, and this sensor should not be like this, because the whatever water is condensed over here, that will going to affect the reading over here, and this should be like this, okay. So water will not come in the contact, so it will not affect the reading, okay. Then this white one is directly going to the expiratory cassette, okay, and there is also one of the sensor, okay, and it is also contain the heated wire, and that will going to patient.
So important points which you heard from here, which you need practical points for your practice, is that the gases which are coming into your oxygen source is coming from either a jumbo cylinder or from a manifold which is many cylinders together. And it may be either automatic in some big hospitals like this. In smaller places, somebody has to manually turn on the cylinders. So the pressure coming in from behind is not equal for air and oxygen, then blender कुछ नहीं कर सकता. आप होटल में गए, गर्म पानी, ठंडा पानी, and आपका गर्म पानी आ ही नहीं रहा है. आप नहाने चले गए तो कैसे आएगा? ठंडा पानी बोलोगे तो आप जल जाओगे. So easily what is coming inside? Now what safety systems are there? All standard ventilators are having an alarm. If the pressure coming in from the air and oxygen is not same, it will show a alarm on that saying that oxygen source is giving less pressure. लेकिन लोग क्या करते हैं, वो म्यूट कर देते हैं, देखते हैं. Or it will say compressed air is giving less pressure. So that is very important to learn. There are ventilators which do not have a compressor of air at all. खाली ऑक्सीजन होगा, लेकिन वो compressor के बिना नहीं चलते. They have a turbine technology, small size compressor sitting inside the machine. So when you're buying that, you have to match it to your unit, and you need 2 oxygen points. Why? Not 1. If you want to hand bag the baby, 2 करना है तो कैसे करोगे? तो ये डिजाइनिंग के टाइम पे ये सब ध्यान रखना है. You need at least 2 oxygen points. You must pay attention. Your whole unit has to pay attention to these alarms. And there are some machines. If you buy a VIP bird machine, if the pressure difference between the gas, air, and oxygen is more than 5, it will just shut off. Safety इतना high है. It will not give. Machine ही बंद हो जाएगा. So you have to know that. And in the circuits, you may have either reusable circuits, which are 150 times you can also use. But you have to wash them fully and send for sterilization. You have to reconnect them. It's very tedious. उसके बाद में भी evaporates can be more. Disposable circuits are very expensive. 8,000-9,000 rupees लग जाते हैं एक patient. लेकिन it comes pre-packed. Nurses को कोई experience नहीं, तभी उठा के ऐसे लग जाते हैं. उसमें भी अलग-अलग quality के circuits हैं. These are circuits which are having heater wire inside both inspiratory and expiratory limb. Inspiratory is to save the patient. Expiratory is to save your machine. Machine भी तो बहुत महंगी है ना? And this is going back. Those don't have expiratory heater wire, they will have a water trap, so that water doesn't go to the machine. Humidifier is an autofill in good machines ना. Autofill में जैसे बाथरूम में आप फ्लश चलाते हो, वो बंद किया, उसके बाद पानी भरना शुरू हो जाता है, float will go up and more water will not come. But all of you may not be using it. Some of are manually filled still. वो लगा के भरना पड़ता है. Again infection rates will be high, and there will be times when the water is over and it will be dry. अंदर dry रहेगा. So it is worth investing on a autofill chambers, because an autofill chamber only. This PEEP valve will show you the cassette. When you buy a ventilator, insist on having 2. क्योंकि असली ventilator तो वही है, बाकी it is all electronics. The real ventilator is this. The PEEP valve, where it controls PEEP सब कुछ वहीं control होता है. Gases बाहर चले गए तो patient को नहीं जाएंगे, gases बाहर नहीं गए तो patient को जाएंगे. So this valve you have to have 2. अगर 2 नहीं होगा तो autoclave के कैसे भेजोगे? एक बच्चे के साथ ब्रश किया, वो दूसरे के बच्चे में मुंह लगा देंगे, नहीं लगाएंगे. So you have to take the PEEP valve and send it to autoclave. लेकिन उस टाइम पे एक और बच्चा आ गया तो कैसे करेंगे? So you have to have one spare expiratory valve, always purchased with 1 ventilator. So ventilator have you 2. ठीक है ना?
So before
blender is not reliable if pressures are not same.
It can't do its job. It is designed for
pressures must be same for optimal.
पीछे डायल होते हैं दोनों के लिए. आप देख सकते हो कितना प्रेशर आ रहा है. It shows
कितना मिलीबार प्रेशर है.
So pressure is mandatory for optimal good functioning of blender.
Otherwise you will not get, you will think you are getting certain FiO2 or certain pressure, you won't get the same.
There are two readings actually. We are setting the FiO2 and delivering the FiO2.
So it will show you it is getting less. And if you are buying a cheap ventilator, let us say 2 lakh rupees ventilator, they cannot give you so many sensors. So अगर वो अलग भी है तो चलता रहेगा.
Blender is like a venturi. It is not compressor. Compressor is different thing and blender is different. Blender means it is giving a desired amount of FiO2. Compressor means it is giving a compressed gas, volume, pressure and everything. So it is this gas is comprised the compressed gas. So if we do not have a compressed gas, and if you want to attach the cylinder which is not that compressible that much, or just like the things, so we need to have a separate compressor, like initially which were coming like they were doing awaj, they said. So blender is different thing and compressor is the different
Blender
thing.
is what mixes how much air and how much oxygen.
But I am asking whether the pressure should be same for good functioning of
Yeah. Pressure should be. That's what sir was. Yeah.
Pressure is low, one is high,
No.
blender
Yes.
is not reliable.
Especially if you are having a smaller hospital where big jumbo cylinders are connected and somebody has to turn it on.
Manual.
Yes.
Yeah.
Then you will have a problem. If it is a big manifold of 1000 cylinders and automatically it gives the pressure by open cylinders base, then there won't be a problem.
You need to maintain 4 kilopascal pressure over here.
So practically there is a pressure fluctuation.
Yes.
Yeah.
While changing the cylinder
Centralized things is less likely.
Larger manifold में नहीं है. In a big hospital like this, if you go to the basement, 1000 cylinders are connected and they are running a digital machine. It is sensing the pressure in the line.
Yeah.
अगर वो pressure drop हो गया तो automatically 4 हो.
So you can see outside there is a pressure gauge. Okay. उसमें dial होता है. You can see outside. So central line pressure we monitor from there. So it will give alarm if the pressure is dropped. Okay. Ventilator will also give alarm if pressure is dropped. Okay. So both two wall check technique we have. So generally it is monitored by biomedical persons. Okay. So this is a expiratory cassette. You can see a expiratory wall over here, and that need to be sterilized for each and every patient. So here the expiratory circuit will attach, and the inspiratory circuit toward the patient, which will denoted by this blue tubings. Okay.
Now you have to also know that there are two temperature sensors here, one here and one here.
Proximal and distal. Yeah.
This is very close to the patient. And there is no heater wire inside circuit after that. If it shows a display of 37 degrees here, it means that 39 is read here. आपको दिखाएगा 37. Because 2 degrees it knows it will drop further when it goes to the trachea. There is first heater which is here. That heater heats gases 50-60 डिग्री तक ले जाता है. लेकिन आपको रूम टेम्परेचर कितना है? 20 डिग्री, 25 डिग्री. तो ऑल द वाटर में कंडेंस होने लगे. वो कंडेंस नहीं होना चाहिए, उसके लिए एक और हीटर वायर है. तो जो ये पीछे देख रहे हैं, दिस इज जस्ट इलेक्ट्रिकल वायर, ये वाला. एंड वो व्हाइट वाले के लिए भी रहेगा एंड ब्लू वाले के लिए भी रहेगा, क्योंकि इस सर्किट में दोनों में वो है, इधर लगेगा इसका
सेंसर्स.
ये तो सिर्फ इलेक्ट्रिकल सर्किट है
सर.
लेकिन दिस इज ए प्लैटिनम टेम्परेचर सेंसर. ये ऑटोक्लेव के लिए नहीं बेच सकते, ईटीओ के लिए नहीं बेच सकते, खराब हो जाएगा. इसका टिप सिर्फ पाइप करना होता है.
Okay. So this all things should be sterile with a sterile gloves and everything. So if you are using this test lung also, that should get autoclaved, okay, for each and every patient. So there are chances that could directly infect the patient. Okay. Second thing, this is a humidifier. It has a separate wire. So there are two modes: invasive mode and non-invasive mode. There is a machine. If you switch on this, so there is invasive mode or non-invasive mode. According to that, we can set. Okay. So these are the brakes. If we are keeping ventilator in position, we need to apply brakes. So it should not get accidentally dislodge the tube and all. Okay. And that's all regarding
and
the
you
circuits.
also need to know how to clean the ventilator also. You cannot use anything but simple soap detergent, because all these surfaces will get spoiled if you use any of those aldehyde sprays on it. And these circuits, ETO if you do, remember ETO will never come back the same day. Minimum 1 day is required. एक दिन लगता है उसको करने में.
बिकॉज वो इतना महंगा होता है कि वो एक ही बार रखते हैं. बट इफ यू आर डूइंग हीट स्टरलाइजेशन 2-3 घंटे में आ जाएगा. इफ यू आर यूजिंग रीयूजेबल सर्किट देन कॉस्ट टू पेशेंट विल कम डाउन, क्योंकि वो 8,000 हर बार पेशेंट से लेने की जरूरत नहीं. वन सर्किट कैन लास्ट यू फॉर रेस्ट ऑफ द मे बी नेक्स्ट 10 years. बट द प्रॉब्लम इज वो सर्किट बहुत महंगा होता है. 60-70 हज़ार रुपये का अब नहीं 15 साल करेगा. एक नर्स ने कुछ ऐसा ही गलती से काट दिया, क्या करूँ क्या हो गया 1 लाख रुपये गई टाइम पे. प्लस वो वैप रेट्स इन्फेक्शन रेट बढ़ेगा उसमें, बिकॉज इस हाउ ओवर स्टेराइल यू बी देयर इज अ हाई रिस्क. प्लस यू स्पीड इसमें इनके बाद घुसाना पड़ता है. इसमें पहले से
So anything you want to ask about the circuit? So these circuit is use up to 20 kilos. After that the adult circuit will come in play. Okay, so up to 20 kilos we can use this circuit. Okay,
and the cost of circuits will go up based on whether heater wire is only in the insulating and or in both. And in the both also there are breathing circuits now. That means there are actually mild pores which will allow the humidity not to allow condensation. And this is also a second generation humidifier. अभी third generation आ गया. Third generation में condensation problems have come down even further, but they're expensive. But it is worth investing on a good humidifier, because your quickly patient coming out of ventilator will depend upon warm humidification.
Okay, anything in the circuit? Any doubt or something?
Humidity, one fact you need to know, which is a little theoretical but practically important, what is called as relative humidity. At a given temperature, let us say in this room, if this temperature it can hold 4 liters of water without condensation. So what will happen if there is only 3? Then this air is hungry and it will take water from all of us. So if the air which is going to the patient has condensed before, then what goes to inside the trachea is hungry and it will desiccate all the mucosa. आपका वेंटिलेटर से पेशेंट निकलेगा भी नहीं एंड उसको वैप भी होता रहेगा क्रैकिंग की वजह से. एंड दैट इज व्हाई दिस ह्यूमिडिफिकेशन के ऊपर इन्वेस्टमेंट इज वेरी वर्थ. सो बाइंग ए गुड ह्यूमिडिफायर इज लाइक becoming a magician ventilator person. It can make such a huge difference in extubating a baby.
That will cause the drying of secretion, discomfort.
क्योंकि आपने तो गर्म करके वहाँ अंदर भेजना था, तो बाहर निकलने को अंदर क्या जाएगा? There are many problems technology is still facing with this condensation problem.
सर जो रेस्पिरेटरी ट्यूबिंग जो है छोटी सामने वाली, सेंसर के बाहर है.
ये
लगाते हुए उसको डायरेक्ट बाहर
पेशेंट है
ये यहाँ पे डायरेक्टली बोल रहा है.
पेशेंट है जो प्रॉक्सिमल टेम्परेचर सेंसर है ना.
हाँ, ये डायरेक्टली इधर लगाए तो सर वही बोल रहे हैं ना, वो 39 डिग्री पे आता है यहाँ होके. और
आप सही कह रहे हो. हाँ, क्योंकि उस पार्ट में हीटर वायर
नहीं है इसलिए.
लेकिन वो इसलिए रखा हुआ है कि वो मशीन इज डिजाइंड फॉर द 2 डिग्री फॉल. जो फर्स्ट जनरेशन, मैंने आपको सेकंड और थर्ड बताया, हम लोग ने तो फर्स्ट जनरेशन में भी काम किया 2000 में. उसमें क्या होता था कि 2 नॉब्स होते थे यहाँ पे, सम ऑफ यू माइट हैव सीन इट ह्यूमिडिफायर. एंड वो सेकंड नॉब वाज डिजाइंड कि कितना टेम्परेचर ड्रॉप होना चाहिए. तो अगर वो सर्किट ड्रॉप कर दी यू विल डायल 0. अगर वो 2 डिग्री है तो
सबसे ज़्यादा कंडेंसेशन यही होता है, बिकॉज हीटिंग वायर है ही नहीं. यहाँ तक 39 होता है और जो पेशेंट को जाता है 37 होता है, तो इसलिए.
हाँ, वो क्यों लगाते हैं आपको बताने वाला था. कुछ मशीन्स में प्रेशर लाइन होती है, वो प्रेशर लाइन जो जाती है वो वाईपीस के पास आके जुड़ती है एंड उसी से आपका पीप एंड अलार्म्स मेजर होते हैं. जैसे आप ड्रैगर में जाएंगे तो ड्रैगर में कोई प्रेशर लाइन नहीं होती, because they are measuring the pressure inside based on mathematical calculations and that depends on the length of the circuit जो pre-designed है. तो अगर आपने लेंथ बढ़ा दिया या घटा दिया तो वो कैलकुलेशन ठीक नहीं आएगा. समझ गए सर. तो ड्रैगर में तो यू कैन नॉट, जिस मशीन में प्रेशर लाइन है अलग से उसमें फर्क नहीं पड़ेगा, लेकिन जिसके बाद प्रेशर लाइन नहीं है इट इज अ मैथमेटिकली कैलकुलेट प्रेशर इनसाइड बेस्ड ऑन द लेंथ ऑफ द सर्किट. सो इंस्पिरेटेड एक्सपिरेटेड लेंथ जो पहले डिफाइन किया उतना ही होना चाहिए.
तो बिफोर दैट वी डू द पेशेंट सर्किट टेस्ट ना.
आपने देखा होगा प्रेशर लाइन. आप कौन से वेंटिलेटर पे काम करते हैं? इसमें तो इसमें प्रेशर लाइन आता है. ओनली ड्रैगर कम्स विदाउट अ प्रेशर लाइन. बाकी सब में एक प्रेशर लाइन होता है एंड वो प्रेशर लाइन के अंदर वाटर ड्रॉप नहीं होना चाहिए. बहुत केयरफुल होना है, क्योंकि अगर वाटर होगी तो प्रेशर नहीं करेगा. आप घर बनाते हैं ऐसे प्रेशर लाइन से बनाते हैं ना, वो सारा का सारा एयर कंटिन्यूस होना चाहिए. वो अगर उसमें एक ड्रॉप आ गया तो सारा जाएगा.
ठीक है.
एक्सपिरेटरी लिंक के अंदर हम लोग फिल्टर लगाते हैं एचएमई, वी डोंट हैव टू चेंज द कैसेट्स.
करेक्ट. इट इज मेंट फॉर प्रोटेक्टिंग होम. यू कैन थिंक protecting the
others.
Machine.
Yes.
Machine. So nowadays many people are not using filter for various reasons. That is, when the burst of gases come, it actually pushes more inside. So mostly now ventilators have become obsolete, most of them.
Sometimes we use a bacterial filter in pediatrics, so it is like huge one, with a 300-400 rupees ka tha white one. So we attach over here as an accessory. You can also use a HME, but sir ne bola ki HME is not a bacterial filter, okay? So
HME is a replacement for
humidifier, okay?
वो adult humidifier.
Yeah, हाँ. So bacterial filter आता है ऐसा, जिसमें serrations होते हैं. So after 5 to 7 days, we need to throw it out and again reattach with a new filter.
जो familiar नहीं है उनके लिए बोल रहा हूँ मैं. Heat, moisture,
Exchanger.
तो जब मैं बाहर ब्रीथ आउट करता हूँ मेरे लंग्स से जो गैस आती है वो वार्म ह्यूमिडिफायर होती है. तो वो वहाँ का जो स्पॉन्ज है वो मेरी ह्यूमिडिटी और मेरी बॉडी टेम्परेचर ऑब्जर्व कर लेता है. जब मैं वापस ब्रीथ करता हूँ उसी हीट को और इसी ह्यूमिडिटी को वापस दे देता है. उतना एफिशिएंट तो नहीं होता. तो शॉर्ट आप ट्रांसपोर्ट कर रहे हो, आप 1 घंटे के लिए वेंटिलेटर पर लगा रहे हो एनेस्थीसिया के लिए, तो HME काफ़ी है. लेकिन वो अडल्ट में प्रॉब्लम नहीं है. न्यूबॉर्न में जो सुबह आपको दिखाया था, डेड स्पेस इतना बढ़ जाता है कि वो 6 ml का तो बेबी को देना है, 25 ml इसी के अंदर है, तो सारा वेंटिलेशन में बढ़ जाता है. तो न्यूबॉर्न में अभी भी HME नहीं यूज कर रहे.
We have observed in smaller babies, if you put a HME filter over here, then there is a CO2 retention. Okay, so that's why we do not use a HME filter in smaller babies. Second thing is that in some ventilator there is flow sensor. So there is a disposable flow sensor like SLE, disposable flow sensor or reusable flow sensor. So it is very delicate sensor and very costly. You need to handle with care. And if there is a mucus or something, some secretion, only under tap water you can clean and keep it like that. Okay. And
reusable sensor खरीदा है तो you will have to be very careful because सारा कॉस्ट मशीन को उसी में. अगर सेंसर खराब हो गया तो आपका वेंटिलेटर CMD बन गया, IME बन गया.
that's like a cost around 80,000 something.
तो डिस्पोजेबल सेंसर्स का दोनों फायदे हैं. खराब हो गए तो नया लगा सकते हैं, 1000-2000 रुपए के आते हैं. एंड ये है कि पेशेंट टू पेशेंट इन्फेक्शन स्प्रेड का भी चांस कम होता है. सेंसर्स कैन बी फ्लो सेंसर लाइक इन ड्रैगर इट इज हीटेड बाय सेंसर और इट कैन बी दैट बर्नौली प्रिंसिपल का ऐसे एक डबल शेप का होता है, वो होता है. देयर आर आल्सो लाइक नावा इट इज टेस्टिंग द करंट प्रेशर कैन बी गोइंग इनटू द इसोफेगस, डिफरेंट आ सकते हैं. लेकिन ये है कि सेंसर की जिंदगी है, इसकी लाइफ है सारा कुछ. जो एडवांस मोड करने हैं तो प्रेशर सेंसर एंड फ्लो सेंसर, दैट इज व्हाट इज डिसाइडिंग द होल मशीन.
प्रेशर, फ्लो, ऑक्सीजन, 3 important सेंसर है फॉर टू वर्क वेंटिलेशन.
देन ये मॉड्यूलर देख सकते हैं आप साइड में, मॉड्यूलर
दिस वन.
तो आपने खरीदने के टाइम पैसे नहीं, यू ओनली बॉट इट SIP. देन कहते हैं मेरे को HFO भी चाहिए, ठीक है जी, एक कैसेट और लगा दिया, मदरबोर्ड लगा दिया, तो इट कैन बिकम HFO also. Then now I am expert in ventilation, I want to buy a most advanced TTV ventilator also. One more cassette. So these ventilators are upgradable very easily.
This one.
You just keep on adding one more motherboard.
This one. It's removable. Anything in circuit now?
So important is humidifier. It's very critical to your outcomes. You should not see condensation in circuit. Invest in reusable circuits. Platinum sensor should not be autoclaved. Circuits, if they send for ETO, if it is reusable, it will take at least 1 day to come back. If you are using reusable circuits, patient to patient cost will come down, but lot of hard work will go up. And you must be knowing about pressure that comes from behind. You must be knowing that there can be battery backup. Again, internationally you cannot buy a ventilator without battery backup. 4 hours battery backup होना चाहिए. कोई भी बैटरी बैकअप की तरह से 3-4 साल में बैटरी खराब हो जाती है. यूज़ करो या नहीं यूज़ करो. इंडिया में वो बिना बैटरी के भी बेच सकते हैं क्योंकि बैटरी 1 लाख रुपए की होती है. आप कह दो कि मेरे पास जनरेटर है, मेरे पास UPS है, तो आई कैन बाय इट. बट उसका नुकसान क्या है? एक दिन अगर करंट चला गया, बचा भी है. आप क्या जवाब दोगे जो करंट चला गया बोलोगे? तो इसीलिए इट इज वर्थवाइल बाइंग विद बैटरी बैकअप. यू स्पेंड 1 टाइम मनी, लेकिन 2-3 घंटे भी किसी वजह से जनरेटर खराब हो गया, बैकअप खराब हो गया, चलता रहेगा. इट विल टेक केयर ऑफ द बेबी. सो अदर थिंग इज दैट 3 things are displayed on any monitor. One is what did I dial. मैंने कितना TI लगाया, कितना PIP लगाया, कितना PEEP लगाया, कितना FiO2 लगाया, कितना flow लगाया. What did I dial? The second will be what is the alarm limit. And the third will be what did the patient get. So all these three things should be shown on the display. In some machines, the alarm limit is default. आपने पिप अगर 20 लगाया तो 15 to 25 is the limit, जैसे ड्राइवर में है. In some like in बेयर कप आपको अपने आप डायल करना पड़ता है 5/3. But you have to know that because otherwise it will keep cutting off, and then there is a difference between PIP and PEEP also minimum. Less than 5 it will not allow. तो अगर आपने PEEP 10 लगा दिया 15 लगाया तो it won't allow. So that you have to know which machine what it is. So first one is what did I dial, second one is the limits of the alarms, third one is the display. So any guesses why it will give only 15 PIP if you dial 20 PIP? आपने 20 लगाया लेकिन अंदर 15 नहीं आया. मेजर्ड आप कहते हैं सर पीछे से
प्रेशर
नहीं आ रहे. आपने 30 FiO2 लगाया लेकिन 50 मिल गया बेबी को, मेजर्ड 50 दिखा रहा है.
ये निकल गया गलती से यार.
उसका ब्लेंडर नहीं काम कर रहा है अंदर से. या ये भी हो सकता है कि कुछ भी नहीं दिखा रहा है, डॉट डॉट डॉट. इट इज सेइंग यू हैव टू चेंज द
सेंसर.
गैल्वेनिक और टैलेडन सेंसर होता है उसका, वो भी कॉस्टली होता है. आपको हॉस्पिटल में बदल देंगे, कोई बात नहीं, देख लो सर, ऐसा नहीं. ROP रेट्स बढ़ जाएंगे आपके, because you are not knowing exactly what is being given to the baby, है ना?
So these alarm are set, the pressure, upper limit pressure over here, then minute ventilation. If there is a leak in the circuit, it will get alarm because low minute ventilation. Respiratory rate, it should be set at least 20 up of the desired rate. And this is the end expiratory pressure. If the PP is high, if patient is coughing on the ventilator, there is a ventilator asynchrony, it will get alarm. Okay. So you need to watchful for it while setting the alarm. Second thing is that before starting ventilator, you need to use a pre-use check. Okay, there is a pre-use check tube over here. You need to connect in between the inlet and outlet and do the pre-use check. Second thing, after that, ventilator will ask to attach the circuit. After you attach the circuit over here in the ventilator, then you need to do the patient circuit test. After doing patient circuit test, it will calculate the length and all, compliance and all of the circuit, and it will deliver sensitize the sensor in equilibrium. Okay, so all these things. So there are different kind of modes available over here: adult mode, infant mode, invasive and non-invasive mode also. So with this ventilator you can give a non-invasive. The color will change over here, you see, it become orange over here. Okay, so we are more interested in an invasive mode. So basically this was all regarding the circuit. Now we'll discuss the modes. Okay, so basically there are three main modes are there, because you will get a different ventilator, different modes, different terminology, but three are basic modes. One is a pressure mode, one is a volume mode, and third is a spontaneous mode. Okay, so volume control, pressure control, and spontaneous. In spontaneous it will come CPAP or pressure support. Okay, pressure support ventilation. Okay, so and with this mode they have combined with each other, taking some advantage of some mode and discarding some disadvantage of other modes. So like they have combined volume mode with a pressure mode. So they have said that volume guarantee, pressure support ventilation, or PRVC, pressure regulated volume control. So both mode are combined, pressure and volume, to regulate the pressure and to regulate the volume. Third is SIMV mode, that is synchronized intermittent mandatory ventilation. It is like a assisted ventilation. Okay, it is same only, IMV and assisted ventilation are same only, but it is synchronizing with the patient inspiratory efforts. So it is a synchronized intermittent mandatory ventilation. According to need, they have added like a pressure support. If there is a spontaneous breath, they have added a pressure support in it. Okay, to support the patient spontaneous breath. Then pressure control. If the pressure is very high on the spontaneous breath, so the Pmax we can set over here. Okay, then PRVC mode, they have also added a pressure support for spontaneous breath. So in this all SIMV, patient plus machine will deliver the breath, whereas in control mode only machine will deliver the breath. Whereas in pressure support and CPAP mode, what is the difference in between that? CPAP is a continuous peak pressure will be maintained throughout the cycle, whether it is inspiratory or expiratory. Whereas in pressure support ventilation, it will just support the spontaneous breath to achieve a PIP or target volume. Okay, you understood? So these are the mode. And for neonatal purpose, we don't use this APRV, airway pressure release ventilation. This is one of the kind of new mode which we less likely used in a neonate, but sometimes we can use in pediatric as well. So if there is a patient is spontaneously breathing and lungs condition are bad, So that will maintain desired amount of pressure in both inspiration and expiration, and that will prevent alveoli to get collapse. So you can use that mode, APRV, airway pressure release ventilation mode. Okay.
You heard Ashish sir in the morning. There are only 3 things. नाम 50 है मोड के, लेकिन 3 ही पॉइंट है. Are you able to sense the inspiration of the baby or not? Baby ने ऐसे किया, it will either through flow or pressure it will send a signal and the patient will get a support from the machine. Starting of it. दूसरा है termination sensitivity. And always a best way to understand termination sensitivity is the way you stand a traffic signal. ट्रैफिक सिग्नल पे खड़े होते हो, काउंटडाउन लगा होता है 10, 9, 8, लेकिन आप 7 पे क्या करते हो, ब्रेक हटाने लगते हो और एक्सीलरेटर दबाना चाहते हो, सो दैट जब 0 आएगा यू आर ऑलरेडी मूविंग. सो इन टर्मिनेशन सेंसिटिविटी व्हाट इट इज डूइंग इज वंस ए पीक फ्लो इज रीच्ड एंड द फ्लो स्टार्ट्स ड्रॉपिंग फ्रॉम द पीक फ्लो, देन इट स्टार्ट्स सेंडिंग सिग्नल टू मशीन, जिससे डिले नहीं होना चाहिए. एंड दैट यू कैन डायल, आइदर यू कैन डायल 30% ऑफ पीक फ्लो और इन सम इट इज डिफॉल्ट सेटिंग. सो जैसे ही पीक फ्लो, तो यू कैन देन डिसाइड टू कोऑर्डिनेट विद द पेशेंट्स expression. And third one is, are you limiting the pressure or are you limiting the volume? यही 3 चीजें. Names are different, but the concept is only these 3. Are you able to coordinate the start of inspiration? Are you able to coordinate the stop of expiration? And are you able to set the upper limit of
pressure and
pressure or volume? Now, in one thing you have to know is that all ventilators, it is not real time. That means 4 or 5 breaths का सैंपल, 4 या 5 ब्रेथ को सैंपल करके वो लंग की हेल्थ को जज करता है मशीन, एंड देन अगली 4 और 5 ब्रेथ के ऊपर चेंजेस करके देता है. सो इफ इट फाइंड्स दैट द लंग इज स्टिफ एंड यू सेट अ वॉल्यूम लिमिट, उसके लिए ज्यादा प्रेशर चाहिए था, तो इट विल मेजर दिस एंड गिव मोर प्रेशर इन द नेक्स्ट 4-5 ब्रेथ्स, not in the same one, except in PRVC mode. In PRVC mode is real time. As slope changes, it will change the settings. But all this is wishful technology. You have to understand that the delay between picking up and giving the breath is nearly 0.13 seconds. Whereas total cycle time भी inspiration का 0.3-0.4 सेकेंड है. तो रियल टाइम में हर स्लोप के साथ साथ सिग्नल देख के करेक्शन करना कितना मुश्किल होगा आप सोच सकते हैं. एंड डजंट मैटर ऑल्सो, उतना फाइन ट्यूनिंग में कुछ फर्क नहीं पड़ता. Now some simple mantras for deciding कितना पीप लगाऊं, कितना फिट लगाऊं, कितना आई टाइम लगाऊं. तो सुबह बता रहे थे आपको FiO2. अगर FiO2 22% है, बच्चे का लंग सिक है कि वेल है, वेल, तो उसका पीप लगाएंगे 3.5 to 4. अगर FiO2 आपको 60% चाहिए तो वो सिक लंग है. You will put a pressure of PEEP of 5 to 6 to start with. And the same way with the PEEP also. Initially you may decide a PEEP of 14 maybe for a well lung and maybe 18-20 for sick lung, but that's only, these all are only in dial first time. Then you will stand near the baby and see. If you can see, my teacher Dr. Saurabh used to say, आप face और tube cover कर दो, सोचो कि बच्चे को वेंटिलेटर लगाई है, and then you look at the chest. Normal हम ब्रीथ करते हैं, ब्रीथ थोड़ी रहती ब्रीथ कर रहे हैं, लेकिन अगर इतना दिख रहा है तो ट्यूब ज्यादा है, ट्यूब कम है. You should not see. न्यू NRP में क्या बोलते हैं, कैसे पता चलेगा कि PPV मिल रहा है कि नहीं? हार्ट रेट इम्प्रूवमेंट. चेस्ट हटा दिया अभी, बिकॉज प्रीटर्म बच्चे में चेस्ट मूवमेंट नहीं दिखना चाहिए. ठीक है, द सेम विद द ट्यूब. ज्यादा ट्यूब लग गया तो यू विल फाइंड दैट बेबी इज हैविंग हार्ट रेट चेंजेस, यू विल हैव ब्लड प्रेशर फॉलिंग. तो अगर ब्लड प्रेशर फॉल हो रहा है तो ऑलवेज आस्क क्वेश्चन, मैं ज्यादा ट्यूब तो नहीं लगा रहा. हाई टाइम सिर्फ वो केस डिस्कशन के लिए अच्छा है, 0.35-0.4 लगा काफी है. रेट 40 फॉर ए टर्म बेबी, मे बी 50 फॉर ए टर्म, उससे ज्यादा नहीं आया. 30 पे आ गया तो एक्सट्यूबेशन पर आ गया. अगर FiO2 कम चाहिए तो रेट भी कम होना चाहिए. ठीक है. एंड देन वेदर यू डायल, व्हेन यू डायल वॉल्यूम लिमिट, इफ यू आर यूजिंग वॉल्यूम लिमिट वेंटिलेशन, रिमेंबर दैट यू चोज वॉल्यूम लिमिट सो दैट कि बच्चे को प्रेशर अगर कम चाहिए तो आई शुड नॉट बी गिविंग मोर. So when you set the volume limit, some breaths are giving 16 pip, some are giving 8 pip, some are giving 7 pip, then you're doing good job. But if it is saying, please check settings, don't get fooled thinking that this was a bad lung who I didn't understand, and then increase the upper limit of pressure. actually then machine is not looking at harming you. हमारा machine का मकसद why it may do, there are so many leaks in the circuits, can't measure accurately. So the purpose of applying volume limit is actually बच्चा better हो जाना चाहिए. So जो भी मोड आपने यूज किया, 1 घंटे के बाद में baby's FiO2 should come down, his distress should come down, heart rate should become calm. अगर वो नहीं हो रहा है, कितना भी एडवांस नाम का मोड है, SIPP भी लगा देते हैं लोग, बेबी का ब्रीथिंग रेट 80 to 90, तो उसको प्लेट्यू टाइम कब मिलेगा गैस एक्सचेंज के लिए? नथिंग विल बी देयर, मिनिमम टाइम फॉर आई एंड मिनिमम टाइम फॉर ई. So if your rates go too high, then your mode of ventilation is not good. Okay.
So here we can see that I will just demonstrate volume control mode. If you want to give a volume to neonates, suppose we can go to 4 to 8 ml per kg according to need of the patient. Okay. Second thing is respiratory rate. Basically, if lungs are well, then the respiratory rate should be in the physiological range. Or if you want to CO2 elimination or something, there are bad lungs, so according to that we need to set the rate. Okay, and we need to set the alarm for it also. Okay. Third is a PEEP. So generally if lungs are well, then you can set a PEEP in a neonate like a 3-4 centimeter of water is okay. Otherwise if lungs are bad, so you can go for 5 to 10, but if you are increasing the PEEP, you need to be very watchful. First thing is that you need to see the patient bedside. Second, and his vitals also. Second thing is that you need to see the X-ray. We need to see how the lungs are hyperinflated or not. If they are hyperinflated, there is a flattening of diaphragm and ribs are more than 7, 8 like that, 9, 10 like that. That means lung is hyperinflated or there are chances of generation of auto PEEP. Then FiO2. We need not to give a FiO2 more. We need to select the desired FiO2 required for the patient. So, sir has already told that if lungs are okay, then minimal 25 to 30% of FiO2 is enough. Okay. So you need to, if you are starting with a 60%, and you need to come down faster on FiO2. Third thing is IE ratio. So generally physiological IE ratio we keep like 1:2, 1:3 like that. But if you are going more playing with a more IE ratio, then there will be chances that you cannot set a respiratory rate over here. Okay. So basically try to keep in the physiological range. So inspiration is an active thing and expiration is passive thing. So for any passive thing will require more time. So expiratory time will be more as compared to the inspiratory rate. Sir said that we can set in between the 0.3 to 0.4 like that inspiratory time in neonate. Okay. So T pause. What is T pause? Is basically in volume control ventilation there will be a first increase in the flow and there will be a no flow for a while. Okay. To reach the PIP. Okay. So to reach the PIP, how much percentage should required is like a 15 to 20% of the initial breath of inspiratory time. So it should be keep in between 50 to 20% to reach PIP. Then this one is T inspiratory rate. It's like a ramp in how much time you are reaching to PIP. Suppose if you are increasing, it will take time to reach that particular PIP. So it could be like a 5 to 10 is okay for the child. Okay. If lungs are so bad, then you need to just increase the T inspiratory rise. And flow trigger. There are two types of trigger: pressure trigger and flow trigger. So once you increase the flow over here, flow trigger over here, it will become more sensitive. It is reverse of a pressure trigger. So like that you can set a volume control, as well as when you are setting the mode, you need to set a alarm also.
And very important is, if you have very small baby, then you need more tidal volume. Contrary to what you think, हम सोचते हैं कि small baby को lung injury हो जाएगा. You will have to direct volume ventilation if you are doing it 6 to 8 ml per kg. Can you guess why? क्यों ज़्यादा करना पड़ता है? उनका anatomic dead space trachea, bronchus compared to lung बहुत बड़ा है. तो effective volume which gets into what is called a ventilating volume, alveolar ventilation, वो relatively छोटा है. तो आपने 8 ml डाला तो जो lung में जाता है वो 3 ml है. लेकिन in a bigger baby, the dead space is the same, and ventilating volume is much larger. So there you will dial 4 to 6 ml per kg. But again, these are only initial settings. And then you watch the baby and then reset the settings. Okay? Again, this one thing is just this machine is calling and telling मुझे नहीं बता रहे. Good machines में ये है कि everything, चाहे ventilator चाहे humidifier हो, trouble shooting कहाँ पे करना है वो भी बता देता है. अगर अलार्म है तो जहाँ पे अलार्म चल रहा है वहाँ पे प्रॉब्लम है. ये वाला वायर खराब हो गया आ जाएगा, So your nurses and yourself can immediately find the problem and correct it. So whether it is humidifier or ventilator, it will read out. For example, the change may be different if this is opened by mistake. In dragger, for example, I am more familiar with draggers, I use more draggers. It will show us hose leak. Whatever hose leak means, the leak is before the flow sensor. And if it is showing leak in circuit or leak from patient, it is after flow sensor. That means ET has come out or ET is too small. So that we need to know, and we means आपके अकेले जानने से क्या मिलेगा? आपके residents and आपके nurses को भी जानना होगा. So once in a while एक ventilation workshop अगर आप अपना करेंगे आधे घंटे का, उनको एक practical tips बताएंगे तो आपका outcome clear हो जाएगा. 10 minutes.
Okay.
Right.
So we'll see the graphics according to the modes we can set over here is like.
flow आता है सर.
हाँ जी. Very good. कुछ machines में flow पहले से ही है. You can't do anything about it. वो अपने आप से ही जितना सेट करो उसके हिसाब से उसमें से उसका इंस्पिरेटरी राइज टाइम. तो अगर बच्चे का लंग बहुत सिक है और आपने इंस्पिरेटरी राइज टाइम कम लगाया, मतलब फ्लो बहुत आएगा, एकदम से राइज कर जाएगा एंड प्लेट्यू विल बी फॉर लॉन्ग टाइम. लेकिन अगर बच्चे का लंग सिक नहीं है, इट इज बेस्ट टू गिव इट लाइक आपने पोस्ट ऑफ वेंटिलेशन करा है, खाली लंग नॉर्मल है, तो उसमें इंस्पिरेटरी राइज टाइम ज्यादा लगाएंगे तो धीरे धीरे फ्लो बढ़ के ही प्लेट्यू आएगा. तो उसमें रिस्क ऑफ गेटिंग शॉक, न्यूमोथोरैक्स ये सब बहुत कम होगा. ओवर डिस्टेंशन ऑफ लंग विल बी लेस. सो इफ इट इज ए नॉन सिक लंग, or broadly we used to say unless you have ARDS like very bad lung, then only you play with flow. Otherwise you leave the flow to be as low as possible.
नॉर्मल लंग वेंटिलेशन में कुछ करने नहीं.
नॉर्मल लंग वेंटिलेशन कुछ नहीं, अपने आप ही मशीन से कर देते हैं. वो जितना आप ज्यादा बढ़ाएंगे फ्लो को बढ़ाएंगे तो आपको हिसिंग साउंड्स नहीं, वो सारी गैसेस जो पीक पर बाहर निकाले जा रहे हैं, यानी आपके पैसे सारे निकाल जा रहे हैं, सारा ऑक्सीजन जो है निकल मिल रहा है.
5 to 10 पे सेट करना है बस.
नया वेंटिलेटर है,
keep it 5 to 10 T rise 5 to 10 सेट करना है, ज्यादा उससे खेलना नहीं है.
Some rule is 20 times of the tidal volume. But these are all thumb rules. But if you are in brand new ventilator, 5 ventilator, बहुत पुराना वेंटिलेटर है, 20 साल से चल रहा है, आपने रिफर्बिश खरीदा है, तो उसके इंटरनल लीक्स हो रहे हैं, तो आप 15-20 लीटर भी लगाओगे तब भी वो प्रेशर नहीं मिलता है बाहर.
आपके पास सिलेंडर ज्यादा है तो करो. So because of time constraint we will go to graphics. Anyone is having a doubt regarding modes or something? So there are basically graphics which are divided on ventilator, loops and scalars. So first of all we will see regarding loops. There are two types of loop: pressure volume and flow volume. Okay, only two loops are there. Need to remember. Okay. So this is a normal pressure volume loop for the normal patient who is not on ventilator. So it is starting from the 0, and this is the inspiratory limb and this is the expiratory limb. Okay, this is tidal volume and this is pressure. Okay, so this is 5 is the pressure. Okay, so if patient is on ventilator, the loop will start from here because we are giving PEEP. Okay, suppose if we are giving a 10 ka PEEP, the loop will start from here. You understood? So that means lung is bad. If lung is normal, the things will be over here. Okay, so this is the inspiratory. So this is, you know, the steep curve is there because we are increasing the pressure, but there is no increasing volume as compared to the pressure. So it's known as lower inflation point. So that amount of pressure is required to open up the alveoli. That's why PEEP is kept at 5. Okay, so that will continually open the alveoli. So after that the inspiration will begin, and that will form the shape of the curve, and this will be the upper inflation point. Where after that, after increasing pressure also, there will be no change in volume, and there will be a parrot beak appearance. Okay, so this is PIP, peak inspiratory pressure, that is maximum pressure. After the termination of inspiration, the expiration will start. Okay, and likewise expiration will start over here. Okay, and this shape of curve is like a leaf. Okay, so this is a normal pressure volume curve. You want to say?
Yeah. इसमें only 3 points. Number 1, ये ऐसे खड़ा है. Yes, like you were showing in the next graph. Here. This is a stiff lung. Whatever pressure you are giving, volume is not there. After giving surfactant, ऊपर हो जाएगा. अगर ऊपर चल रहा है, it is time to reduce pressure. Second is the gap between this inspiration and expiration. एक ही pressure पे, this is the pressure. During inspiration, this is the volume of the lung. During expiration, this much volume is there. Can you guess why it is like that? Yes.
Yes.
The lung is holding back the air. That is FRC. तो हेल्दी लंग होगा तो वो आराम से ज़्यादा FRC रिटेन करेगा. सिक लंग होगा तो उसका FRC नहीं आएगा. आप कुछ भी करेंगे
ये छोटा हो जाएगा.
तो ये कम रहेगा.
यस सर.
तो तीसरा पॉइंट इसमें ये है, अगर आप प्रेशर बढ़ाते जा रहे हैं और उसके बाद में भी वॉल्यूम नहीं बढ़ रहा है, सो यू विल सी ए वीकिंग देयर एंड इट सेज की प्रेशर पॉइंट आउट. तो प्रेशर वॉल्यूम लूप में प्रैक्टिकल पॉइंट्स इतने हैं. इज द स्लोप सिटिंग अप और इज द स्लोप फॉलोइंग डाउन. Second one is what is the hysteresis, the difference between the inspiratory and expiratory volume. And third, you are not getting a leaking. Okay? Then we go to scalars. Yeah, this one also you can.
So this is a pressure volume loop. If there are secretion in the circuit or ET tube, it will be like a serrated loop. Okay. So you need to. This is the time for suction in the baby. Okay. Regarding this is a flow volume loop where the R2P is get generated. Basically, this expiratory limb should end over here at 0. This is flow and this is volume. Okay.
Correct.
So basically, it should end over here, but because of air trapping and R2P, it is ending after that. Okay. So if the curve is ending like this, there means there is a air trapping in the lung. Okay. I am telling. So if the flow, if air leak is there, if it's suppose peritubal leak, inspiratory tidal volume is more than expiratory tidal volume. So in leaking, it will end before the 0. You understood? So there are chances of leaking. So it is in flow volume loop. Okay. Then we will go with the scalars. So there are basically pressure, flow and volume scalars against the time. Okay. So these are the scalars. So basically pressure versus time. So this is a pressure scalar in which it is a box kind of. Okay. Whereas in volume it is like a tent kind of. Okay. So and this is a inspiratory pause. So after that expiration will start. So it is up to inspiration, and here the expiration will start, and this is PEEP. Okay. Whereas the flow will increase gradually to attain PIP, and after that it will start expiration in a volume curve. You understood? This is PIP, peak inspiratory pressure. After that there will be pause of flow. So pressure will be in the equilibrium with alveoli. This is P plateau pressure, and then the expiration will start.
This is helpful for you when you are doing ventilation. This is the passive part of expiration. So if there is a tube block, the passive part will be very low and prolonged. जैसे आस्थमा में स्पाइरोमेट्री में होते हैं. अच्छा लंग होगा तो ये ऐसे जाके यहीं खत्म हो जाएगा, and it will go on like that. But if it is a blocked ET tube because of secretions, then this will run parallelly and very long distance. So
Yeah,
that is a practically
this
useful
one.
point. Yeah.
This one.
ये छोड़ दीजिए. So in a pressure time scalar, we will also be able to see whether auto peak is coming. जो आपने सेट किया पीक उससे ज़्यादा आ जाएगा. ठीक है. So before we conclude, आपको उसके बाद क्वेश्चन भी पूछ सकते हैं. आपसे भी क्वेश्चन पूछेंगे ना क्विज. ये कौन सा मोड ऑफ वेंटिलेशन है? You can see that we have marked circles that every ventilator breath is sensing the is triggered whenever patient is breathing breath. So instead of seeing the name of the node, what you understand is every time patient takes a trigger, but यहाँ पे अगर patient ने trigger नहीं किया बहुत देर तक, तो ventilator ने ये blow breath नहीं दिया. So this is in Dragon SIPPV or assist control. In some others it is just called PTV. लेकिन इसमें आप देखेंगे कि expiration is not synchronized. जब पेशेंट एक्सपायर कर रहा है उस टाइम से सिंक्रोन नहीं है. ठीक है. सो दिस विल बी योर पेशेंट सिंक्रोनाइज्ड टाइप ऑफ मोड्स वेयर expiratory termination sensitivity is also there. So when baby started breathing in, ventilator gave breath. When baby started breathing out, the ventilator also stopped. तो इनका ग्राफिक कैसे दिखेगा? एक मोटा एक पतला, एक मोटा एक पतला. तो ये इस एक टोटली लाइक PSV इंट्राइगल In some others it will have different name. Therefore, you have to only go back and ask that जो mode लिखा हो मैंने लिख के पूछो, are you synchronizing the inspiration? Are you synchronizing the expiration? अभी इस मोड में प्रॉब्लम क्या है? ये किस तरह का प्रॉब्लम है? अगर वाटर आगे सर्किट में तो you will only have thin pillars like this. Effective ventilation will be very bad. क्योंकि मिनिमम टाइम तो चाहिए इंस्पिरेशन के लिए और एक्सपिरेशन के लिए गैस एक्सचेंज करने के लिए. So when you are using very advanced mode of sensitive ventilators, it can ventilate in this way, where you get auto cycling is called. So in this setting, if you still are obsessed about not using IMV, मैं तो कहते नहीं हूँ, मैं तो सिर्फ ट्रिगर लगाऊंगा, then you change the sensitivity. अगर sensitive ज़्यादा होगा, तो वो हर वक्त ट्रिगर करता रहेगा. Any questions you want to ask us?
प्रैक्टिकली कितना फ्लो ट्रिगर कितना रखेगा?
प्रैक्टिकली तो सबसे कम लगाना चाहिए, क्योंकि आपने मशीन खरीदी, मान लो आपने कार खरीदी अच्छी, तो इसका जो शॉकर है वो बेस्ट होना चाहिए. हार्ड क्यों करने का है? लेकिन हार्ड कब करते हो? अगर आपको जाना है वो पहाड़ी पर चढ़ने के लिए. अगर वो सॉफ्ट रहेगा तो टूट जाएगा. उसी तरह से अगर आपको कैसे भी किसी भी वजह से आपको, मान लो आपने एक बच्चे को लगा रखा है पोस्ट एनेस्थीसिया, एंड आप सिर्फ उसको देख के घर पे बैठ के फोन पे देखना चाहते हैं कि ये जा गया कि नहीं जा गया, then you can put trigger on that, and then you can put a very sensitive trigger. As soon as it triggers, it will let you know. But otherwise, there should be no reason for changing the trigger. Whatever is default, that is the best. Only when you are getting auto cycling, you may want to change the trigger. Otherwise, there is no reason to change it.
Flow is more sensitive than pressure.
Yes.
Is there different modalities? In some machines, for example, in Ragger, most of them. In Siemens, you are having both. You turn the knob to one side, it is flow, other side, it is pressure. So, pressures are easier to measure technology-wise. Cheaper ventilators will be able to provide pressure triggers, and they are more high fidelity, so you obey correctly. Flow requires very sensitive devices, and it is more prone to error, but it will give more accurate volumes. So, if you want to do volume ventilation, flow sensitivity. So, वहाँ पे flow trigger चाहिए. Then only it will give correctly. So it is more accurate to the patient, but more prone for errors. So you must choose based on that.
Sometimes secretions,
वो flow
that will also alter.
So if you are having pneumonia, the flow नहीं लगेगा, वो हर वक्त disturb होता रहेगा. Surfactant देने के immediately बाद में, जब तक surfactant उसमें हिल रहा है, तब तक वो flow disturb हो जाएगा. Condensation problem में flow disturb हो जाएगा. लेकिन pressure line है, तो pressure line में water नहीं होना चाहिए. Pressure line में water आ गया तो वो भी है. The pressure line is very hardy. It will not get easily disturbed by this.
3 to 4 सेट कर सकते हो आप.
But trigger is not to be changed actually. You don't have to change.
Yeah. प्रेशर ट्रिगर सेट करना है तो -1 -2 कर सकते हो. Flow 3 to 4. हाँ, मतलब that give a good trigger sensitivity. But if you are finding there is a difficulty, then you need to go for scalar and loops. So whether the inspiration ending early, there is a synchrony or something.
Ventilation going bad is your ET tube going slightly deep. This is an important mantra you have to take home, because if it goes slightly deep, then one lung is getting over ventilated and other lung is getting under ventilated. So your ET card, what is called, should be there in front of the machine. After you have done intubation by using 6+8 whatever the weight rule, it may not be accurate. Then you took an X-ray and you confirm the position. If it is accurate, then you write, for this baby 7 is good. आप 7 पे मार्क फिक्स करके गए, कल सुबह को आपने देखा उस स्लिप होकर 8 पे चला गया. It cannot be. So unless you write on your ET card, like where did I fix the ET tube, and keep checking in every moment whether it is in the same place, you will be ventilating baby for a long time. So one of the main reasons for going wrong is this. The tube slips inside and it goes into one lung.
Bronchial intubation.
Consider. Especially neonates, when you get smaller and smaller, the length is very small.
Tailor-made approach is there. But we get the length, and these are not suited for all babies.
Yeah.
Some baby require more.
Correct. So you may start with a formula, but then you have to customize it based on the actual.
Tailor-made approach.
You need to see air entry or good on both sides, X-ray.
क्योंकि आपको अगर जल्दी बढ़ गया तो you can enjoy.
Even the head position, flexing of the neck will also push the tube up and down.
Yeah.
So head position is also.
Practically very important is आपके सीखने से नहीं होते होंगे. Your team has to know all the practical points, and only you can teach them. So one time you take a master mentor, whether it's a nurse or a doctor of a unit, once in a month, at least one half-an-hour session, your outcomes will go to different level.
Headache भी कम हो जाता है.
तो वो पढ़ाना तो आप ही को पड़ेगा एक बार. उसके बाद अपने नर्स मेंटर को या रेजिडेंट को बार-बार पढ़ाना पड़ेगा.
Whatever you set over here doesn't matter. What is the patient is having is matters. तो वो ज़्यादा comfortable जहाँ है वहाँ setting करना चाहिए.
Okay. So good afternoon. So you come on the ECMO workshop. We are going to talk about ECMO over here. So what is ECMO? Excellent. And what does ECMO do? Artificial lung and artificial heart. You can use both or either. Okay. Now the main point of any oxygenation is your excess. If you want to ventilate somebody, what do you have to put down? Endotracheal tube, ET tube. In ECMO, we have to put ECMO cannulas. How on the sizes we decide the ET tube? ET tube has to be good size. If ET tube is small size, what will happen? Because resistance will be high. Yeah, so if the tube size is small, the airway resistance is high. Okay, so we need to make sure that when we intubate somebody, we put good size tube. Same thing in ECMO. To get ECMO blood flow, we have to put good size of ECMO cannulas. Okay, ECMO cannulas are based on the body surface area or weight of a child. For appropriate weight or body surface area, you have to put appropriate size. The idea is that each size of the ECMO tubing should give you 80 to 120 ml per kg per minute of blood flow. Okay. For newborns, usually we put 8 French and 10 French ECMO cannulas. Okay. So these are the 2 ECMO cannulas we put, and there are those nice small ECMO cannulas which we put. For people saying what is the normal central line we put? 5.5. We put 5.5 triple lumen or 4.5 double lumen. Most of our patients, cardiac or septic shock patients, we put 5.5. This is now. When we were training, 7 and 8 French were the only central lines available which we used to flick from adult ICU and put in our pediatric patients. So putting 8 French is very simple. How do we put this ECMO cannulas? Okay, the process of putting ECMO cannulas is very simple. Right. So we first put this here. How we put pick line upon 22 French. So we put 22 gauge cannulas and we put the pick line with the guide wire. In this, what we do is we either put 22 gauge cannula or 20 gauge cannula. 2.5 or less we put 22 gauge cannula, 2.5 and more we put 20 gauge cannula. In that we put a guide wire. Arterial line guide wire, okay, it's just 2 French. We put the arterial guide wire. We put our central line under the ultrasound. We find the SVC, we prick it, put your cannula, pass your guide wire, make sure your guide wire is longitudinally, your guide wire goes in your jugular vein and SVC. Okay, go down, see it going to the SVC, finish. Remove your cannula. Once it is done, then you open your sheet, cardiac sheet, which is used for your angiography. Okay, PDA ligations or something, they use 4 French sheet. We push that 4 French sheet. 4 French sheet comes with 2 dilators, 3 French and 5 French. 3 French dilator goes easily, we dilate it. Before putting 5 French or 3 French, we need to cut the skin in the subcutaneous area. Make sure you cut it enough that there's enough longitudinal space for it to dilate. Okay, so we cut it, we put the 3 French, then we put 5 French, dilate it, we remove it, then we put the sheet. This all happens on the small guide wire. Once 4 French sheet goes, or in a bigger child 5 French sheet goes, we remove the dilator. We remove the guide wire. Then we put ECMO guide wire. So this is ECMO guide wire. The advantage of ECMO guide wire is that it is slightly more strong, okay, and it is long. If you are using single lumen ECMO cannula, okay, then you need to go, the guide wire has to go into from your jugular, SVC, right atrium, IVC. Okay, the single lumen catheter has to go to your IVC. In your putting double lumen, you put into your right atrium. So this has to stay in your right atrium. Okay, so this has to go into right atrium with your TOE or with your transthoracic echo. Confirm it's in right atrium. Once this is that, then you remove your sheet. Okay, then you remove your sheet. Then you have serial dilators. This is an adult dilators. We don't need all of them. We just need one, which is 10 French. Okay, so we did 5 French we finished, then we have 10 French. So what we sometimes do is open up adult central line. That gives 2 more 6 and 8 French dilators. Serially dilate all of them. Finally put the 10 French dilator. Once the 10 French dilator goes in, comes out, ECMO cannula will go in easily. Okay, so we do either do jugular for drainage and return from femoral, or mostly we do femoral drainage and jugular return. In newborns, mostly in India, we go VA. We do this and then we do carotid, and carotid usually we do by a open semi-Seldinger technique. Okay, we do it slightly open is because we want to tie up the carotid distally and proximally. In case the cannula or the guide wire slips, it should not bleed, you can just tie it up. Okay, so you do semi-Seldinger and that's how you do it. You get your jugular cannula right up to the right atrium or near the SVC, and your carotid cannula in your descending aorta. Just above the arch of aorta, pointing towards the descending aorta, is your carotid artery. Your 2 cannulas are done. In adolescent or in pediatrics, we use bigger cannulas. So this is for 20-30 kg child. This is a femoral cannula. Okay, 20 French. Small for me. I use 29 French. Okay, this has to go from femoral. This has to go right up to the diaphragm near the IVC. This is not the tip. Tip is over here. Okay, so this has to come near your IVC above the hepatic vessel. Catch up good. So this is what you do. Okay, so this is where it comes in your femoral cannula, and this comes down. So this is where the cannula ends. Okay, when you put this, you need to use all the dilators. You serially dilate to dilate your veins up to the 4 centimeters more, so all your cannula goes. You do this, and this will be your return 18-19 gauge in your jugular. So this is your femoral venous and femoral jugular, and again this is not your tip is over here. So this is a sterilizer. So this goes through and the guide wire will pass through this. Okay, then you remove everything and then the blood will come back. Okay, it's very important to size your cannulas properly. Base your cannula, you get a blood flow. We need a blood flow of at least 80 to 120 ml per kg per minute. Okay, so this is your airway. This is your drainage, your cannulation. This is when you cannulate, you need to remember to give heparin, because blood is going to come in contact with artificial surface. It will block thrombus. So usually we give 50 to 70 units per kg bolus of heparin. Okay. So this is about cannulation. Cannulation, the important is how you tie up your ET tube, it does not fall. You have a standard procedure of doing ET tube. You use 2 tapes, correct? In cannulation, we always do 3 stitches. Okay, so this is the cannula. This is my entry side. I'll put 1 stitch in front. Okay, closing my cannula with my skin and subcutaneous. 1 after that. Okay, 1 at the end to prevent the traction. Okay, after this is done, when my tubing is connected, it's like your long T-piece. You put a band on the T-piece and stick the T-piece on the band. Okay, so if somebody pulls at the circuit and not at the cannula. Okay, pick line रहता है तो pick line में कैसे band करके लगा देते हो कि if pull आएगा तो it goes under the connector but not on the pick line. Same principle we follow. So we need to connect your ECMO circuit. ECMO circuit में there are 2 colors. What does blue and red mean? Perfect. Blue is venous, red is arterial drainage. Blue is venous drainage, red is arterial return. Drainage means it drains the blood away from the body. Return is returns to the child. So now we come to the ECMO machine.
Hi, good afternoon everyone. My name is Prajakta and I'm a perfusionist by qualification and currently working as an application specialist for ECMO. So the machine which you can see right now is Neonatal 2. Don't get confused because of the design of the machine, but just look at the basic 2 parameters here and look at this monitor. So this is LPM and second one is the RPM, which is revolution per minute, which we do monitor on the monitor or the console. Okay, so this is the console, this one is the drive unit. This console and drive unit are connected with each other with the help of this black drive cable. So what is under my control is this RPM, which is a revolution per minute, which I can control with the help of this rotary knob. So simply, if I increase the RPM, you can see the flow is also increased. So flow is not in my hand. What is in my hand is the RPM. So this increase in the flow is depending upon various factors. We'll discuss that later. But if the patient has enough volume, then after increasing in the RPM, increment in the RPM, your flow should increase. That is the basic thing. So this is connected to the drive unit. So as I'm increasing the RPM, the signal will be sent to the drive unit with the help of this cable and speed of the pump will increase. Okay. So this is console, drive unit. This drive unit and this pump look similar. So what if you have a ventilator and that is a single ventilator available in your center? The patient is already on venti and suppose that ventilator stop working, you don't have backup ventilator available. What will you do?
Excellent. Loudly.
Okay. Similar to that, if this pump is not working when patient is already on ECMO, we'll use this backup pump. That is the hand crank. That pump don't have any connection with the console or with the electricity supply. Okay. So that will work on the manual backup. Okay. So as and when pump is not working, we'll shift the disposable part. We'll demonstrate that also. We'll shift the disposable part on the top of, we'll keep that on the top of that pump and we'll manually do the hand crank. Okay. So you can call that as a manual backup or the hand crank. Okay. So again, console, drive unit, hand crank. Also in hardware, we need something known as gas blender. So this is the gas blender and this part is the heater unit. So this all will come under hardware part of the machine, which will stay fixed in all the cases. You have to buy or you have to take new disposables every time. So what comes under disposable, as sir has already mentioned on the cannulas, we need 2 cannulas. One is the drainage cannula and second one is the return cannula, right? So we need 1 drainage cannula, 1 return cannula. Drainage cannula will connect to the drainage line or the line which has a blue sticker on it, which will be drainage line. And the return cannula will connect to the return line, the line which has a red sticker on it, right? So if you look at the circuit here, we have, this is the drainage line and this one is the return line. So first, when sir is doing a cannulation, what I'll do as a perfusionist, my role is to prime the circuit that means to dear the circuit with the priming fluid and keep ready. So when the cannulation is done, we'll cut it from here and we'll directly attach it to the connectors which cannula has. Okay? Then once we'll connect it to the cannula, I'll increase the revolution per minute from the machine. We'll do unclamping, we'll have to clamp the circuit, but again, simply after cannulation, we'll increase the speed here. So once I'll increase the speed here, the movement will happen here at the motor side. That means this is the, as you know, this is the centrifugal pump. So because of the vortex effect which is generated by the centrifugal pump, the negative suction pressure will be generated at the inlet of pump. Cyclone dekha hoga na sabne, that is the vortex whirlpool like effect, you know. So because of that, the negative suction pressure will be generated here and the positive pressure will be generated here. That means the blood will be sucked at the center and will push out. Okay? So blood will come here in the center, will go again outside of this pump towards the oxygenator. So first the blood from the drainage cannula will come to the drainage line. From drainage line it will come to the pump. From pump it will go to the oxygenator. So this is the device which is known as oxygenator or the artificial lung. What we'll do, we'll attach this to the source of gas supply. Just like your ventilator, we'll have to attach it to the air and oxygen. Similarly, we'll attach this to the central gas supply with the help of gas blender. So this is the gas blender. You can see the numbers are written there. It is just to measure or to control the flow. Flow of what? Gas, that is air, and the oxygen. So this grey color part here you can see percentage of FiO2 which is written, fraction of FiO2 that is written. Which is starting from 21% to the 100% just like your ventilator. And the second part here you have control. You have a control on your airflow. Okay, the airflow which is coming from the central gas supply. Clear? So we'll connect that to the oxygenator with the help of this gas tubing. So inside the oxygenator, what exactly happening is a gas exchange, that is taking in oxygen and removing out CO2. Basic, just like what is happening inside the body, right? So gaseous exchange will take place in the oxygenator. Similarly, you can see these blue tubings which are attached here, which are coming out from this heater unit. So we'll add almost 1.5 liter of water inside this. That water will circulate from heater unit to the oxygenator with the help of these tubes. And then the heat exchange inside will take place by conduction. There is no blood and water mixture is happening inside. Only by the conduction, this heat transfer is taking place, and by diffusion, the gas transfer is taking place. That means we have a higher concentration of gas in here. From here, it is going here, right? So the higher concentration of oxygen is going in, and the higher concentration of CO2 which is there in the blood, which is going out. Clear? So after oxygenation and the temperature correction, highly oxygenated blood will go back again into the return tubing to the return cannula. So this is the basic physiology. Clear?
So what are the three main components? Console, pump, centrifugal pump, and oxygenator. Okay. So the extra will be the supporting the oxygenator will be your heater and your gaseous exchange. This is same thing as what you use in your CPAP machine. Okay. Keep your FiO2 based on the oxygen you need. Keep on the only extra thing is the sweep gas. Sweep gas is used for your CO2. Okay. Usually oxygenation is difficult. Oxygen coefficient is high. Oxygen diffusion is high, it takes longer. We keep nearly on 100% FiO2. CO2 is very easy to diffuse. Okay. CO2 is easy to diffuse, so we keep CO2 lower to begin with, diffusion. So if we're keeping at 3 liters, we'll keep the sweep gas at 1.5 liters. 1 is to 0.5. Because we do not want CO2 to wash out fast. What will happen if CO2 washes out fast? Hyperventilation. But what will happen to the brain? Vasoconstriction. Vasoconstriction will happen, infarct will happen. Cerebral perfusion pressure will decrease. Okay? So you do not want to wash out your CO2, especially in newborns, because it will lead to infarct. So we start with a lower sweep gas, okay, and based on our gases will go up. Oxygenation we continue, it takes longer, so we don't worry with the FiO2. We need to make sure that the ventilator, we are giving 100 ml per kg per minute of the flow. They will arrange the rotation per minute to achieve 100 ml per kg per minute. There's an upper limit. Upper limit on each machines are different. In this machine it's 2500. You do not want RPM to go about 2500. If you are going about 2500, then you are worried your cannula size is not good enough, or the patient is hypovolemic. Why hypovolemic? This machine works on preload. It's a preload dependent. You want your preload to be good. You want your patient to be filled up properly in the intravascular space. Okay? So that's why you need to make sure that your patient is preloaded before you go in. Okay? Usually we do point of care ultrasound. We make sure that what's going on before we put the child on ECMO. We make sure we do the IVC. See the IVC, look at its distendability, look at its compression, look at the echo of the heart to make sure we are going on VV or VA. Most of the neonates we go on VA because it's easy to cannulate jugular and carotid than to use femorals. Okay? So we go on VA ECMO. Once we go, we decide, we put on. Once we put on an ECMO, before we put on ECMO, what are the 4 things we are going to be worried about on ECMO? Sepsis. Any patient in ICU will be worried about sepsis. That's the 4th thing. Blood is coming out. Blood is coming in contact with artificial tubings and cannulas. It will thrombose. Okay? So it will be thrombose. Most of these tubings are heparin albumin coated. Okay? But we have to give a heparin bolus. So usually we give 50 to 75 units per kg of heparin bolus so they do not clot. At the same time, if we are making sure the patient is on heparin, we need to make sure the patient does not bleed. Okay, so third is thrombosis and bleeding. Second is air. Okay, this is an outside circuit. Okay, the lung is getting totally bypassed. So air will be sucked from the venous side and go back in the arterial side. So you do not want air, especially air in 50 ml syringes will cause a lot of issues. So now here, especially neonatal nurses don't worry about the 3-5 ml of air. But on ECMO you have to worry a lot. See now when we put air, what happens? Now there is air. You can hear the noise. Till now when the machine was working, there was no air. The machine is continuously working, you can't see anything. But now at the top of the centrifugal pump, where the vortex is, you can see the air bubbles over there. It will not allow air to go down in. If the air goes and travels down, there is a particular way by which this is configured that the blood and everything will go down, water will go down, air will come on top and come out from here. Okay? So that is most important why you need to see that the air does not go in. The worst thing which can happen rarely is that something is opened over here, one of the 3 ways, and air goes on the red side, which is return. You don't want that. You straight away clamp you see air, you straight away clamp it. Okay, clamp it, find the air, push it back, travel with the air, push it back to oxygenator, or before oxygenator there's a area where you can drain the air out from. Put a 50 ml syringe, drain out the blood and air both from here. So you need to make sure there's no air in the circuit, because then air embolism happens. This is one of the commonest reasons why sometimes in PPHN when they have a PF or a PDA, they have a right to left shunt, they have stroke or infarct. People think it's because of the PPHN or the severity. 50% of the time is because of air embolism. People do not take care of air in NICU, which we need to, because there's a shunting going on. So we have to be very careful of air embolism in a patient. Okay, so now we saw about the air. What was the next?
Circuit pressures.
Circuit pressures.
So, it's a clamp.
For example, we can keep some high saturation.
So you can see we are able to achieve almost 4.6 liter of blood flow with around 1995 of RPM, right? So normally when you initiate the ECMO, you will able to achieve this in adult patient, especially in pediatric also the scenario is same. You can hear that churning sound has gone down because the air has gone out from the vent port. Okay? So now you can see, so we are able to achieve almost 4.6 liter of blood flow. As this pump is a centrifugal pump which is preload dependent afterload sensitive pump. Unlike roller pump में क्या होता है? When the roller pump has, what is roller pump exactly? There are two rolls, there are two actually heads which are opposite to each other. They rotate and they are creating some pressure on the tubing. So after generation of the pressure, the fluid is going in the forward direction. So if you clamp those tubing when the rollers are already working in the place, after some times it will lead to bursting of the tubing because of the excessive pressure generation inside the tube. Okay. Whereas with centrifugal pump, if you clamp anywhere or if clot is there in the circuit or kink is there in the line, your flow will go down, but nothing will happen to the connectors, nothing will happen to the tube. Okay, because this pump is preload dependent afterload pump, as well as we can call as a smart pump. Okay, so in case if fluid is coming to it and then only it will try to push. Otherwise it will not generate any negative effect in the circuit. So that is the reason we are using this for the longer run, like ECMO. Apart from that, now you can see we were having this clamp was placed on the venous line. So the flow gone down. Similarly, if you have a clamp on the arterial line, again the flow will go down. But in normal scenario, if you are not getting enough flow, how will you understand at what side you have an issue and because of that the flow has gone down? So for that, what we do, we usually do this pressure monitoring of the circuit. So as we have already discussed, this pump will generate a negative suction pressure at the inlet. So if we have any issue with the negative suction pressure line, the pressure will go more negative. For example, in case of hypovolemia, now we were able to achieve 4.6 that we have seen. So in case of hypovolemia or maybe kink in the circuit, on same RPM the flow has gone down. And at the same time, to increase the flow, if we increase the RPM, what we are doing exactly, we are increasing the speed of the pump. So increase in the speed of pump will increase the negative suction pressure, more negative. It will make it more negative. Sometimes that will have an effect at the site of cannulation or at the tip of the cannula, right? So to avoid that, it is very important to have a proper pressure monitoring. So if you can see here, this is the first area from which the blood is entering into the pump. So you can measure your first pressure from here, which we can call as a P1 or venous pressure. The second pressure is the pressure at which blood is going inside the oxygenator. We can call as a P2. And third pressure is the pressure at which blood is leaving from the oxygenator. We can call as P3. So in case of pneumothorax or any compression on the venous cannula that is leading to the decrease in the flow, that is because of the venous issue, you will have a more negative venous pressure. And how will you monitor that? Well, just attaching simply a pressure transducer on the venous line. So attaching a single pressure transducer and connecting it to the another monitor, you can see your P venous pressure. So if it is exceeding the previous limit, that means you will understand something is wrong with the negative pressure side. Similarly, if pressure of a blood is higher, which is the pressure of a blood which is entering into the oxygenator, previously this was 220 and this was 230. So the difference was only about of 10 mmHg. But suddenly this pressure gone up to 300 and this has actually come down to 150. So maybe this rise in the pressure with fall in saturation, that will tell you that something is wrong inside the oxygenator. So to rule out that, to understand that, pressure monitoring is very, very important. Apart from that, we can take advantage of these ports that we can do pre and post ABG to check how the oxygenator is functioning, right? So
how did you do? What do you think will be the oxygenator pre and post? What do you think the pre-oxygenator will be there? Pre-oxygenator ABG का PO2 क्या होगा? That will be equivalent to? Patient's venous. Venous PO2 will be how much? 45. Okay, so 45 to 55. And उसके बाद पोस्ट ऑक्सीनेटर, इट इज योर पल्मोनरी आर्टेरियल ऑक्सीजनेशन, उसका PO2 कितना होना चाहिए? It has to be 100% saturated, which will be anytime from 300 to 400. So it has to be higher because the oxygenation PO2 keeps on falling as the gradient increases, the distance it goes. So your post oxygenator will be 3 to 400. Your pre-oxygenator will be 40 to 50. Okay, so it is your pre and the post. So most of the times we used to measure before the newer oxygenators, older oxygenators we used to measure it frequently. Okay, newer oxygenator nowadays in neonates and pediatrics we don't even monitor P2, P3. Okay, because the oxygenators are so good. Neonates anyhow in 5 to 7 days come off ECMO, pediatric by 7 to 10 days. This oxygenator now lasts for 3 weeks minimum. So after 2 weeks, 3 weeks, we measure P2, P3, they're also in adults. Or we think there's a clot happening. Okay, so that is the only time we measure P2, P3 and we do the oxygenator. Okay, so this is the one of the important thing about the oxygenator. You can have sometimes a thrombus or a clot in your oxygenator. Then your oxygenator is failing. So if your oxygenator is failing, then you need to only change your oxygenator. Don't change the whole tubing because patient's blood is already used to this new circuit. Usually we just change the oxygenator and somebody, a good perfusionist like Prajakta and her colleague, 2 perfusionists to change the oxygenator will change the oxygenator in 10 to 15 minutes. That time you need to support the child. Okay. Similarly, when the pump is not working, you're going that, you need to make sure you fully ventilate the patient. Okay. You fully ventilate. So one ECMO consultant will take care of the ECMO and the ICU consultant will take care of the ICU. ECMO consultant will straight away say pump failure. The whole is like your crash code blue. Okay, the ECMO consultants, everybody will come and start doing with the ECMO. ECMO perfusionists will come and do with the ECMO and ICU team will look at the child. We'll say you start ventilating and give inotropes to the child while we swap the pump.
Yeah. So if pump is not working now and I want to clamp one of the lines so that not air or any clot is there, that should not go to the patient. So which line I can clamp first?
Which line, artery or the drain? Return arterial, very good. So always you want to clamp the artery first, drainage second. Okay, then we swap start getting used to pumping and bringing. So you know you have to get it to the green. The beginning is easy. Once this comes, it becomes difficult. You need to keep on doing it. It's like your hand bagging. Till this is on green. Is it on green? You don't look at it. Ask somebody to keep on looking. If it's red, you have to keep on saying red. What is it? Okay, usually when you're doing this, you have to sit on the floor and do it so it happens easily. When you're sitting doing like this will hurt you. You can't get your full excess going. And this is the time while they are sorting out what was the wrong with the pump. Why did the main pump fail? Was there any electrical problem? They'll change the electrical problem. Was there any pump issue? They'll change the pump issue. If there's needed, then we'll get the second machine. Okay, once it's done, this we can do it easily for 1 hour. After 1 hour and every 15 minutes you have to change the person doing hand crank. It's like bagging. You can't bag for more than 15 minutes. Okay, same way you can do the artificial cracking and then you swap it over to the new pump. Now once the patient goes back on the back to the same pump fixed or next pump fixed, now what are you going to remove first? Venous line.
Yes.
Because you want the blood to come back first to the pump. Make sure you get the flow back to 100 ml per kg per minute. Once the flow is coming, then when she says yes, you open the arterial side, the return side. So you can have 3 issues: pump failure, oxygenator failure. Second is, as I said, this is a preload dependent. Preload dependent means the child needs the ventilator, the ECMO circuit needs fluid. Okay, if the fluid is not enough, this will start shuttering, will start shaking. Okay, that means you need to give fluid. So you straight need to give fluid. Second thing is if the intrathoracic pressure rises. Intrathoracic pressure rises with your cardiac tamponade or your pneumothorax or pericardial effusion. Straight away do your lung ultrasound, pneumothorax, put a chest drain. Okay. Cardiac tamponade, see what has happened with your cannula. Okay, straight call for code blue. ECMO code blue always has the cardiac surgeon to come by. Okay, 3 to 4 times I've seen cardiac tamponade bleeding because the cannula had made a hole in the right atrium. Okay, so you need to stitch it. Child survives and goes home. Okay, they come, they stitch the hole, put back, and the child is fine. Okay, but things can go wrong. You need to be aware of it. Okay, so now we put the child on ECMO. Yeah, so we put the child on ECMO. How do you decide how to wean ECMO? Weaning of ECMO is just like weaning of ventilator. How do you decide your child is ready for weaning ventilation?
Spontaneous breaths.
Spontaneous breaths are better, lung function is improved. How do you know lung function is improved? Before that, minimal pressures, child is having good compliance. Okay, when you put the patient on ECMO, as we said, we put them on rest settings. What is rest settings? We do not ventilate the child. We keep the child lungs open. We keep on PEEP of 8 to 10. We keep a delta P of 8 to 10. We keep a rate of 8 to 10. We keep an I time of 0.8 to 1. Why we keep a little longer? We want to keep the lung fully distended and aerated. It's like when you have a sprain your ankle. Okay, do you keep your foot down or do you keep your foot elevated? Elevated to heal better, to drain fluid. When lung is wet, infected, anything, you keep the lung atelectic and collapse, or do you want to keep lung expanded? That's why we keep it expanded. We PEEP of 8 to 10, I time of 0.8 to 1 with a slow rate of 8 to 10. We keep FI to 30. We are not ventilating, we are giving rest to the lungs, but we are keeping it expanded. Usually on the rest settings, in the severe cases, your compliance will be poor. Your tidal volume will be 1 to 2 ml per kg. As the child improves, on your rest settings, the compliance will improve. The child's chest X-ray, which was white out, will start getting aerated. Child on ECMO usually is sedated on fentanyl and dexmedetomidine. Okay, we give them sedation holiday every day. You'll see when they are ready to come off, you don't need to put the child back on fentanyl. Child is doing very well on the ECMO itself. Child is awake and spontaneous. That's the time. Once you see the tidal volume coming up to 3 to 4 ml per kg on your rest settings, child is very active, is getting active, is comfortable on ECMO. You know now is the time to come off. Every day when you are on ECMO, it's like every day when you're on ventilator, you want to wean the ventilator. Every day on ECMO, you're thinking of weaning the ECMO. That should be your aim every day in the morning to do that. Is my child ready to come off? Okay, because that's why I said you don't know when is the 3 to 5 days. Some come off on 2 days also, some 6 days also. So you need to wean, see, think every day. So we look at the lung compliance and the lung function. We also have to look at the heart function. Okay, heart function, how do we look at? Excellent 2D echo. 2D echo to look at the ejection fraction, look at the VTI. Okay, at the same time the blood gases, look at, make sure there's no metabolic acidosis, there's not lactate is normal. Okay, so child is not on any inotropes. Most of the newborns should not be on inotropes when we are weaning off. Okay, unless it's a VA ECMO, post-cardiac ECMO, post-transplant, little bit of inotrope is okay. Most of the respiratory ECMOs don't need any inotropes while coming off. Okay, if the child on sepsis has gone on 3 inotropes, has gone on ECMO, within 4 to 6 hours your inotrope requirement will be half within 12 hours you should be coming off inotropes. Within 24 hours your inotrope should be 0. Okay? If your inotrope is not decreasing, then you should see why my VA ECMO is not being optimal, because I want to rest the heart. Okay, rest the heart. Now how will heart rest? 80% of the blood is drained from the SVC and is going to descending. Heart will only function with 20 ml of the blood, which from the right atrium will go into the pulmonary circulation, come back to the left side and will eject. So the heart is also rested when you go on VA ECMO. Heart will eject most of the time, okay, and that you need to make sure it's enough ejection is going on and it's rested. When you see that the heart function will be better, on your arterial line you will see the pulse wave looking better. Your arterial blood pressure itself will start improving on the arterial trace. Okay, so we looked at the lung, we looked at the heart. Third thing is, we want to make sure the child is awake and appropriate. You do daily, routine, regular brain ultrasound, always you do. While going on ECMO, you do one pre-ECMO, one immediate post-ECMO, 1 4 to 6 hours after ECMO to make sure with heparin you not had any IVH. Okay. Now, another important point is fluid balance. Most of the newborns are 10% fluid positive. First week you're supposed to lose 10% of your body weight. Okay, on ECMO in first 5 to 7 days, your total ICU fluid balance should be at least negative 3 to 5%. Okay, you want your organs, your lung to be dry. Okay, so you do strict intake output monitoring, including weighing your nappy for stool and everything. So you see how much fluid is going on and how much the child is losing. Okay, you do daily and you do cumulative percentage of fluid balance. So cumulative fluid balance in the ICU should be, when you are weaning off, should be negative, minus 3 to 5% is good. Sometimes we allow 1 to 3%. Last but not the least is end organs. Your lactate VCR is normal, your kidney function is normal, your liver function is normal, your clotting factors are normal. So you go from head to toe, make sure everything is normal when you are weaning. Once you think the lungs are ready to wean, the advantage of VV over VA is, in VV you just have to remove the oxygen. Oxygen tubing, the green tubing which is attached to the wall, just disconnect. So the oxygenator is not giving oxygen, will not blow CO2. So whatever gaseous exchange of oxygen and CO2 will happen in the lungs. Once we put on the ventilator, you put your ventilator settings, decrease your PEEP to 6 or 7, keep your delta P of 12 or 14, so 22 on 6, increase your rate to 30 or 40, I time to 0.4 or 0.6, FI2 to 40 or 50. And then you monitor the gases. Initially do 1 hourly gases to make sure whether you have titrated the ventilation. Okay, once the patient's blood gases are maintained, you decide. If you feel very confident that the gases are maintained for 4 to 6 hours, I want to decannulate, I can remove the cannulas. Often in babies we wait for 24 hours. We let the pump run, we let some small dose of heparin run, and we continue. We don't connect the oxygen to CO2. Make sure over the next 24 hours the child is maintained. Why? Sometimes while coming off you have a honeymoon period. Everything looks good. After 4 to 6 hours, after 4 to 6 months, after 4 to 6 years, शादी के बाद झगड़ा चालू होता है. बच्चा अपना ट्रू रंग निकालती है. Husband और wife अपने ट्रू कलर दिखाते हैं. Child will after 6 o'clock, at 12 o'clock at midnight or 3 o'clock in the morning will show the true color what he can do or she can do. Okay, if they want to fight, he'll fight at that time, or he will be fine. He'll be fine, he'll come off next time. Once the child is fine at 6 o'clock, 7 o'clock, you have to tell them to switch off the heparin. Switch off the heparin because you're going to decannulate. Venous ECMO is easy to decannulate. 4 hours of heparin, ACT, clotting factors are normal. You remove the cannulas and compress. Pressure has to be for 15 minutes in spite of your normal clotting factors. Idea is not to see. Every time you lift, 15 minutes get added. So my nurses knows कि 7 मिनट में खोला 15 मिनट हो गया है 25 मिनट दबा के बैठना है. वो खोलेंगे ही नहीं. Because they know we are sitting there 15 minutes until we say she will not lift it up. So 15 to 18, 20 minutes where you lift up, no bleeding, then you do dressing. Do not do compression dressing while bleeding like you do in angiography patients. Okay? Arterial needs repairing of the artery. The surgeons will mostly either take back to theatre, or our surgeons are very comfortable, they'll do arterial repair bedsides. And they'll do the arterial repair and decannulate doing VA ECMO. VA ECMO, weaning is a little bit complicated. It's for advanced course. So this is how you will wean. Okay. One of the other most important thing we spoke about is sepsis. So in ECMO, you have to be very careful. Like all ICU patients and newborns, infection is our biggest enemy. So we have to strictly make sure that we are wearing our cap, mask, gown and chappals when we enter the ICU. We wash our hands, we do it. The problem is who takes care of the X-ray machine coming or the things rolling in and out of the ICU. You need to be careful because when the X-ray machine goes, wheelchair comes, medicine trolley comes, वो ऐसे ही जाता है. The wheels, उसके साथ क्लैप्सुला आता है, सोडोमोनास आता है, MRS बोलता है, मैं भी हाई बोल के आता हूँ ICU के अंदर. So all that comes. So we keep a chloroxidine wipes on the floor, and the trolleys have to go on it 3-4 times. The whole wipes are washed, trolley, and the trolley is properly cleaned before it enters the ECMO unit. Any trolleys, any trains, all are properly wiped before it enters the ECMO unit. X-ray plate is going next to the child. Okay? X-ray plates have to go in a sterile cloth, in a sterile pillowcase, which is then it comes in contact with the patient. We need to take care of everything. Our nurses, bedside nurses and our perfusionists have full right to tell anyone, please wash your hands again, we are not sure. You can't argue. Go, do your 5 minutes wash and you come back. Strictly. They can even tell me. I can't say that I've washed it. No sir, I'm in doubt, can you wash it again? No discussion. Go, clean it and come back. Give the power to your bedside nurses and perfusionists, then things go right. Anything you do to the patient has to be done by 2 people, doctor and nurse or 2 nurses. Drugs have to be kept and attached by the 2 nurses to make sure air does not go in. Okay? Doing suctioning, very important. Okay, why we want suctioning to be done by 2 people is secretions on ECMO patients are very thick and copious. Okay? So they have very thick secretions. What is the habit of the nurses? Thick secretions रखे लोगे तो क्या करेंगे? NS डाल देंगे और नहीं तो suction pressure बढ़ा देंगे. Suction pressure 200-300 किया, ECMO पे heparin पे, you have a mucosal tear of your esophagus or your nasal, that bleeding will not stop. Okay, you have to really take a lot of pressure to stop your nasal pack. Nasal is fine, you can nasal pack it. Esophageal bleed is very difficult to pack. Okay, we lose patients because of esophageal bleed. More than IVH, which is 5% bleed, esophageal tear is 15%. Okay, so that's why you need to have 2 people to make sure nobody makes a mistake of increasing the pressure. Second thing is in NICU nowadays with hepatitis B IM vaccine, वैक्सीन वाली नर्स आती है सबको खट IM देके जाती है. बॉस ECMO साइड पे आने का ही नहीं. IM दिया मस्त हेमाटोमा गिफ्ट में लेके जाएगी. Okay, no IM, no testo subcutaneous. Okay, you can't do all that on ECMO patients. You need to take care of all of this. Second, if the patient is on ECMO, do not ever forget your glucose. Make your glucose is monitored and start minimal enteral nutrition within 6 hours. Okay, within 6 hours we start minimal enteral nutrition, and within 24 to 48 hours everybody is on full feeds. Because as I said, within 24 hours your lactate is down, your inotropes are off. So they should be on full feeds by that time. So you need to make sure that you do not forget your NICU basic stuff just because patient is on ECMO. If not, we can start TPN. We start TPN on the central line. We do not put anything on the ECMO pump. Now, rarely after your cardiac shock or your ECPR. What is ECPR? ECMO while you're doing cardiopulmonary resuscitation. So when the CPR is going on, in hospital cardiac arrest, when you are doing your CPR, within 15 minutes or 10 minutes you're not getting a return of circulation, you can call for ECPR. So in our unit, if you go on ECPR, as soon as ECPR goes, straight away the surgeon, somebody will put betadine on your hand. Suddenly the surgeon will come and say move, you move, surgeon with the sterile gloves will start clamping. Another surgeon will come, will again do betadine, will wipe the area. Straight away he'll say he'll move, goes, he'll put a good midline incision. Another surgeon who was free will take a retractor, will retract. First surgeon will start internal cardiac massage. Okay, 3 minutes your internal cardiac massage, another next 10 minutes they'll cannulate the aorta in the right atrium. And you go on ECMO. Usually within 15 minutes in our hospital you can go on ECPR. So you go on ECMO while you're doing cardiopulmonary resuscitation where you have a witnessed cardiac arrest. कि अभी तक अच्छा था, suddenly they died. Okay? So if you go within 15 to 20 minutes on ECMO, they have a very good prognosis. They come out. The ECPR is one of the rare indications of ECMO for centers which do ECMO regularly. Especially in our cardiac ICU, we do that. We'll have at least in a year 2 or 3 patients going on ECPR. And it's a routine procedure which happens, and we have a dry run. In fact, with the high-risk patients, we discuss and we keep the cannulas next to the patient. Okay, this patient is not looking good, might need ECPR, these are the cannulas. And nowadays we preempt it. As soon as we think of going on ECPR, we say let's put it on ECMO. And we electively go on ECMO with our post-op cardiac patients. Okay? So this is a routine thing happens in neonatal ICU or neonatal cardiac ICU where ECMO works. But ECPR, cardiac ECMO, 30-40% survival rate. And respiratory ECMO, how much survival rate? 70 to 80. Meconium 95. So respiratory ECMO is the best indication for ECMO. Okay. Bolo. Any other questions? Okay. How did you find? Overwhelming? This all is routinely done. The idea is to get you all acquainted to all this. We are doing for this all for last 10 years. But ECMO is for neonates, and we don't get neonates referred because people don't know it's happening. We adults and pediatrics refer, but neonates don't refer. So don't worry, it happens. It's routine and it's done. There are more cardiac neonatal ECMOs than cardiac neonatal respiratory ECMOs. Ratio of cardiac to respiratory should be 1:3, 1:4. In India, it's vice versa. Chalo. Thank you. I forgot. That is an adult circuit, this is a pediatric circuit. Huh? See, the size is so small.
सेशन आप दोनों करना है
सर क्यों चलेगा सर
दोनों को दे
अरे नहीं चलेगा सर बनेगा अरे करो यार बहुत बोल दिया
मैं रीड कर आप बोलते हो
नहीं करो करो यार आपको कम्युनिकेशन आ गया मैं जो घूम गया सबको चलेगा
यही करना
दिख रहा है तो यार
मैं आप दोनों बात करने वाले हो ना
नहीं करना
मिलेगा सर उसके बाद ही मिलेगा जल्दी start. So we discuss everybody. It will be a very short case, more of a discussion. So first, we'll discuss only one case only, lack of time is there. So we go for 29 meters, G4, P0, A3, L0, R is positive mother, normal antenatal scan, normal antenatal period, PPRM of 10 days. You can see one course of antenatal steroid, last one 8 days ago. So the gynec has called me. What we will do? Delivery, yeah. So this is a high risk case. GPRM is there and this is only 8 Yeah. So first of all we make a team. At least 2 people should be there. And whenever we go for delivery, we go for any delivery. Normally I say we're giving the 3 ABCs, the preparation, the temperature, airway, breathing, circulation. So for temperature, warmer should be on, we should have the wraps should be there, it should be warm. For airway, ET tube and everything. There are 4 or 5 important things. What all we should do for a preterm delivery? No, for the preparation. In the preparation I'm telling. Warm-up we have already done, sir, for the term also. Everything is for term. It's same for the term and preterm both. So for preterm, at least we should have a plastic wrap because we are having a preterm very high risk baby. First thing that we should try to have a TP resuscitator or a delivery room CPAP because baby might require for that. At least for these type of babies, drugs like it should be kept ready at first only, like adrenaline and the normal saline should be there. And oxygen, everything you will be keeping for that. But at least in a preterm delivery, we should keep it at least ready. Very important. Anything about the steroids, antenatal steroids? Do you know what are the types of steroids normally mothers receive? Betamethasone. What is better? Dexa is better. And what is the dose of Dexa like? 6 mg BD. At least we should go 4 doses. The total doses should be around 24 mg. We can give betamethasone also, but according to both are okay. But according to the Government of India guidelines, dexamethasone is preferred in their guidelines. So for medical legal purpose also, I think dexamethasone will be a better option. Apart from steroid, what all antenatal drugs we can give to the mother? Maxil, sir. So what is the dose of Maxil? Like what is the protocol for giving Maxil? How much do we give and how do we give? So what we will do is, normally we give 4 gram loading dose over 30 minutes. Then it will be 1 gram per hour normally we give. And total dose we should give around 24 grams. But that should not be a criteria for aborting for stopping the delivery. If mother is in imminent threat labor there, we can stop Maxil and we should deliver. Okay? And if the mother doesn't deliver after 24 hours, we have given, so we can stop the Maxil, and once if she comes back, once again we can start. Use of Maxil is for neuroprotection only. Okay? So this we have discussed about the antenatal preparation, and in fact I'll tell you this is a very steroids, Maxil are very low cost ways of preventing RDS in babies. So baby delivered, normal vaginal delivery, weak cry at birth, requires some few pups. Apgar is 5 and 7 at 1 and 5 minutes. So what is this? Is it perinatal asphyxia or perinatal depression? EBG also, I forgot to tell you about the cord blood gas. Cord blood gas, pH is 7.3, PCO2 is 52, PO2 is 39, bicarb -5 and bicarb, basics is -5, bicarb is 25.3. So what impression do you get from this? So first of all, we should know whether this is perinatal asphyxia or perinatal depression. Depression. Why? Because initial the Apgar which was 5, which has got better. Can we interpret this gas? So how do we interpret any ABG? First of all, 3 things we should always look at. First thing is the pH. After looking at the pH, we should decide whether it's an acidotic or an alkalotic pH. What is the normal pH normally? 3.545. PCO2 is 5, and bicarb 20, 24, or we take an average of around 18 to 24 is also okay for us. But in a cord gas, always remember we look only 2 factors, the pH and the bicarb. So PCO2 is not very important for us. And in a cord gas, if the pH is more than 7.1 or 7.2, that is okay for us. In cord gas, I'm not about the normal gas. So whenever we look at the cord gas, we always look only 2 things, the pH and the bicarb, because we need to see whether the baby has any perinatal asphyxia or not, and then metabolic acidosis or not. Okay? Understood? So baby now has developed tachypnea and retraction. So what you will do? Baby has developed tachypnea and retraction. Okay. Okay. Should we start delivery room CPAP? Delivery room CPAP, because I think since we know it's a 29-weeker and chances of that baby might require surfactant also, we want to open up the lungs first of all. So it's always better to start delivery room CPAP. So what is how much % oxygen do we give that time? If we use a Neopuff, if we don't have a blender, how much % we are giving? How much % oxygen we are giving? So in a resuscitator, what all we can control? The PEEP, the PIP. But if we are using so now so many good, in fact, what I have warmer mounted resuscitator there, in which we can control the FiO2 also. So here I'm more stressing upon the FiO2. Whenever we started with Neopuff, we are giving 100% FiO2. So the real FiO2 requirement will not be able to come when we start a delivery room CPAP. So it's always better whenever we are starting a CPAP or when we are starting a TPA, keep a blender of oxygen with that. So hence we get a thing that how much target saturation we are achieving with the FiO2. Okay. So preterm deliveries, how much how much FiO2 do we give when we start a resuscitation? So more than 35%, we start on room air. Less than 35 weekers, we start with 30% FiO2. So according to the 8th edition of NRP. So now this baby is in the NICU. RR is around 65 per minute. Audible grunting, upper chest seesaw movement, lower chest retraction, sternal retraction, flaring of Elanism. So what is the impression on seeing this?
Child requires severe.
No, looking at all these factors, is there any scoring system? SA score, Silverman-Anderson scoring system. What is Downey score? Term baby. So what is the difference between SA score and Downey score? So Downey score contains more of a cyanosis, the oxygen requirement, while the SA score, basically Silverman-Anderson scoring system, is for preterm babies. So do you know the component of SA score? Low chest retraction, xiphoid, grunting, and nasal flaring. So if we calculate this scoring, how much is the score? So it's 0, 1, 2. If I calculate this score, it might be around 8 or 9. So if you see the scoring system, any scoring system more than 7, the chances are there that the baby might require intubation. But only going on this scoring system, we can't really directly intubate the baby. We should give some time. So coming down, we have started on CPAP. PEEP of 5, FiO2 of 30%, flow of 5 liters per minute. And retraction and everything still percent. But whenever we start CPAP, what all we look when we start a CPAP? In your center, what type of CPAP do you start? Bubble CPAP or the ventilator CPAP? Bubble CPAP. We all use Fisher and Paykel. So what all we see in that? Whenever we start a CPAP, what all we see?
If there is any leakage.
Leakage is there, the bubbling is coming up. If the bubbling is less, we always look out for the leak. Second thing, if the bubbling is less, then what we do is we increase the flow also. So what is CPAP failure? At what PEEP we go? If we say that this CPAP is not working, probably we might need to intubate the baby. Understood the question? So if the PEEP is more than 7, this retraction, this grunting, this everything is same only, then probably we need to intubate the baby, because FI2 requirement is increasing, your baby is not getting better. And what we see when we start CPAP, how do the chest movement and everything. So we have persistent distress and retraction, high FI2, we have intubated the baby. Okay? So whenever we intubate, what all things we see when we intubate? After intubation, if I'm asking. Air entry. No. So before you are putting a sticking, we always check for the air entry, because once you stick and after that you can't do that. So it's always better to check for air entry, the chest rise. What we say is everything is equal or not. So after that, we just go for that. So this is the X-ray of the baby. Can you describe what was there? So normally whenever we read a chest X-ray, how do we go for it?
We have to first describe the view of the...
Yes, very good.
It is a AP view of the
Yes, okay.
X-ray showing the...
Is it rotated or non-rotated? How do you feel it's rotated? What about the clavicles? You are telling something. Well centralized, in fact. So, as you said, centralized. So, can you tell, whenever you describe a chest X-ray, what all thing we see and what all we say?
View, centralization,
Yeah.
Exposure, inspection of exposure.
Is it well exposed? It's quite well exposed. If you see the stomach and the chest, both are looking equal. Then so RDS X-ray, na? So what all we look into the RDS X-ray? You understood my question? Like, what is this X-ray? Just say a few words about this X-ray.
Granular opacity.
Yes, very good. Yeah. Can you get a grading of the RDS from this? Is it white out? No. So it's not grade 4 at least. It must be between grade 2 to grade 3. Okay. Apart from this, what all you can see in the X-ray? ET tube and can you see the lines also? Can you see the lines also? There's the ET and the lines also there. Okay? So whenever you describe by X-ray, you should go from, in fact what I say is from bone, then the cardiac thing. So that this is how we never forget about the description of the X-ray. Okay? So we did a gas. pH is 7.21, PC2 is 48, PO2 is 63, bicarb is 14, base axis is minus 11. Can you interpret this gas? Like, what is the pH? Is it acidotic or normal pH or alkalotic? acidotic. What about the PCO2? Normal, high, low? Yeah, little bit high. What the bicarb? Decrease 14. Base X is minus. So this is more of a metabolic acidosis. Should we give bicarb in this condition? Should we give bicarb? So what are the criteria of giving a bicarb? 7.2. Okay. And so what is the side of adverse effect of giving bicarb? Risk and chances of IVH will be more, because the PCO2 will be very high. First thing is that. Why we have kept this gas is that this is metabolic acidosis. Instead of giving bicarb, you should look for the cause, that why this baby is suddenly having metabolic acidosis. So we should always check the vitals, the pulse and everything, the BPs. If there is any of that, then we can just treat that condition. And if you start treating the underlying respiratory condition also, because if you see the PCO2 is little bit on a higher side. So if we start treating the respiratory condition also, these things will get better. Can you see the setting here? PIP 18, P5, I time 0.35, rate 40, mode is SIMV, and FI2 is 60%. So 60% FI2, and how is the PO2? 63. So this denotes this is hypoxia is present. So see, all of us know ABG, but what this station is basically we discussing about is that how you should approach a gas. Sometimes we say, and in the gas, what all we look after, whether it's compensatory or uncompensatory. What is the pH? pH is 7.21. So it goes more in favor of uncompensatory one. So we have given surfactant. You guys know types of surfactant. In your institute, what type of surfactant do you give? Serventa, Neosurf. Neosurf. Ma'am, आप क्या? Sir? क्यों sir?
I'm dependent on whatever is available.
Available. But most commonly क्या देते sir आप? Neosurf. Neosurf. Okay. हम लोग Serventa. But what is better? Neosurf.
Graduation days we've used both.
Both.
इसमें Neosurf में थोड़ा hemorrhagic changes आए थे एक बार.
So basically we all three sir. So basically what the implication that we all prefer to use a animal based. We don't use a synthetic based surfactant. All three have equal efficacy for that. It's all choice. It's all about cost and how much ever, because Serventa is 4 ml and that is 4 ml per kg. This is 2 ml per kg. So anything is okay with us. So now this table, now baby is 6 hours old, no tachypnea, minimal intercostal retraction, minimal chest rise, saturation 88 to 90%, settings wise SIMV is 18/5, rate 40, 60% FI2, 0.35 at time, ABG is 7.36, 48 PCO2, 32 PO2, bicarb 18, -4. At 12 hours, still no tachypnea, no intercostal retraction, chest rise prominent, saturation is 95 to 97%, SIMV rate 16/5, same setting, but the FI2 now come down to, you say, 21% we have come down. And this is also fine, but at 18 hours, same, there is no there is no further improvement, like FI2 is still 21%, but there is sudden desaturation. So how do we go for this? We have received a call. So before going to dope, we should always see whether really the pulse ox is working or not, because sometimes we are in a panic situation. We are looking at all these things, but we never see that where the sister has placed the pulse ox also. So that is very important for us. And definitely dope is again good. What is dope? and
pneumothorax equipment.
Yeah. So we have to go by step only. Whenever we get a call for this, that this has happened, we should always check. What we do is we should disconnect from the ventilator. We should give bag and tube. We should check the air entry and everything, whether the air entry is equal or not. So what we do is disconnect. This is a flow chart. Disconnect from ventilator, start bagging. Look for adequate chest movement. So there is adequate chest movement. Whether we look for normal breath sound and oscillation. If there is poor saturation or improving saturation after breathing. If there is no chest movement, no poor breath sound, poor saturation. So we look for no air entry, unequal sound, breath sound over stomach and wheeze. If there is no air entry, then it is blocked tube. Unequal sound should be pneumothorax. Breath sound over stomach will be tube displace and wheeze will be bronchospasm. शायद से हाँ. I don't know कैसे इसका. ये वाला? नहीं. It's just a table, like how we should go for that. So we should take appropriate action depending upon the pathology. So no bagging, on bagging, no movement, change the tube, got better. But post reintubation also, FiO2 is around 40 to 50%. Now what we should think more? We have done no pneumothorax, nothing is there. Huh? Congenital? Congenital, उससे ज़्यादा in preterm babies, heart, channel open, like PD I am talking about. So we should see this also in that. So the place from that I did my fellowship, we used to screen all the babies after 24 hours. And if the size will be more than 2 pounds according to the weight, we used to start paracetamol for all the babies. I don't know whether it's correct, whether it's wrong, but it's a unit protocol we always follow. What about your institute? You screen for all the babies? We do. Do we do? No, we don't do. Okay. So echo is showing hemodynamic significant PDA. Okay, and we started paracetamol and everything for that. Apart from this, in these 4 days, on day 4, this baby's 4 days, what all we are missing, what we have not done. We have done everything for this baby. What we have not done. Probably questions समझ में नहीं आ रहा है. So we have done everything. We have given surfactant. We have started ventilator support. We have screened the echo also. We have done the sepsis screening. Babies on antibiotic. Babies on IV fluid. What not we have done for this baby? Feeding now you told. So we have not started feeding till now. So we have not taken the care of nutrition part. So if the baby is hemodynamically stable, except the full feed, we can at least start some trophic feed for the baby so that there will be no complication for that. I think we'll finish here only. Any doubts, sir? I think this was the most boring station. This is more of a practical base. Then we are more discussing about ECMOs and so many things are there, new things are there. So basic rule, 3 things we should always look after this. First is the pH, whether the metabolic acidosis or alkalotic, whether it's metabolic or whether it's respiratory, any alkalotic or something. And third thing, whether it's compensation or not. What we look after the Winter's formula, हम बोलते हैं. If the PCO2, but that is more for a metabolic acidosis. If the PCO2 is rising more than that from a equal, like from a target, then we say it's a compensatory one. We get some charts also online, like so 2 or 3 charts. If it's there, I'll share on the group. That'll be better. Apart from explaining for that. Okay. You're from which institute, sir?
GMC Neeraj.
Neeraj, sir. आप मैडम? सर आप कहाँ से? अमरावती से.
TY Patil Pimpri.
Pimpri. Okay. Okay, my God. सर अमरावती. चलेगा. तो I think let's disperse off. Okay, how was the station? ऊपर भी सब graphics and everything, and high frequency must be good. I think so. Very well, fair. And ECMO was new or something like new thing. So ECMO actually is new for all of us. We don't normally practice, so we don't know. Chalega. Take care. Thank you. Thank you. I think अभी होगा सर, मुझे लग रहा है. उसके बाद सर्टिफिकेट मैं एक बार देख लेता हूँ कैसे क्या है.
Thank you.
अरे सर जी सर पहले भेजो.
अरे कोई मैं मान रहा हूँ सर.
अरे सर
अरे भाई ऐसा नहीं होता. चलो चलो
Slightly come this side. Perfect. Wait.
सीट भी नहीं है.
अना माइक पे बोल दो ना सर.
माइक तो छोड़ो यार. रिकॉर्ड हो रहा है इसीलिए.
सर आप थोड़ा सा पीछे हो ना. बस परफेक्ट परफेक्ट. Thank you.
Thank you, sir.
श्रीकांत बाबू इतना काम किया सब लोग ने.
शिकाने बहुत टेंशन था सर. एक्सरे चिपकाओ, ब्लड टेस्ट चिपकाओ, सर को बोला मैं हो जाएगा तू फिक्र मत कर. सर एक्सरे देख लो ना.
Wait, one more.
है ना शिकाने सर. गुड.
Thank you. और थोड़ा Perfect. Wait, one more. Thank you. एक सबका ग्रुप
कितना सिंसियरली किया सब कुछ
उतार दो ना ऊपर का कवर. Yes.
Thank you.
We'll have one group picture of all of you. Please come.
एक जरा हाथ से दबा दो. Best moment of the day. Yes. We did it.
थोड़ा सा और इधर शिफ्ट करना स्लाइटली. परफेक्ट.
भैया बहुत एंगल करते हो.
सर पीछे अभी परफेक्ट अभी फ्रेम तो लूं.
Enjoy.
Yes, smile all of you. Thank you.
इसकी लिंक मिलने वाली थी इस फोटोज की. प्लीज.
अपने ग्रुप में सब फोटो डाल दो.
Thank you. Delegates का फर्स्ट पूछते रहे उसको थोड़ा वो है. Delegates